So throughout the 2 days of the summit, we have had an opportunity to look at a number of topics, such as integrating mental health and spirituality, addressing the psychosocial needs of mental health professionals, community outreach in faith-based settings, which will be presented in the course of the day, and the impact of digital health technologies on holistic healthcare from our colleagues in Boston. And we shall have a recap and a way forward. The breadth and depth of discussions for yesterday have been inspiring, and we are confident that the knowledge shared and connections made will have a lasting impact on mental health practices in East Africa and beyond. So we would like to express our sincere appreciation to our distinguished presenters yesterday and the session chairs for their invaluable contributions and expertise. So your insights and guidance have been instrumental in shaping the dialogue and fostering meaningful exchanges among participants. Special thanks to our keynote speakers, Professor Peter Baguma, and the participants for yesterday for their thought-provoking addresses and unwavering commitment to advancing mental health research and practice. Your leadership and vision have been truly inspiring. In addition, we would like to thank the organizing committee for their selfless dedication in making the conference a booming success. So I would like to give special thanks to the Reverend Dr. Mary Kinoti, Acting Vice Chancellor, who has been keenly following Professor Bantu, who is the chair, Reverend Douglas Nchebere, Dr. John Muchiri, who was the master of ceremonies and made the sessions more attractive, Dr. Rebecca Washira, Reverend Dr. Kibara Tasira, Reverend Dr. Peter Mwiti, Reverend James Karanja, Reverend Dr. Justus Patrick Karani, Reverend Dr. Alice Mudhoni Mwila, Dr. Esther Gaki Mbabu, Dr. Gaki Malete, Ms. Jane Jenu, Mr. Daniel Mwimi, Mr. Corinne Mutuma, Ms. Beatrice Shisha, Ms. Judith Kabwi, Mr. Victor Samburi, Ms. Catherine Jiru, and our IT persons. We really have to thumbs up. We would also like to extend our gratitude to the other members of the committee, volunteers and support staff for their dedication and hard work in ensuring the smooth execution of this summit, both in person and virtually. Your efforts have not gone unnoticed, and we are immensely grateful for your contributions. As we reflect on the key learnings and insights gained from the summit, let us remain committed to driving positive change in mental health care and promoting holistic well-being for all individuals. So together we can continue to break down barriers, foster collaboration, and create a more inclusive and compassionate society. Once again, thank you for your participation and unwavering commitment to mental health advocacy. We look forward to continuing this journey together and building a brighter future for mental health care in East Africa. And at this time, before we begin our meeting, I'm going to request Reverend Karanja to open this session with a word of prayer.
Thank you, Prof. Before we pray, allow me to read one verse taken from the book of Acts, chapter number 13, verse 36. Acts chapter number 13, verse 36. It says, "Now when David had served God's purpose in his own generation, he fell asleep, he was buried with his ancestors, and his body decayed. Now when David had served God's purpose in his own generation, he fell asleep, he was buried with his ancestors, and his body decayed." So we know David was a man after God's heart, and he did a lot during his time. He wrote, he used his talents and gifts even to write, to sing. He was a military expert, and that was his time. Now this is our time to influence and to impact on the society, because God has placed us at such a time as this to do his purposes. And I think one of the purposes here in an institution like this is to do research and to have it dispensed in the society to make a difference. So even as we begin this day, let's involve God, whose will is that we may serve him in our various capacities and fulfill the purpose for which he created us. So let us pray. Father mighty and ever-living God, wonderful Redeemer, we are most humbled for this far that you have carried us, and more so even for causing us to have a rest and to replenish the energy that we had lost. Now here we are, refreshed of you, to begin yet another day in our second day of this particular conference. May you take the center stage, the preeminent place in these particular sessions, and use those those whom you have prepared, Lord, even as they speak, that thy inspiration and thy Holy Spirit may direct them, O Lord, in what they are going to share today. And also as participants, O Heavenly King, we may bracket all else and really concentrate and appropriate and really get that which, Lord, you'd like us to be involved in, even as we partner, as we collaborate, and as we call upon you to give us that which it takes to fulfill the purpose for which this particular conference, this particular summit was created. And we thank you for the opportunity. We thank you for the privilege. We thank you even for the ones that are presenting. We thank you even for those that are coordinating us in whichever capacities. We pray for the participants in those that are participating online and even physical. May it be well with you, and may we remain thankful because of this opportunity. We bless you and we exhort you, for this is our prayer in Jesus' name. Amen.
Thank you very much for the word of devotion, and therefore I would like to mention that there were some questions yesterday that people were envisioning to ask, and especially the ones that concern art therapy. And this was presented by Laura, and she talked about the importance of creative expression in psychosocial support, and she indicated that creativity is and has always been essential for humans everywhere in the world. And of course, she talked about passionate about art, creativity, and equity in education and well-being. And she briefly talked about the current mental health crisis of young people, and with reference to climate change was COVID-19, and she provided the statistics that are happening in Uganda. She mentioned that 20% of adolescents experience mental disorders. That was according to the report by the World Health Organization, and indicated that in Uganda, 23% of children experience mental disorders. And in Finland, 30% of the girls at upper secondary schools experience anxiety. Also, loneliness is very common. And there remains a gap of lack of funding and availability of mental health services for youth everywhere. So her interest was to help us understand how we can come in to help. As you are aware, a number of people are suffering from undiagnosed mental health conditions, and they're only discovered when it is too late and they really could cause a problem. For example, she forcefully mentioned that about 103 million were forcefully displaced persons. And I think a number of people, asylum seekers who need psychosocial support, they are still missing, and normal reactions to abnormal life situations. So expressive arts can play an important role in psychological support system, and especially providing compassion by the community and optimism to reinforce young asylum seekers' mental health. And since art therapy is the best approach to use for people who have undergone traumatic experiences, and I therefore would wish to request Laura, who will be online, to make a presentation and answer some relevant questions. But before that, I'm going to request the Master of Ceremonies to read out the speech from the Vice Chancellor of Kabale University. Kabale University is a university that is intending to have collaborations and partnerships along with Maclean Hospital, Harvard University's teaching facility. And since Kabale University already has a mental wellness center in place, it would be very prudent that Methodist University can be able to have a leaf from the already existing facility. So I would like to request the Master of Ceremonies to read through the Vice Chancellor's report or remarks from Professor Joy Kwesiga.
Distinguished guests, ladies and gentlemen, welcome you again for the second day. Like the chair of the organizing team of this symposium and conference has indicated, we are glad that you're able to join us in the second day. And on behalf of the team that is leading, I want to welcome you again. Those who are online and those who are streaming through the various platforms, we are happy that you are able to join with us. Allow me now to take a moment to bring to us the message of the Vice Chancellor, Kabale University, Professor Joy Kwesiga, on this occasion. Distinguished guests, esteemed colleagues, and honored participants, it is with great pleasure and immense pride that I stand before you today as we convene for the Global East African Mental Health Hybrid Summit. On behalf of Kabale University, I extend a warm welcome to each and every one of you as we embark on this journey of exploration, collaboration, and transformation in the field of mental health care. The theme of this summit, integrating psychiatric and spiritual approaches for enhanced mental health and international dialogue, holds profound significance in our collective pursuit of holistic well-being. In recognizing the interconnectedness of psychological and spiritual dimensions, we aim to bridge the gap between traditional psychiatry treatments and spiritual healing practices, fostering a more comprehensive approach to mental health care. As we gather here today, we are confronted with a sobering reality. The global burden of mental illness continues to rise, impacting individuals, families, and communities worldwide. In East Africa, where resources are often scarce and stigma remains pervasive, the need for innovative and culturally sensitive approaches to mental health care is more pressing more than ever before. At Kabale University, we are deeply committed to addressing the psychosocial needs of mental health professionals, clergy, psychologists, psychiatrists, chaplains, and counselors. These dedicated individuals are on the front lines of mental health care, tirelessly serving their communities with compassion, empathy, and resilience. Yet, they too are vulnerable to burnout, compassion fatigue, and moral distress, often grappling with their own emotional and psychological challenges amidst the demands of their profession. Today, as we engage in meaningful dialogue and exchange of ideas, let us not only explore the latest research and best practices, but also create a space for introspection, self-care, and mutual support. Let us challenge ourselves to confront the systemic barriers and structural inequalities that hinder access to mental health care for marginalized populations. Let us cultivate a culture of empathy, understanding, and solidarity, where every voice is heard and every individual is valued. As we embark on this journey together, let us remember that the work we do here today has the power to transform lives, uplift communities, and pave the way for a more compassionate and inclusive society. Let us seize this opportunity to make a meaningful difference in the lives of those affected by mental illness, leaving a legacy of hope, healing, and resilience for generations to come. In closing, I would like to express my deepest gratitude to our esteemed speakers, organizers, volunteers, and participants for their unwavering commitment to advancing mental health care in East Africa and beyond. Together, let us embark on this noble endeavor with courage and compassion and determination, knowing that our collective efforts have the power to change the world. Thank you, and may God bless you.
Thank you very much, Dr. Muchiri, for these remarks from the Vice Chancellor of Kabale University. I would like to thank you for having time to send a message of remarks to this important summit. This summit is happening at the Kenya Methodist University, one of the best private universities in Kenya. And Kenya Methodist University has a number of programs. They have programs from certificate up to PhD in various disciplines. For example, the School of Business and Economics, the School of Medicine and Health Sciences, the School of Science and Technology, the School of Education and Social Sciences. And they have an institute, the Kenya Methodist University TVET Institute, which provides programs, national diploma programs in the various areas, and certificate and artisan programs. I want to take this pleasure to also welcome other universities that are partnering with us. We have universities from Nairobi in Kenya and other universities within East Africa and the Democratic Republic of Congo. I want success. In the West, we have universities like Maclean Hospital, Mental Hospital, Harvard University's teaching facility. Maclean Hospital is one of the best teaching and referral mental hospitals in the U.S. and is based in Boston. We also have our colleagues from Humak University in Finland, and yesterday we had a presenter from them, that is Laura, and she'll be joining us shortly to respond to some questions related to the resilience and coping of various categories of persons, the children, the adolescents, the elderly, through the experiences they go through. Participants, we want to encourage you to log in, because sometimes when you don't log in, then you'll not be able to access our communication. So I would like to welcome Laura. I believe Laura has been able to log in. And after Laura, we can have a presentation from Professor Karen Nyamwange, because Professor Karen Nyamwange was supposed to present yesterday, but due to some unavoidable circumstances, she was not able to present. This morning, we shall have presentations from Professor Kerry Ressler. Professor Kerry Ressler will be presenting to us an area called post-traumatic stress disorder, and later on we shall have a presentation from digital health, that is Professor Shefali, and we shall have also presentations from Professor Peter Baguma on PTSD. Yes, PTSD, that is post-traumatic stress disorder, and veterans. Then we shall have plenary sessions where people will be able to discuss important issues in mental health. And then Professor Kerry Ressler will be talking again about post-traumatic stress disorder experiences from the West, whereas Professor Peter Baguma will be talking the experiences in Africa. And then we shall have some presentations from Brenda Nawanga on community outreach in faith-based communities. And Professor Carroll will also be presenting on understanding aggression of men and female. And then we shall have reflections on key learning insights from the conference. Then we shall have closing remarks. So I want to welcome all of you to this session, and I would like to hand over to the Master of Ceremonies to conduct the session this morning. Dr. Muchiri.
Thank you very much, Professor Bantu, and we are glad that Kabarak University would be gracious to us as a Kenya Methodist University to allow a distinguished professor like you to be with us for the time that you're here. We acknowledge and appreciate that very great kindness from Kabarak University, and of course the Inter-University Council of East Africa for the fellowship that has allowed you to be here. Like indicated, members, we want to get going in the program. The morning session, we are now at the point. I see Karen, you are online. Karen, Professor Karen Nyamwange.
Yes, I am.
All set?
Not right away.
Not right away. Okay, fine. As you get yourself ready, there were a few people who wanted to ask a question or two, and we can ask those questions as we get Professor Karen to get ready, so that we can get going. Those who wanted to ask questions, those who are online, I can see we have over 40 members who are logged in. I want to ask you now, you may ask a question now, one or two questions, even as we get Karen to get set, and so that we can start off. Has Lola been able to join? Professor Lola from Humak, now at Kabare. Lola, have you been able to join? Lola? Not yet. She will probably be joining. Now I see Dr. Mwamisi, you would want to ask a question. Please go ahead. Just introduce yourself, ask a question, and we will get a response.
Thank you, Dr. Mchiri, for this opportunity to ask one or two questions. My name is Joseph Mwamisi, working in the School of Medicine, Department of Medical Laboratory Sciences. My question is kind of pointed to Reverend Dr. Kibara Tasira. When you are giving the presentation, I think I walked out, so I may have missed the answer to the question. And then Professor Bantu on addressing the psychosocial needs of mental health professionals. I am not very sure, so you will just pardon me for the question. And this one, even yesterday was bothering me. Then I said, I need to get some clarification. And it's because Dr. Tasira also mentioned somebody who put a carpet for her, and she was able to walk on that carpet. Now, mine is based on demons and mental health diseases or sicknesses, and that's why I'm saying, I hope it is not offensive. Demons and mental health diseases or sicknesses, because I wonder, do we confuse with what we are dealing with globally, or are we, in the right path? I have decided to give just 3 areas, totally based on the Word of God and Christ Jesus himself. And one area is casting out devils into the swine. If you can allow me, Dr. Mushiri, and there is time, I can read a few verses. Is that okay?
Keep it short.
Yes, I will. Matthew 8:28-32. And when he was come to the other side into the country of the Gergesenes, there met him 2 possessed with devils, coming out of the tombs, exceeding fierce, so that no man might pass by that way. And behold, they cried out, saying, What have we to do with thee, Jesus, thou Son of God? Art thou come hither to torment us before the time? And there was a good way off from them a herd of many swine feeding. So the devils besought him, saying, If thou cast us out, suffer us to go away into the herd of swine. And he said unto them, Go. And when they were come out, they went into the herd of swine, and behold, the whole herd of swine ran violently down a steep place into the sea, and perished in the waters. And then casting out the devil from a dumb, possessed person. This is somebody who can't speak, and he is possessed. So I'm just wondering about mental health issues. Now, Matthew 9:32-33 is short also. As they went out, behold, they brought to him, this is to Jesus, a dumb man possessed with a devil. And when the devil was cast out, the man spake. And the multitude marveled, saying, It was never so seen in Israel. And the last small bit is casting out a devil, blind and dumb. Matthew 12:22-23. Then was brought unto him one possessed with a devil, blind and dumb. And he healed him in so much that the blind and the dumb both spake and saw. And all the people were amazed and said, Is not this the Son of God? This is mental health issues. and some spirits. Maybe I need some clarification here. That will settle my question. Thank you, Dr. Tazila and Professor Bantu.
Thank you so much, Dr. Daktari, for seeking the clarification about mental health versus demons. When we look at the mental health issues, we understand there are various causes. Causes of mental health are diverse. And the one you are referring to right now is interpreted spiritually from the biblical perspective about demon possession, which we see very clearly that, you know, they were casted out, and immediately after they were casted out, the man became well. Other sources of mental health are sicknesses, just normal sickness, physical sicknesses, which end up depressing the individual so much that, you know, the person gets mentally disturbed. Other issues are pressures of work, relationships, drugs and substance abuse. They cause mental health. So that's why this dialogue is very important, so that when we understand the causes of mental health, it is possible for us to address them. And that is why the integrated approaches are critical to us, so that people get to understand there are some mental health issues which can better be addressed spiritually through spiritual approaches. Others can better be addressed medically, and also through psychosocial support, through the counselings by the counseling psychologists. And that's why we are saying we all need to come together and give support and be able to make an analysis, understand what is disturbing the individual. Another thing about, you also mentioned the experience I gave about a person who was mentally disturbed, making a carpet for me out of a carton box. This was to show that these mental health, these people we see at mental health people, they understand, they can relate, and they respect people. And therefore, we need not to stigmatize them. We need to get close to them and be able to understand what is ailing them, so that we can be able to support them and bring them back to order. Thank you so much.
Thank you very much for that observation. I want to bring notice to our viewers that our subject is integrating psychiatric and spiritual approaches for enhanced mental health. And this is an emerging field that recognizes the connectedness of psychological well-being and spiritual well-being. This approach acknowledges the importance of addressing mental health concerns from both clinical and spiritual perspectives. As you are aware, mental illness is not a sign of spiritual weakness. This means that in the scriptures, the man who had a mental illness, a combination of many illnesses, can cause an individual abandon himself or herself and begin to live a very solitary life. This was an experience as is envisioned in the Bible when Jesus had asked the disciples to go and rest and cross over the other side of the lake. The implication was that these ones were sober, were in a good mental state. But while they were on the journey, they were met by a man who had an abode in the tombs. That means the man had gone through psychological problems, fear, anxiety, phobia, panic attack, depression, stress, and there was no treatment modality. There was no treatment plan for this man. And as he continued, he eventually found himself in a board of tombs. It was during that time that Jesus was able to meet him and they were able to talk. So the Bible does not offer one simple answer for mental health. And that's why we are saying let's have an integrated approach. Earlier on, I mentioned that when God created man in his own image, in Genesis chapter 2, verse 7, it's a combination. It's a combination. He gets the soil, the dust of the earth. He forms man, and then he breathes into his nostrils the breath of life, and then the man becomes a living soul. Living soul, psyche. Soul is psyche. So as we do the work of bring about wellness, we are practicing what God has destined us to do. So in the process, we need now to have a dialogue. The priests and the clergy work towards bringing back that image of God that was lost in the Garden of Eden. And that does not dismiss the fact that people are completely okay. It is because of the experience of sin that people continue to suffer the myriads of problems. So the statement of the problem here, as we discuss in this dialogue, is that despite growing recognition of the significance of integrating psychiatric, because the demon-possessed person, one thing was Jesus was able to recognize and bring him out. But because Jesus had superpowers, the best approach, because he was cutting himself, that means he was completely mad. So the best approach was for him to have been taken to a psychiatric. If Jesus was not there, would have been taken to a psychiatric, then the psychiatric would immediately begin treatment. And then afterwards, he would take him back to the community. Now in the community, he will find the psychologists, the counselors, who would be able to now to talk to him. Actually, a number of people later on, when they discovered that he's sober, they were wondering, and they were able to label him and say, "Isn't this man who used to live with the, in the, you know?" So in other words, the partnership between the psychiatrist, the clergy, and the psychologist is more complementary than conflicting. And that's the reason in this dialogue that we need now to recognize. We need to recognize that this dialogue should be always interdisciplinary. We should be able to recognize that the innovative approaches for integrating psychiatric and spiritual perspectives in mental health. So in all these situations, we are able now to work together as a team so that we bring wellness. And there still remains a lack of international dialogue. That's why we are looking for those people who have the same mind that indeed we need to discuss some of these issues and come up with a unique collaboration in the area of mental health. And that's why Kenya Methodist University has given us an opportunity to come and begin the dialogue. And the eventuality of this dialogue is supposed to bring us something like Global Mental Health Center. And since Kenya Methodist has one of the best medical schools in the country and has produced one of the best students who have later on become lecturers in the area and well recognized, I think it would be very necessary that we begin some of these things within these premises. So many mental health professionals and spiritual leaders operate within silos. They are just on their own. But this center should be able to link so that we can have opportunities for interdisciplinary exchange and collaboration. So the Bible helps us to understand these circumstances. Actually, in many cases, the Bible has used concepts like demons, curses. But then there is a true meaning of the causes of these demons in psychology and psychiatry. There are biological components of the mind that interact, and then the body gets into more worse situations. So the Bible explains that these people in this state are demon-possessed. The psychiatrists say, no, you cannot say they are only demons. Let us dig deeper and see the interaction of the biology of the body. And then the psychologists say, yes, I think there could be some environmental experiences, there could be some unmet needs this person has not met, and there could be more of a risk factor that is causing these conditions. And as I mentioned yesterday, one of the risk factors in Africa that causes these mental breakdowns is poverty. So therefore, when we come together, it should be really important for us to have this dialogue focusing on integrating psychiatric and spiritual approaches for enhanced mental health. The reasons, one, is that it should promote a holistic understanding of mental health that takes into account both the biological and spiritual dimensions. And secondly, it should foster a collaboration between the mental health professionals and spiritual leaders, which would lead to more comprehensive and effective interventions. And thirdly, it should be able to help us address the diverse needs of individuals seeking mental health support, recognizing the importance of cultural and spiritual factors in their healing journey. You will notice that a number of people who have been identified by the Bible or the Christians as demon-possessed. So there are many triads of treatment. One of them will just go to consult the mediums, the sorcerers, the psalmists, the healers, all right? And when they are taken into those forums, they distort the reality. So we are saying, yes, we can work hand in hand with all of them because they are dealing with mental health of these people. So by coordinating together and looking into the factors that contribute these conditions, we have already mentioned these factors. Some might be biological or genetical, or they could even be curses. In the past, people used to curse. They can really be curses. So how do we deal with occult, for example, curses and belief systems? So by coming together, we'll be able to help the people explore innovative approaches. For example, if the priests discover that a psychiatrist can help us in treatment modality, the culture of sorcerism or looking for healers, even the Bible, you remember in the book of Samuel, Saul consulted the spirits of Samuel. Many people, when they reach at a stage where they have no other help, that's when they start looking for help from other sections. So it's very important that we get together. We can be able to explore some of these conditions and then help each other to understand the connectedness that we can do. I see someone asking, could we risk calling a demon possession a mental disorder and treating it as such? Or calling a mental disorder a demon possession and treating it as such? Can demons respond to antidepressants and antipsychotics? I like the discussion about multidimensional approaches. This will enable no one approach to be monopolistic. I believe a human being is a unit who is integrated socially, spiritually, mentally, name them, and therefore one affects the other. And that's the reason why this morning we are looking at how we can integrate psychiatric and spiritual approaches. There are those conditions that are exacerbated by failure to identify early some of these conditions. And the reasons why they do that, is they don't have other service providers at that moment. And that's why you see a number of people go to church, go to mosques, because there's no identified psychosocial support that has been put in place. And for psychiatrists, they will just be treating things that are beyond psychological, things that are beyond spiritual. And therefore, if we believe that by bringing back the unit, the body, mind, and spirit together with the key service providers, it will be very interesting. And people now would be able to acknowledge the importance of addressing mental health concerns. I want you to take an example, especially for the clergy. When God had created man in his own image, and he was naked. He was naked, and actually the Bible says he was naked. And then all of a sudden, we see the man declaring himself as naked. That you see, my wife told me to eat on the tree of the knowledge of good and evil. So good and evil, demons are evil. Demons are evil spirits. But these spirits cannot be touched. These spirits are invisible. Psych or psychology deals with the mental health, is the science of the human behavior and mental processes. When someone is mad, he does not understand himself. And that's how the Bible in the book of Romans, I think my bishops will tell me, there is a text that says, when I want to do something good, I find myself doing something bad. It's an experience of exasperation. He ought to be doing something which is good, but is not seeing it being done. Such person needs spiritual prayer. And actually, Paul says at the end that who shall then rescue me from this life of death? Really, mental illness can lead to death. If you have anxiety and it has not been classified, you have fear. There are people who fear space, for example. There are people who fear heights. They cannot stay in a room. Even in medicine, there are students who have qualified to do medicine, but when they are exposed to cadavers, those dead bodies for experiments, they leave out. They fall down. So we don't want to see such kind of scenarios. So this dialogue should be able to give us a limit that I am limited in this, but there is someone who can take over from this. And that's the reasons why in most hospitals, when you are not able to handle a particular case, you refer. You say, this one can be handled in Nairobi Hospital. This condition can be handled in another area. So this dialogue is able to help us acknowledge the importance of each of these professions, psychiatry, psychologists, and spiritual leaders, so that now we don't bring a confusion between them. So with these kind of remarks, and I'm very excited that people are more concerned about the interconnectedness. This interconnectedness will bring us to come with a mental health facility, which is an university. Why are we beginning from our universities? Universities are put in place through an act of parliament, and the parliament gives the operations of this institution through a charter that charter streamlines the programs that need to be offered. Now, the churches will provide an avenue for us to settle some of these conditions. When the churches provide, then the institutions will say, okay, let all the pastors who are preaching on the streets, they are doing good, they are calling on, because in the past, in the last days we shall have apostles. Then they say, no, I think the best thing, let's take them to Kenya Methodist University or USIU so that they get basic skills on how to handle a human being. All right? So the universities will now have short programs and say, okay, like the experiences of Shakahola, for example. We say, okay, if people are desperate completely, let's take them for the mental health checkup, which is maybe located in Methodist University or one of the facilities in East Africa. Because if you want to go and see Jesus, there is a time when you are supposed to see him, because he says anytime he'll come. So you don't hurry situations. So lack of such kind of coordination and partnership will make us lose a number of variable personalities. So this dialogue within the establishment of the Inter-University Council for East Africa, and also with these universities, Kenya Methodist University and other universities, we will really be able to appreciate that human beings operate as a unit. And even professions, we are now looking at multidisciplinary approach. We work under that kind of collaboration. And I'm very happy that this dialogue should ultimately bring increased awareness and understanding of the importance of the integration, and it should create collaboration between mental health professionals and spiritual leaders. So yesterday we looked at the burnout, the professional traumas that they go through. So if, for example, a psychiatric has had many patients, all right, so where can they be spilled off? The psychiatrist may require that, before we deal with these conditions, let's have a psychologist do an assessment. Let us classify these conditions. And when they have treated them, they can have a facility for rehabilitation. And one of the places for rehabilitation are Christian or religious institutions where they can be prayed for, and then they are connected back to their homes. So this, in so doing, will help us to empower some of the mental health professionals, like psychiatrists. For their work, they are medical doctors, and they are really specialized in treatment of these medical conditions. We can say that. We can still empower them and have short courses for them, say in psychology. We can also offer them courses in prayer, and so that now all of them are not inadequate, and if there is inadequacy, they can refer to each other. And then we can have a strengthened support systems for individuals experiencing mental health challenges within faith-based institutions. Thank you very much. I believe, Chair, you can proceed from there.
Thank you very much, Professor. Thank you. I think you gather to address this issue as a team from all disciplines, from the relevant disciplines, and that way we'll be able to hopefully provide a solace for issues of mental health. Professor Karen, are you now ready? Can we give you a chance? Thank you. Lola from in Uganda, you managed to log in. Thank you very much. We welcome you. Karen? I'm checking with Professor Karen Nyamwange.
Yeah.
Are you now set?
I am ready now to speak.
You're now set?
You can hear me?
Yes, we can hear you.
Yeah. Thank you so much for the chance. Am I able to share my screen?
You should.
I should.
From where you are?
Yeah.
Use the green button at the bottom which says share the screen. You can see that it's a button that tells you to share the screen. Good.
Are you there now?
Yes, we can see you. Thank you. Welcome. Let's get going then.
Thank you so much. Let me now extend my screen.
If you can spare about
Okay.
20 minutes, then you have a few responses so that this becomes a dialogue. That would be good. Thank you.
Thank you so much. First of all, I want to thank the organizers of this conference for the opportunity to put something together to share with the participants. My name is Karen Nyamwange, Professor Karen Nyamwange of Educational Psychology, and I'm a lecturer at Kisii University, Kenya. I'm happy to speak to the audience about, of course, that is not me, assessing the impact of digital technologies on the holistic health of frontline health providers. And the study was geared to get information from Kisii County of Kenya.
Those others online, please mute your mics. We want you to mute your mic so that we can follow the presentation. Sorry for that disruption. Professor, continue.
Thank you so much. The study has been carried in Kisii University, but has the possibility of generalizing the results to the whole of Kenya. Yeah, as it were. And I just want to mention here that when we talk about frontline healthcare providers, this is very wide, and it includes everyone, beginning from a human being. In some way, everyone provides some kind of healthcare to someone or to some people. Based on the theme of this conference, now frontline will include the pastors, the clergy, all those people that work in the service of the Lord to humanity. The clergy, it will include the psychologists, the psychiatrists, it will include anyone and everyone that works in a hospital facility. It includes any healthcare provider in some way, has a home, has a school, has an organization that deals directly with the welfare of human beings. So when we talk about digital technologies, I just want to give a brief background. This is not a new area. Digital technologies have been there for a lot of time, and even here in Africa, we have experienced technologies, but a lot of it dates back to COVID-19, which begins from 20th March of the year 2020, when there was lockdown and there was now need for everyone to start thinking of how to provide service. And that is how the influx of digital technologies came up. So the study really aims to find out, what is it like? What is the impact? Is it something people are happy about? Is it something that is stressing? And so the study was based on that. I would like to just give a disclaimer that because of the time I accessed this link to start thinking of what to put together, this presentation will only give basic information that is just come in. What we could say that it is a little less than what is expected. So much will be coming in as many people respond to the questionnaires that were given out. And we would say that many people have done studies on this on the aspects of what technology is doing, the internet technologies, the new therapies that are coming out to be utilized, and if we are utilizing, how are we getting results? Are the results the best of what we would expect? And then so much about controls and quality of the information compared to where we were before COVID-19. And I would say that from this study, we find that technology is not something we are going to avoid. It is quite crucial for communication in today's world. It is hard to imagine that any company, any hospital can work without technology. But efficiency is also another aspect. Now,
Professor,
in this era,
Professor, your slides are not moving, and perhaps because you have not been able to share them as a full screen. Are you able to do that so that we can also follow?
all right, I will follow and
You are okay. You only need to do that as a slideshow. So cast them again. Cast them again will help you get there. Just share again.
I will get there. I will get there. Okay. So I'm now on the entire screen.
Share the slides.
Are you there now?
Just a minute. They are coming.
I'm seeing already the participants can see my screen.
Can you see the slides? Members? Now run the presentation. You are now sharing now select this presentation. Yes, you are sharing the screen of, now select your own presentation. You have selected the entire screen, but you haven't selected your slides yet. Go to the PowerPoint icon at the bottom. You can see the PowerPoint icon at the bottom. Yes, click on that. Good. Now, from there, you have written slideshow. Go to where you say from the beginning, under the word file, where you normally go to file, the next one. Okay, good.
You see?
Yes, we can now move on, please. Good.
Okay. Okay, thank you so much. Then now I was actually saying that the significance of technology and communication cannot be underrated. And that is things to do with email, messaging apps, video conferences, just like this one we are having now. And this is likely to help us improve in collaboration. Just imagine the many of us that are in this conference. We have come from different parts of this world, yet we are together and we are understanding ourselves. So the study was aimed at getting to understand is that when we talk about technology being important in service delivery to our clients being those who have issues, the patients. So we are asking ourselves. So in this background, I've just given reviews of what people have done. There is a case of 2009, 2011, 2021, there's 2022, 2023. And the idea is, what have other people done? A lot of information coming from the reviews is that the digital technologies have done much good to us than where we were before. Preliminary findings of this study. Now, this study, that information came from a half of the expected respondents, and that is because of the time from which I started thinking about this, sending out Google Forms and them being responded to. These are the preliminary findings. Okay, it has come out clearly that healthcare service providers utilize a wide range of the digital technologies in improving patient care and improving administration for those who are in administration and all when you find that maybe in a hospital facility, the digital technologies are networked. Doesn't matter where you are, you only need to click and get information. So electronic health records gets to be so easy. Anyone, any service provider can get information of a client from wherever they are. You only need to get the number and get details of the client, and you are able to know where to begin. You will have the medical history. You will know the medications that have been given. You will get to know the results of lab tests. You will now, the frontliner health provider will now think of the next plans. And does not mean that the patient must all the time move from one point to the other. You can actually reflect on where we have come from. In this study, you would like to communicate with someone, you only need maybe to key in the information and want to ask what other people think about the diagnosis. You will do it very easily from a sitting comfort. Wearable technologies which people use, such as fitness trackers, smartwatches, and medical grade sensors, monitor patients' vital signs. And you know, these days you go to the hospital, before you do anything, they ask you, take your vitals. The vitals are shared to all those required to make decisions. Then we have other technologies like remote patient monitoring. These ones enable the healthcare providers to remotely monitor patients, even when the patients are in the hospital, even when they are in their homes. You will know the health status of the patient, the adherence of treatment plans, and this helps the healthcare providers to think of the next steps. Another one would be the health hubs and patient portals. Those are some of the ones they use, so that even you as a patient, you can click on the portal and you understand information that has been keyed in. Clinical, that one I've said, sorry, that is a repeat. Some of the physical impacts of using technology. What came up is that, most healthcare providers who use technology, they have screens in front of them for long hours. These screens are likely to cause eye strains, and that is because of prolonged use. You are either out of the computer. Before you are through with the screen of the computer, you are on your phone screen. Before you are through with that, you have entered into a matatu. There is a screen in this matatu. You go to your home, there is the TV screen. So screen, and you are in many hours out of 24 hours. Many of the hours, more than a half of those hours, you are on the screen. So when you use these technologies, as much as they're helpful, there is also an impact, a physical impact on the eye strain. And soon, if someone has not taken care, self-care, by getting maybe contact lenses for screen use only, they are likely to suffer. Another impact, the study was getting the impact and getting to understand how the healthcare providers feel about usage of technology. It is muscle tension and fatigue. Really, those people who are on screens, they complain of fatigue and making very tired. They maintain awkward postures. Yeah, if people have not been trained on how to sit, they don't have comfortable seats, yet they must still continue working, they will have that issue of muscle tension, and many of them, with due time, they will complain of backache. Then there is repetitive strain injuries, continuous use of keyboards, mice, touch screens can contribute to, such as corporal tunnel syndrome, dendronitis, synovitis, and all these result on repetitive movements and awkward positions of sitting. Sedentary behavior. When we have, okay, digital technologies. Okay.
Reverend Kanoru, could you mute? Reverend Kanoru, please mute.
Okay, thank you so much. You are going to notice, or it has come out clearly, that many people use digital technologies will be at one place, one point for extended periods of time. And this is associated with health risks, including obesity, which is a preliminary reason for setup of some ailments and sicknesses, cardiovascular diseases, musculoskeletal issues. They begin from there. High blood pressure begin from there because of the sedentary behavior of sitting continuously for long hours. So mental fatigue and stress. So when one person exposes oneself to digital information, digital use, multitasking, navigating complex software at the same time with several interfaces, this can lead to mental fatigue and stress. And you know what stress can do to someone. It will lead to depression. And remember that depression is not so easily curable. So, okay. So, what does it then mean when using technologies, digital technologies, and efficiency in provision of health care of patients in terms of service delivery? Sure. What came out is, it is true that work gets easy. There is streamlined documentation. Digital health records become an easy thing. They enable the frontline officers to quickly access and update patient information, hence giving quick feedback, and administrative burdens are lowered. Then another advantage is that there is remote consultations. You use a telephone to consult. And then this gets to be very easy. A lot of time is saved. Enhanced communication. Digital communication tools such as secure messaging platforms and video conferences facilitate collaboration, enabling timely consultations and care coordination in a whole facility, like a hospital or a health care, a home, a safe home for maybe the elderly patients, or a mental hospital, a mental clinic, a mental facility. Decision-making support is imagine the MOE, the medical superintendent of a hospital, for example, wants to meet the top managers. He doesn't have to do it during work time. He can do it before 8 in the morning, he can do it in the evening. And therefore, decisions are made easily. And especially when issues come down from the bottom, from the top office, from the national office, they're trickling down, and a response is required immediately. Imagine in such a scenario where we have come from, it would be writing a message or waiting for people to come the following day and you call them for a meeting. Remote monitoring, digital healthcare technologies, including wearable devices, remote monitoring system, enable health indicators, allowing proactive intervention and management of chronic conditions. So that is where you would wish to find out from maybe a senior consultant on an issue, and then you go on to make decisions for the treatment plan. Efficient resource allocation, data analysis, analytic tools help frontline officers analyze patient populations, identify trends, and allocate resources more effectively, optimizing staffing levels, medication inventories, etc. Education and training gets to be easy because like we are in a training now, we will not be the same, we will not go back the way we came, but we've learned and we have learned remotely. Patient engagement. Again, I think there are developed digital hubs that are able to access patient portals to know how the patients are going, and then they are able to empower them for the next steps. Okay, basically this is one of the questions that was given to the respondents, and some of the questions, some of the responses are the ones that are here, and I've almost spoken about some of them, that there is efficient communication, remote consultation, save on time, fast access to information. You don't have to say, walk like 500 meters, 500 feet to go and get information. Now it gets to be easy for the healthcare workers. Adoption of this technology. Again, I've talked about this. Emotional impact of use of digital technologies. One of the things you find is that due to constant exposure to a barrage of digital information, there are images to be read, there are messages to be read and responded to, there are notifications, they can overwhelm an individual, and this will lead to feelings of stress and fatigue as they struggle to keep up with the influx of data. Almost like I am one person who will read some messages after 3 days, and some that were important, they would have bypassed me. And because of that, I would struggle now to keep up to date. By keeping up to date, I am welcoming stress and fatigue into my life. Work-life boundaries. Digital technologies enable constant connectivity, making it challenging for individuals to disconnect from work, even during non-working hours. I am sure everyone, even in this meeting, can tell me that there is no way you can go home without extra work. Even if you have not carried it physically, you have it in your mind. Even if you don't have it in mind, someone has posted something that needs to be responded to. So boundaries, it gets to be so hard to keep the boundaries between work for workplace and work for home place. It is like, it is intertwined, it is part of you, and this one can work on your emotional resilience. There is constant availability of digital devices, and the allure of social media, online entertainment, and news updates. They just want to encourage you. They push you into watching. They are so entertaining. And even when you want to get out, you just say, let me read this one. Before you are through with it, another notification has popped in, and you want to see, and you find you have spent so much time on the screen. Digital technologies often encourage multitasking. Yeah, you are eating, you are on your phone. You want to keep working. You are talking to someone, but you are still on your screen. And this causes mental overload to the practitioner. It could even be a pastor. The pastor is seeing messages from the lady, and you want to respond, you want to call back, you want to find out how it is, and this works on your emotions. Pressure to stay updated. That is the push, the pull and push. And if there is anyone who has managed, it would be so good that you are able to keep off. A few people have told me they can keep off if they stay upstairs, they sleep upstairs, they will leave the phone downstairs. But I will tell you for sure, majority of the people want their phones next to their bed. Even in the middle of the night, when you hear click, you get hold of the phone. You want to see what is there. Some can come with bad messages and they get you awake for so long. And some also bring anxiety. And if you don't have skills to deal with anxiety, it will now spiral and it will get you into situations that would take long to be dealt with. Now, communicating primarily through digital channels such as email, instant messaging can lead to misinterpretation, very sure. And many times, it is easy speaking to someone on a face-to-face environment than doing it on paper, on screen. Sometimes people read that you did not mean, and this can bring mental issues that can last for so long before they can be resolved. Now, again, this was one other question I asked, and only few responses came in because of time. Some will be coming and the paper will be beefed. So to what extent do people feel that their use of digital technologies impacts their ability to maintain a healthy work-life balance? Now here again, most people responded that they often feel their use of digital technology significantly impacts their ability to maintain a healthy work balance. Yeah. Multitasking demands. The use of the technology, digital technology, encourage multitasking. I am almost very certain it will work very well for females and not for males because of the way they are wired. But such multitasking can lead to cognitive overload, and if you are doing 2-3 tasks, some of them will suffer than others. It has also been proven that multitasking is not encouraged. Okay, pressure to stay updated, I've already said that. And what would then be suggestions to make digital technology usage more supportive of one's holistic well-being? So, these were some of the responses. 1, promote digital literacy. Whereas we are using digital technologies, a lot of literacy needs to be given. We need to be put into workshops. We need to be told how to use, how much time, how to say no, how to close your screen. We need people to teach us on this so that we are able to balance how much time we use technology and also balance work time and home time, or other times, even church time. Many of us, even when we are in church, the Bible says, keep quiet. When you enter the house of the Lord, you walk in silently and keep quiet. These days, we actually keep quiet, but we are so loud on our screens because we have a lot of information, a lot of messages coming in, and you even respond, only that you keep it low. So one other thing is enhance collaboration. Collaborate with EHR. That is an app to improve the usability and user experience of electronic health record system. Implement ergonomic workstations. Design ergonomic workstations. That is to say, you design where you go to work with your technology, design where you go to socialize with your people, and when you go there, you close your phones. I am aware of some places, some entertainment places or rest places where you go to, where in psychology we say, psychological first aid. You just go and sit and speak to yourself, have a conversation with yourself, have a conversation with someone. As you enter in such places, you are asked to leave your devices behind and have rest from the screen. So encourage breaks and time offs.
Yeah, Prof, I want you to allow. I want you to summarize so that you allow a question or two for people to interact with you. And that would be good, yeah, because you might, we need to get some response to these things.
Okay.
Okay.
Okay. Right. Then I am there. I'm very obedient. So more results will be coming up, but it is clear that digital technology is a must in the current dispensation, but a lot of regulation is a must. Thank you. And back to you.
Thank you. I like that. I was, maybe the last one you were mentioning about the church. I was wondering whether we need to put a place where everybody leaves their gadget outside. Maybe just to take it up as we invite one or two comments or questions in this on this presentation. But you can tell me, maybe you might tell us, do you think that would be a good idea? We keep our gadgets outside, but you also say the screens are everywhere, and we all of us want to do digital.
Thank you for that thought. I would say yes and no. Yes, because it will be a good thing. When people come to church, they know they have come to interact with the physical people that are in church and to listen to the presentations coming from the podium. And no, because that will be a way of sending our youth away, and we need them. The beauty is that some youth are able to multitask. They will be listening, yes, they will be on their gadgets. How we wish they would close them, but if they don't, we also pray that they are able to multitask and get that is being presented. Again, finally, I would say education is a major tool that can be used. The clergy have a responsibility to keep talking to their laity about holy hours and even speak about lessening the use of technology in the service. Because already in most churches, the service is televised. It's on the screen. So too much screen use can pose negative challenges to us. I think that would be my response. Anyone can respond. This is maybe open to everyone.
Thank you very much, Prof. Any other? I want to invite the online participants. We haven't given you a lot of time. I want you to get to see whether any one of you has a question for Professor and or a comment on regard this, so that you can participate, because this is a dialogue. It's a conversation. It's not a monologue. Online participants, you can use your hand to indicate that you want to ask a question, and then we'll give you a chance. Or make a comment. And we want to highlight that this summit is being streamed on our Facebook and our YouTube, on the YouTube channels. So if you're not able to go into Zoom, you can have people follow this through the YouTube. YouTube is Discover Kemu, I guess. That is the channel that you apply, and the same for Facebook. And you should be able to follow us on Facebook or YouTube, and of course on the Zoom platform like we are here. And you should be able to follow this conversation. I'm asking again, in the online, I can see Lefred, yes, online? Somebody want to ask a question? Yes.
Yes, my name is Jacinta.
Yes, go ahead, Jacinta, please.
I am attending from Karatina University. I'd raised a question that I put in the Q&A about telemedicine, the challenges that we are likely to get because it's something I experienced. However convenient it is, the insurance industry has issues with the telemedicine and making claims, medical claims. Hello.
Hello. Please ask the question in full. By the way, it is not on the Q&A. It looks like either you did not post it. So this
sorry, probably I didn't do.
Yeah, but you can ask it. You are now on air. Please go ahead.
I was asking the presenter, or maybe anyone in the group who could tell us what the insurance industry, the medical insurance industry is doing about telemedicine and making a medical claim. Because, for example, if I could use NHIF, for example, let me use the old name. For me to make a medical claim, wherever I'm going, I'm supposed to have my fingerprints taken. But if I'm in telemedicine, I'm being treated either from my house, as the doctors are consulting, so I'm not able to have my fingerprint taken. And that was difficult to make a medical claim, or maybe for my portal to be opened to authorize. Anyone with information about what has been done by the insurance industry to address that? Thank you, sir.
Okay, thank you very much. Prof, this is about digital transformation, and although it may not directly be the subject you researched on, you might be able to give a comment.
I can only, thank you. Now I understand I did not go that way, but I would say this. I use an example. One time I've taken a patient to the hospital, and it was 8 p.m. in the evening. And because of that back and forth, the insurance is not responding quickly. You have to keep waiting. The patient was admitted at 3 a.m. of that day because of that. I would say here we can apportion blame, in quotes, to the insurance companies, and also apportion blame to us, the clients. In most cases, the clients are not willing to give full information. And when you don't give full information, technology is not like human beings that can think for you. It just stops there because some people are not willing to give their initial signatures, maybe finger signatures that can open the portal for you to get information. So for me, I will give the unwillingness. But remember again, learning is a continuous thing. Perfecting the game is, we would say, like the wise people say that Rome was not built in one day. These are technologies we are uptaking. So that is now saving the companies, that they are keeping learning, and maybe soon they will be up to date. And that also differs from one facility to another, or one service provider like NHIF. Remember, all of us, our data is stored with them. It's not also easy, but I will also allow another person to come in with information.
Thank you very much for this presentation. I only wanted to remind our viewers to try to limit themselves on the intersection between psychiatry, spirituality, and mental health. And based on the presentation by Professor Karen Nyamwangi, I will just try to respond to the question from a colleague from Karatina University, and I want to thank them for keeping in touch. I'm aware that both telemedicine and fingerprint technologies in pharmaceuticals play important roles in advancing healthcare delivery and pharmaceutical operations, respectively. This telemedicine facilitates access to healthcare services, particularly in remote or underserved areas, while fingerprint technology enhances security and control in pharmaceutical manufacturing and distribution processes. So what we are trying to do, we are trying to see how does a psychiatrist, for example, be involved in the process of determining the treatment that is supposed to be given to a client. How does the clergy fit in the process of service delivery? How does the psychologist fit in? Because I'm aware that these technologies are very important, especially in monitoring quality control. And in this dialogue that we have, once we have come together and agreed, then we can still be able to say, okay, if I'm sick, I have a mental condition, and I want to use insurance, what kind of technology can be useful for me? And then also, as I mentioned, these technologies, fingerprint technology, can only be employed in inventory management systems. I'm not an expert in IT, but basically that is what I believe should be done. And the reason for use of these technologies is for access control, inventory management, and quality control. However, I want to ask a set of questions to Professor Karen Nyamwange. These questions may not necessarily be answered in this dialogue, but could be questions for thought. One of the questions that I wanted to ask Professor Karen Nyamwange, one is that how do you plan to measure the effectiveness and impact of the proposed interventions on the holistic health of healthcare providers, and more in Kisii County over time? Because we understand the implications of using these technologies, and in this kind of partnership, they would really help in coming up with a plan. Then question number 2, what policy recommendations would you prioritize to ensure the long-term support and well-being of frontline healthcare providers in Kisii County, bearing in mind that we are having the concept of the East African integration? I wanted to support you in terms of case scenarios. For example, digital support platforms, like now what we are using. In your presentation, imagine a nurse working in a remote health facility in Kisii County, like in Nyamira or wherever this village is, struggles with feelings of isolation and stress due to limited access to colleagues and resources. Then she discovers a digital support platform that provides virtual counseling or peer support groups and resources for managing stress. So through regular engagement with the platform, she finds a sense of community and learns coping strategies that improve her overall well-being. So digital support platforms would be the best thing to envision doing, and that will help us. Another case scenario would be integrating spiritual care. A clinic officer, for example, working in a busy hospital in his county. And then he recognizes the importance of addressing spiritual needs in mental health care, but lacks training and resources in this area. So through a digitally facilitated training program, he learns how to integrate psychiatric spirituality into his practice, providing more holistic care to patients and experiencing reduced burnout as a result. So some of these case scenarios work well in our dialogue so that now we could be able to see a comprehensive report which would be detailing the findings of the assessment on the impact of digital technologies on the health, on the holistic health of frontline healthcare providers. And of course, the recommendations that you provide, although there could be some disadvantages, but through guidance, through guided imagery by the pastors, for example, the clergy, would be able to quite often talk about the impact of these technologies. So I think basically I want to thank you for that presentation, and I look forward to an opportunity where we can explore into the potential integration of psychiatric spirituality and mental health care into the digital health solutions tailored to the needs of frontline providers in this context. So I don't know whether you'll be able to respond to one of those questions, or we can keep it for further dialogue. Thank you.
Well, briefly, I would respond, and I want to begin from where you ended, where you talked about disadvantages of digital technologies on service provision by the frontline health workers. One of the setbacks is age. From this study, it was said that people between 20 and 30 responded, 30 to 50, 40, 50 to 60. And hopefully that those are the people who, in the Kenyan situation, who can work in a health facility. Not so much had come in of respondents between 50 to 60, and I am almost imagining that their responses will be contrary to the preliminary reports that I've given, in the sense that people over 50 or 50 plus, let's call it 50 plus, many of them are very skeptical in the uptake of digital technologies. I see that even from where I work, and you would find someone completely saying students cannot take online exam. And here is a colleague teaching 2,500 students online, but now you are subjected to have them respond to the questions manually. And this is an aspect of age, the age bracket in which people are. They do not want to venture into new avenues. This is likely to be a challenge. You are a very senior officer who is expected to utilize technology to have administrative work go smoothly, but because you've not allowed yourself to learn, to train, and try to put your fingers into that technology, even your phone is that one of the small one, then that is the kind of challenge that is likely to be found. One other challenge will be enforcing. You're sitting down to come up with policies that can support the staff in terms of use of technology. This will now depend on facility to facility. I will again want to comment on the limitations of people working in the helping profession, like the counselors. There are few, but the cases are many, and there is no money to pay for the services. And so when people are not able to get that, some of them quickly find platforms where they can now air their issues. Confidentiality is completely now supported. Many of them, you know, until you are in technology, you will not even find those people that do virtual support to people, clients. But I would also maybe encourage us, all of us, that when you are in many groups, there are people coming up to say, oh, there is supervision of counseling. If you have a case, let's meet today, join in. Maybe it will be important that we are able to join in, because then there is a lot of learning and a lot of support in the work that we do, psychiatry, counseling, and pastoral work. It is true that people have issues. Thank you, and thank you for the many interesting areas Bantu has brought in, the case scenarios, integration of the spiritual needs. Those are things we don't leave out as service providers. Thank you so much, and back to you.
Thank you, Prof. We are happy that this dialogue and conversation continues. So we are going to take a working tea break, I'll call it, because there will be a few questions that can be responded to. So I want to ask, because those of us here physically, who are physically present, there's a cup of tea. I'll ask Reverend Kibara to pray for that, and then we will continue with the conversation as we prepare to listen to the next presentation on post-traumatic stress disorder by Professor Baguma of Makerere University. So that's going to be our next presenter. So in the meantime, there are a few questions. Lola, you are Lola from Humak, you and who is at Kabare, may also be responding to some questions that were raised on art therapy as part of this conversation during this working tea break. So thank you very much, Professor. Let's acknowledge, let's appreciate the Professor's presentation together. Yeah, that is physical. That's not digital. It's true. And those who are in the digital can also use some digital ways of making sure they clap. There are some icons at the bottom which you can use. Those of us physically here, you can see how it feels. So asante sana, Prof.
Thank you so much.
It's indeed very refreshing to have this dialogue. Our online participants, you are welcome to share prayer with us as you take your tea wherever you are. Shall we give thanks for the cup of tea? Jehovah God, we are before your presence to appreciate your provisions for the care of our physical bodies. We give you glory, we give you honor, even for these deliberations, oh God, we are going through to feed us mentally, even to be able to take care of ourselves better. We thank you now for the cup of tea and the snacks you have provided to nourish our bodies. In Jesus' name we pray and give thanks. Amen.
Thank you. As I've indicated, I would want, because we have a big online following and the people who are online, I would want us to continue with the discussions as those of us who are present here enjoy their cup of tea and, of course, refresh in any other form that they may consider necessary. Thank you very much. And of course, we want to not just engage with us here, but also those who are online. So I keep asking those who are online, if you want to ask some questions, please let these questions come through. For example, I can see a question from Natamba Esther, who is attending from Kabare University. And her question is, how would you know that a person needs spiritual support, and to what extent would spiritual intervention be? How would you know that a person, this is from Esther. Esther, I hope I'm asking the question the way you wanted to ask. How would you know that a person needs spiritual support? And to what extent would your spiritual intervention be? This is a fairly open question, of course, but I'm sure those of us who are from the spiritual dockets may be able to give a response. How do you tell? How would you really tell that a person requires this? Somebody is looking to answer that question? Did I hear?
You want to listen to PTSD?
Yeah, the PTSD is coming shortly, soon after. For now, we are having what I'm calling a working break, which mainly is going to be on questions and answers. And I'm listing this question for those of us in the, this is a dialogue from all angles. Those who are in the ministry of the preachers and the clergy and so on. Do you want to respond to Esther's question? Anyone? I want to give you a chance. Just let me know that you want to respond, and then we'll give you a chance. The question is on the chat platform, so you can be able to follow it. But it's literally asking, how do you tell that somebody is in need of a spiritual help? And even when you have known that, what is the dose? Do you have anybody who wants to respond? Yes. Okay, Professor Bantu here offers to give a response. So let's listen.
Thank you very much for this question.
And I want to for every answer.
For every question.
For every question.
We are asked.
Thank you so much. No one has.
Professor Karen, your mic is still on. If you can mute, that would be good. Professor Karen, if you're able to mute, that's good, so that we can hear the answer to the question by Esther. Professor Bantu, continue.
Thank you very much. The question is, how do we know someone needs spiritual support?
Yes. And to what extent do you go for that? Do you give that support?
Okay. So I think the basis of spiritual support is based on a general assessment. Usually we need to be careful in terms of providing services. Services are provided for after an assessment. For example, if I have assessed someone with a mental problem, and the person is able to disclose these conditions that have contributed, and the spiritual leaders. I have a case that I've read through the media, and I was sharing with my colleague chair, Dr. Mushiri, about a husband who had divorced the wife, and then the wife got married to another husband. And this man, the husband, the former husband, found this lady in the church, and an altercation ensued, and actually the husband had the ex-wife. Now this culminates into a police case, because it's not right, because she had divorced the wife, and I believe it was official. And the wife could have been cancelled of what she could do, and I think that's what ultimately led her to get married to another person who later on took her to church. So, whereas the person who hurts could be diagnosed with a mental problem, either this problem could be psychosocial or personality. There are persons who have personality disorders, persons who are narcissistic, for example, narcissistic personality disorders. So such conditions, after assessment by a psychologist, the person is ready, after he has accepted the condition, is able to go through sessions of counseling. Now, when the person recognizes that indeed this is what happened, he will now be required to go for counseling. In the spiritual realm, you remember the man who had 2 sons, and the first son had been loyal to him throughout his life, and then the second son, and I think that's in the book of Luke for most of you who are reading the Bible. So the second son desired to move away completely from the father, and he went and squandered all these things, and ultimately after he squandered all that was given, he was not able to get even a meal to feed. So later on, this man, the younger man, discovered himself, but I believe he might have been consulting on the phone about how life it is. But I think during those days there were no phones, but I believe he must have been consulting. We have what we call inner talk. So the Bible says that he came back to his senses. And when he came back to his senses, he said, how many of my father's workers have food, have all that is needed, and me yet I am here suffering? So he went. Those thoughts, how many of my father's workers are, is a prayer. He's praying. And in fact, the Bible says before he could even reach home, a bull had been slaughtered. Before he could not reach home, a ring had been prepared. Before he could reach home, people were really waiting for this man, and a wedding was done for him. Was it a wedding or a celebration? So, that person who has come, he needs help. He needs spiritual help. He needs spiritual help because he has known he is guilty. He has known the only place to be is at the Father's feet. So he needs to be spiritually connected so that he can be able to discover himself. And the Bible says that if a sinner turns away from all his sins, there is rejoicing in heaven. So for this person to continue living a holistic life, he needs to be under the leadership or pastorship or stewardship of a catechist or a clergy or an imam. I have seen a number of marriages being carried and conducted in churches. The persons are counseled for the 6 months. After the 6 months, they are left to continue living alone. And then they wait when a problem comes. That's when the priests will go back to solve the problem. This person who has entered into such kind of a holy relationship requires continuous prayers, requires continuous gathering, requires continuous assessment. First 5 years, 10 years, 15 years, 20 years. so that issues and concerns keep on coming. And these issues that continue coming can hinder the person from thinking well. You find that you have problems of money, you don't have money, and yet there are demands in the family. So the most important thing is to help the person to have continuous spiritual attachment with the persons that wedded the individual. I believe every time everyone needs to go through an assessment. And when this assessment is done, then they can be referred to relevant personnel. Our assumption is that these people, if they are not talked to, they will spill over their emotional baggages or unfinished businesses in their lives to the significant others, to the juniors and the seniors, hindering effective communication and interpersonal relationships. So it is important that first everyone needs God, everyone needs prayer, anyone needs spiritual touch, because in God's image we are made. We are his workmanship. So the first priority thing is spiritual. And that's the reason why you find a number of men and women. Of course, men and women get to church because that is the primary school. Maybe I should call it the kindergarten. And then later on, when these conditions are not sorted out, yeah, so basically that is what I think, that's the time you provide spiritual guidance. Thank you very much.
Yeah, another question that is on the platform asks, and I read it out. Professor Karen, in her conclusion, stated that digital technology is a must in the current dispensation, but a lot of regulations must be put in place. My question is, what are these regulations and how do we implement them? Clarify this question. It says when medical support has failed, showing signs of suicidal thoughts. So what's the question? Jessica, are you able to speak out and express your question?
Hello, it's not a question, it's a response to the question.
Yes, go ahead. You are responding to a question?
I was responding to this question which Professor Bantu was also responding to. This one, how would you know that a person needs spiritual support? And to what extent would your spiritual intervention be?
Okay. You are responding to Esther's question. Good. So would you want to explain a little bit? Your statements are good, but then maybe you want to speak. It's your chance to speak, Jessica. Explain, no problem.
All right, thank you. On the spiritual basis, that there's nothing impossible with God. With man, it can be impossible, but with God, all things are possible. And many times, as human beings, we start on our own strength, but when we turn back to God, He helps us out. There's a situation, someone goes for medical help, and what? They have no rest, they have no option, because I have seen many, they turn to God, they turn to pray. They say, let's go to God. Let's go to the spiritual aspect. Others may go to the God they believe. Others believe in, people have different beliefs, the gods they have that they believe, but for me, I believe in the God of the Father of Jesus Christ. That's the one I believe in, and I believe seeing Him do great things in people's lives. So each one has a belief. That's where the spiritual aspect would come in. Thank you.
Thank you, Jessica, for that. And you have, of course, clearly reminded us what is impossible with the men is not impossible with God. I think that's a good take home. I see further question. Professor Karen, you wanted to respond to the question of what regulations, what suggestions in terms of regulations you would want. Then we also have a question by Tibejuka Edith. What's the way forward in dealing with medical, spiritual, and cultural perception in treating the psychiatric cases in the community, as many people are broken down completely? So what is the way forward? That's a question that you would want to hear some conversation, and I think that is a good question. Well, how would you then deal with the how do you bring together medical, spiritual, and cultural perception in treating the psychiatric cases in the community, as many people are broken down completely? And then there is I think Dr. Babu must have been providing an answer, and she can always, of course, open her mic and express. As helpers, we need to listen and discern the direction. If the spiritual, then get consent. If it is spiritual, then get consent. Dr. Babu, before somebody responds to the other questions, would you want to clarify what you want to say there? Dr. Babu does not seem to be able to respond. Dr. Babu, can you hear me? Hello? Ongeza sauti hapo ili Dr. Babu asikike vizuri. Dr. Esther, are you speaking? She seems to be online and open the mics. Why are we not hearing her? Okay, allow me to ask Professor Bantu to introduce somebody from... Yes, he wants to make an introduction. Go ahead, Professor Bantu.
Thank you very much, Dr. Mushiri, for those presentations. I have the honor to introduce you to one of our colleagues at Kyambogo University. Kyambogo University is in Kampala, and it is where the seat for the Inter-University Council is. I want to ask Prince Jessica, are you around? Can you introduce yourself? Hello. I saw you online, so I was requesting if you can introduce yourself so that people can hear you. And that will be okay. So, Jessica, are you around? Prince, Harriet, Jessica Harriet is a PhD student at Kyambogo University, and she teaches and supervises undergraduate students in measurements, assessment, and evaluation. She's the founder of Teacher Education and Professional Education Studies at Kyambogo University, and she is an expert in behavioral disorders, which she has been doing since she joined Chambogo University. Her current research interests include creating a smooth transition in different levels of education through quality student learning activities, and her research venues include universal secondary education schools in Uganda. So I think Jessica Harriet Oudo, you can, if you're on, you can introduce yourself further, and we shall be able to hear you. I also wanted to ask Laura, if Laura is there from Hamak University, to respond to some of the questions that were put across. Back to Dr. Mushiri.
So Lala, are you available? Lola, are you available?
Yes, I am available.
Okay, some questions are before you. So you, Professor Bantu, will bring that to you so that you can respond. We are happy that you're able to join with us. Now, there is a question on the chat again that says, you hinted that in the past cases were there and some mental disorders could emanate from such. I'm looking at a situation where relatives to a psychiatric patient believe their person has not and may not benefit from the medical and clergy interventions, and they want to take their patient to a traditional healer. How, as a medical worker, would one attend to such? That's a good question. So anybody can offer an answer to that? You have a situation where culturally people believe that the issues that you are going through are not going to be attended or resolved through the medical or spiritual platforms. They want to take you to a traditional healer, and you are a medical worker. So how do you deal with that? That's a good question. So Lala, I'm sure you can provide some art way of dealing with it, even as you start answering the other questions. And of course, this is not a question to Lala alone. It's a question to those of us who are here. How do you handle this? Because these are real issues. These are real practical issues that we are encountering. And the tea break is almost over, so we can respond to these questions so that we can go to the next presentations.
I think I can respond.
Okay, Professor Bantu would want to respond.
Thank you very much for that observation. One of the objectives of this dialogue is to identify strategies of addressing the social needs of mental health. And of course, we should be able to understand and acknowledge that conditions that resulted from the environment were treated based on the environmental variables that contributed to that. Yesterday, Reverend Dr. Kibara was talking about culture, and the African traditional life was colored by the belief systems. For example, in the past, if you had pain or you had a headache or stomach ache, what they would do, they would just make some herbs, mix them, and then they would give you. These cultural belief systems meant that people could be healed using the traditional herbs. I remember in our village, we had a man who was referred to as a fortune teller and rainmaker. You can imagine, you can be rained on if he says, be rained on. And the rains will beat you, will rain on you, while the rest of the people, the rains are not raining on the people, on the persons. So those ones are rainmakers and medicine men. And because of that level of civilization, people would always consult like rainmakers. Like if you are a bad man and you are organizing for a ceremony and they are not happy, they will call a rainmaker to cause rain. So it can rain the whole day. Then currently in some communities, if you do bad things, or if you store someone's property, someone can make bees come and beat you. Bees, I've seen some of these scenarios. Or if you are a very, you have a psychosexual problem and you move we move with other people's wives, or there has been some which they are called spells. Then you are caught and then you are ashamed, then I think that would be one way of stopping that kind of behavior. So all these were rudimentary means of handling psychological conditions. But they really helped, and people still practice them. And with the advancement in science and technology, we want to transit from the way of doing things to a more structured and professionalized way. For example, the Bible says, if someone grieves you, you forgive. But some have the capacity to practice that kind of approach. They can say, okay, let me try to forget. Others, it is very difficult because there are other, we call them vicarious traumas, someone has carried throughout his life experience, and then he finds these traumas again in his life. So it becomes necessary that people can be now taught how to forgive. The other day I was teaching about how to not get angry. And I said, if you get angry, what you should be able to do. For example, if you get angry, you don't kill someone, you don't hit someone. You can take a cup of tea. You can take water. You can even put water in your mouth and say, these angers, let me see how they work when I'm having water in my mouth. Also, check yourself in a mirror before you act. So those were practical ways of dealing with certain conditions. But in terms of culture, we need to do a lot of cultural interconnectedness. Because even spirituality, people used to go to the trees. There is a tree, when you hurt it, it gives milk. The milk oozes out. And people used to even to build some small things to worship. You find some food is served and it is under that tree. Whether it is going to be eaten by wild animals or not, but the person doing that act is satisfied, is psychologically satisfied that that is what is likely to happen. So, for us to transit from those cultural beliefs, we must have an orientation. We must work towards orientation and understand the circumstances that have caused our mental problems, and then we see, should we continue consulting healers or medicine men or fortune tellers. In South Korea, there are people who read the palms. They're called psalmists. They look at your palms and configuration in your hand. They say, I think your life is going to be very bad. And for you to avoid that, you need to come and we do something. And people have believed in those. So this dialogue is supposed to create an avenue where we can be able to appeal on the mental aspects, because you are what you think. You are what you think. Because if you think things cannot work, then they can't work. If you think you are bewitched, that is what becomes. So we need now to be able to destigmatize what people have gone through, either curses, and when you are accursed, you see people must pray for you, and those curses would be removed. We have also seen people who still believe in witchcraft. That's the nature. That's how we were brought up. I have been in Ghana, and at one time I met some people trying to exorcise. People have been bewitched, and they have horns. So a horn will be put somewhere, and then it begins to speak like a human being. So you put it in the fire, it comes out. You put it in. So in other words, these are some of the cultural orientations that we have been brought in. And that's the reason now we need to begin now saying, okay, if we collaborate, like in South Africa, there is a university which is having programs in witchcraft, death, and society. Why? The reason for this is to structure. If these cultural beliefs are still existing, and how they can be structured so that there will be an interplay or integration of spirituality, because also that form of spirituality, healing, and mental health, so that we are coordinated. There are certain conditions that can be treated psychiatry, using psychiatry. There are certain conditions that can be treated spiritually. There are other conditions that can be healed through psychotherapy. And that's the reason why this dialogue should be able to form an opinion. And this opinion could be geared into an institute, the Global Mental Health. Actually, in Kenya and Tanzania, we call it Global Salama Institute of Mental Health and Psychology. Now, this, since we are having a number of mental health professionals who are being trained, and in fact, I can affirm that in most of the universities within East Africa, all these universities have reached at a level of PhD. A PhD in psychology, PhD in counseling and clinical psychology. So these professionals would be able to articulate, would be able to dialogue, and the place where witchcraft, and the place where healing, and the place where mental health can be able to be taken care of. So I think listeners and viewers on our platform, it is important that there is a growing recognition of the significance of integrating psychiatric and spiritual approaches in mental health care. Because we cannot say, like someone will say, I have been healed. But maybe it is by chance or by grace of God. Then someone will say, it is me who has done it. If it was not me, I think things would not have worked. So we need also to be able to look at some of these and then apply them. You have heard of witchcrafts that have been witches, witchmen, they're called witchmen, witch doctors, who have been burnt in various places because of failure to do what they purport to have done. But you may find some of these witches, either they have confirmed to do something and yet no one has recognized it. We want to see as psychologists, want to see as medical doctors, want to see as psychiatrists, how and to what extent can these things continue to work. So I want to believe that within this dialogue, we are not going to make any mistakes, but we should be able to look at some of the very various factors that can contribute to our sickness and see how we can have strategies to promote awareness and understanding of mental health issues. And then we are saying with the faith-based communities, because the faith-based communities will really believe that they have done a miracle and miracles are there. So we want to see At one time, there was a cult, I don't know whether it's a cult or a spiritual, that they bring people who are disabled, and then all of a sudden they are healed and they get the healing. We don't ignore that, we don't overlook that, but we want to see those processes. Like if, for example, I have come and I'm a disabled person physically, and you have made my leg or my hand to operate well, I need to know the mechanisms. I need to know whether there is a biology behind that. I need to know whether there is a neuroscience related to that. So that now we can proclaim in our dialogue, in our International Dialogue Center, say, now we can affirm that so-and-so, pastor so-and-so touched and the leg came back to normal. And there are various things that were into play. In some countries, there are people who have used these disability, they become disabled so that they can be able to beg and get money. One of the risk factors, as we mentioned in Africa, is poverty. So in order for us to cope with the poverty levels that we have to do something strange so that people can know that indeed it is. One time in Eldoret, where I used to do supervision, we met some man who was having a placard at his back, and it was been written on "Madman." So everybody would see, really, this man is really mad. So we developed interest, and we said, let's find out really whether this man is really mad. But one of the things that were very key, he would just beg using signs. He would just point at you like this as if he wants to finish you. So you fear the finger, and then you say, oh, my friend, let me just give in, even if it's 10 shillings, Kenya shillings, and I leave and go. So we followed the person because the behaviors looked like he was cursed. The behaviors looked like he had an abnormal behavior. But at one time, he would be able to demonstrate goodness and fairness. He would not beat anybody, but he would scare you. Ultimately, we discovered that this man was trying to find a way of surviving. If we found him in the church singing, and then later on we had to ask police to arrest, anytime he would just come to beg. So there are a number of conditions that people try to present, and indeed when you look at them, you say this one is really not being honest. However, there are other conditions like schizophrenia. Like there's one particular one which is called catatonic schizophrenia, where someone will be disturbed by a number of conditions and you'll find him standing still in one place. Even if the rain is come, he will not mind. So the person is just there. So we cannot begin claiming that this one was bewitched until we get a clinical assessment from a psychiatrist. And then we say, okay, this was neglected, and these conditions were not taken care of, and as a result of this, this is what has happened. So this dialogue is supposed to bring in place a scenario where we can go to all the streets in East Africa and find these people who are neglected, people have things they have collected, and we see, why isn't that the clergy does not care about picking these and putting them in the church and saying, this one we have to pray for them? Why must they wait for a miracle to happen within the church? I would like a situation where we can coordinate and say, okay, on Mondays we are going to pick those men who are harmless. By the way, there are men and women who are harmless. They are in their own world. And we say, okay, let's first put them in the church and pray for them. Or let's take them to the psychiatrist in the hospital. Or let's take them to assess. And these things can only be worked on when we have a mental health facility, recognize it. And that's what we are talking about. That will create increased awareness and understanding of these people. These people who are moving out to look for work outside, they are trying to solve the problem of poverty. And if we can structure these things and put them into perspective, we shall not have any person suffering or trying to put himself in a situation that is sympathizing, causing people to begin thinking, this one is cursed, this one was bewitched, this one, you remember, the father told him this and that. We want to work together as a team, of psychiatrists, as a team of psychologists, and a team of clergy. You will notice in Africa, we are a Christian continent, the biggest number, and religious continent, because we have also the Muslims, we have the Buddhists, and all that. So why don't we work together? So this forum is supposed to continue debate in a more structured way so that we can provide the best approaches, the best interventions, which of course will inform policy and will help governments to sort out most of these issues. Thank you very much. Back to you, Master of Ceremonies.
Thank you very much, Prof. Thank you, Professor Edward, for the depth of expression of the things that we need to consider, even as we make certain conclusions. And I see some people putting, of course, some questions on the chat, and I would want them to, some of these to raise. Jason, are you able to speak out and ask this question about religious affiliations and traditionalists?
Yes, I am looking at such a patient, a scenario. You have a patient, they have their beliefs, they belong to families, maybe...
Just a minute, we get adjustment of the volume so that we can hear you. Jason? Just a minute.
Hello.
Hello? Go ahead, adjust that for him to be able to be heard.
Okay, thank you.
Okay, go ahead.
I'm looking at a scenario where you're faced with a patient who family believes has been bewitched somehow or cursed in some way, and surely they are psychologically sick. And they're in a hospital, maybe they were brought by, maybe to be restrained, but somehow at the back of their mind, they believe that maybe they could have been helped by, say, appeasing the ancestors, attending to the ancestral beliefs. They have their beliefs, they are not affiliated to any religious doctrine, but traditional beliefs. So we bring in aspects of medical, psychosocial support, and the religious support, and maybe a month or a week. I mean, as time goes on, they feel they are not improving, and they want to ask if they can be left to also consult their traditional, maybe ancestors. So psychologically, how would we attend to such a situation? We have been with them in a hospital setting, we've had the medical interventions, we've had the religious interventions, we've had the psychosocial support, and now they are bringing an aspect of their traditional faith themselves. They have a faith that they believe maybe could also help them. How do we attend to them? Thank you.
Thank you for that question. Is somebody looking to respond? This is a dialogue again. It's not left to yes, Bishop Alice. You want to give our response?
Thank you very much, Muchiri. I may not provide a very final answer to this, but as we are dealing with mental health, we are actually dealing with the state of mind of a person. And believing in a traditional ritual is also a state of mind. And someone who believes in that, I think unless they are first of all delivered from that kind of a state, they may not be able to accommodate something else. I have also served in a hospital as a chaplain for actually 10 years. And these are the cases we encounter there, and there are people who cannot receive the medicine or the medical help that they are being given simply because they believe in some attachment to some traditional issues and whatever we may actually describe them. We also have people who are Christians and they believe in, they don't believe in medicine. So this is actually a state of mind that needs to be delivered first so that someone can be able to accommodate something else. The one who asked the question says they have had also spiritual interventions. I think this is where we need everyone, including counselors and psychologists, to help change the state of this person's mind. They are actually sick. I believe mental state or mental health that doesn't only involve someone who has thrown away the clothes, someone who has gone out into the streets. It involves anything that alters your right thinking and holds you hostage to that. So that kind of a person is unwell, not physically but mentally, and they need to be delivered from it. I think they may not even take anything, but once they are delivered and they are assured that there is maybe a God who can replace that which they believe, I think they can receive help. Thank you.
Thank you very much, the Bishop, Reverend Dr. Alice, for that observation. I think the question that you have articulated is quite well, and I think the participant would wish to know what could be the overall role of a witch doctor in relation to spirituality, mental health, and healing. Of course, these beliefs need to be demystified. Spiritual healing in terms of witch doctors, they often operate within belief systems that attribute illness or disturbances to spiritual causes such as curses, malevolent spirits, or imbalance in the spiritual realm. Like we went to interact with witchcraft in South Africa. They would get a small bucket and then go and pick some leaves. I think in their language it's called muoko. The green is like a vegetable, and then they squeeze. When you squeeze, the liquid is so thick. And when you come, they will read your mind. They say, I think something must be disturbing you. And when you agree and acknowledge that indeed something is disturbing you, they will first of all relate to the neighbors, your neighbor. Then you say, can you tell me if you have quarreled with your neighbor? They are reading your mind, so you'll still continue to tell them, okay, yes. Now, if anything happens, and maybe you break a leg or an arm or something happens on your body, and you are taken to a hospital, for example, that belief still fills your mind that someone must have done this. It's not a congenial cause. It's not a real cause. Someone must be responsible for that. And that's the reason why the witch doctors, they may perform rituals, they may perform ceremonies or spiritual interventions aimed at restoring harmony and balance to the individual's spiritual well-being, but still there's need for connectedness. Is it true? Can this be possible? So that now we can apply what we call mental health support. Because why should a witch doctor want to do things alone? Why should a witch doctor ask you for certain animals with certain colors? Why should a witch doctor want to perform certain rituals independently? So this dialogue now is saying, okay, let's now try to be together. We have the spiritual support, we have the mental health support, and we also have a holistic healing, because I've seen in some communities, and especially some religions, that do not accept medicine. And doctors have a lot of problems with that. They have identified that this condition is like this. But because of that belief system and the orientations that these people have been told, brainwashed, because, for example, I'm not a medical doctor. I can't treat medical conditions. But I have the opportunity to analyze, to assess, and say, I think, doctor, if you work yourself, you will transform the lives of others, but you will be at your disadvantage. And then the doctor will see the many hours he puts in to work, and then he says, let me now follow what the psychologist has said. Relaxation techniques, drinking enough water, eating on time. Those are basics which can really be able to improve. So this interconnectedness will help us to address some of the spiritual issues, healing issues that interfere with medicine. Because I'm aware that most of the people say, I need to be prayed. I want to give you an example scenario. Here in Eldoret, Moi University Referral, Teaching and Referral, in 1990, I went to this hospital and they brought a very elderly man, almost on a stretcher, not even talking. So, but when this man was put in the hospital, after realizing that the bed he was going to sleep on, someone had passed on, they say he just woke up and walked out. So the student I was supervising asked me, excuse me, what happened? Wasn't this man on a stretcher? Then I said, maybe God has done a miracle. God has done a miracle. Because, and indeed, God used to do miracles. He told the man who had been put on the, struggling with life on the well of Bethesda, he had been there crippled for 38 years. And when Jesus came, he said, what do you want me to do for you? And the man said, I want to walk. And indeed, by command of a word like this, Jesus said, okay, pick your mat and walk. So there is a kind of mystery that needs to be dialogued, that needs to be talked about. What is it that we can be able to do things together and in a more structured way? That's why one of the universities in South Africa is organizing a team, traditional healers. You have heard about some of these things. What is the magic? What is the nature of the spell? That someone has been caught together with someone's wife or husband and they are stuck together. What is the magic? Can we really be able to have scientific explanations? Can we really be able to work together as a team? And of course, healing, holistic healing, which doctors typically approach healing holistically, recognizing the interconnectedness of mind, body, and spirit. And that's why I said they must ask you certain questions about your life. And they may use a combination of spiritual, herbal, and ritualistic interventions to address a wide range of health concerns. I also visited, unfortunately, I've been visiting some of these people in Thailand. You know what they would do? For them, they even have ways of how they can carry spirits. They can come, see where you are seated or standing, they pick some dust, and then they say they have carried your spirits. And indeed, people have those belief systems. That when I see you, when you spit your saliva, when you do what, and by the way, in our traditional African society, we would bless people by touching them on the head. The elders would just touch your head, and then in your head you know, I am blessed. And indeed, those kind of practices really helped. So, these ones, they mix. I've even seen visited you find a witch has a Bible, has a Quran, has even other books. And then he tells you, sit and look into that corner. You know, there are holes, they do some of these things in holes, like this. So they sit you there while they are trying to do those kind of things. So, but we are not saying that is bad. Let's try to see and work together. Which doctors often hold esteemed positions with their communities and serve as custodians of cultural knowledge and traditions. You remember, even in the Bible, Jesus was telling the people that this thing cannot get out until there is fasting and prayer. Mm-hmm. I want us to do these things together, to do a coordinated integration, so that when we are practicing some of these things, we can tell the public that, you know, so and so ate stole someone's cow, and then we put a spell on him, and he was seen eating grass. Have you seen some of these scenarios? You steal something, you are carrying. You steal a TV, they bring you. You go to someone's banana plantation, you cut a banana, your hand remains there. So we need really to see, we really need to see these complementary care. We call them complementary care. And that's why the doctor now needs also to be versed with these cultures. When someone in the hospital decides that, no, me, this thing cannot be removed, let me go back. And indeed, psychologically, when someone says, I'm going back home, when he reaches home, you find he has healed, maybe by God's grace, or he has healed because that belief system has healed him. And remember, the spiritual aspect emphasizes a lot on faith. Go and your faith has done what? Has healed. But what is this faith? The faith is in the mind. The faith is in the heart. The faith is in the whole body. So, members, I would like us to do justice to the wellness of our persons that we heal by integrating psychiatric and spiritual approaches for enhanced mental health, an international dialogue. And I think we have called it, let us see in the Western how they treat aggressive behavior. Let us see in Europe. Let us see here in Africa. And then we see what we really can do to bring wellness and care. I think basically that's what I can be able to say. Thank you very much. We are now going to plenary session. And I think Professor Peter Baguma, I'm not able to reach him. So we may have to go to the plenary session. And the plenary session, I would ask the Master of Ceremonies to introduce, but I see some readings again on the chat, which he can be able to share as we enter into this plenary session. Thank you.
Yeah, thank you. I think this is Jason who is appreciating that elaborate and varied scenarios to handle the situation, and he says it's interesting. Did anybody want to add to what the conversation? Again, I am saying this is a conversation and the dialogue, as the professor has emphasized very many times. Anybody who wants to contribute to it, either here physically or people who are here physically or people who are online or following online and we want to contribute to this discussion. Yes, take the mic, introduce yourself and proceed, yes. Tell us your name so that everybody knows, because they're not all seeing you, and then you proceed.
Thank you. Good afternoon, members.
Good morning.
Still morning, good morning, sorry for that. My name is Mugambi James. I am a psychologist and a psychiatric clinical officer from the Kenya Medical Training College, Meru campus. Thank you for the organizers of this conference. It's really timely, and thank you for this opportunity. For me, I wanted to give a comment on our colleague who was responding to Professor Cullen's presentation on the role of digital health. I wanted to just comment and say, yes, the government has recognized the need for that to be formalized. There is a Kenya Digital Health Act of 2023, last year. I think it's still in the phases that the acts go through the parliament and other regulatory bodies for approvals. And if you can download that act and look at part 7, there is a component of e-health service delivery. And this one is breaking down all the components of the kind of services that shall be provided under this regulation. This includes telemedicine, electronic health records, e-learning, m-health, telehealth, and any other services that are recognized as e-health services. So yes, it's true. I know most of us who are even doing psychotherapy, we might have done that virtually. People are still doing it online, especially during the times of COVID. But now there is a policy that is coming to regularize it. So it will be a formal health delivery model, like the physical visit to a healthcare system. Now that means even the companies like insurance companies will be compelled to actually be able to maybe reimburse or cover you, whether you went to a physical psychologist or a clinician, or you went under session via digital means. So that's my comment on that. The other comment maybe I would like to hand is a topic that was very interesting, as enumerated by Professor, on the role of clergy. I think for me this is a topic that I am very interested in. I have been in discussion with my colleagues in the past, actually last year, including our very own Dr. Monica, she's not around today, on the role, on the role of us in the mental health sector collaborating with the clergy. And this is an area where we need to really focus on. And as Professor said, in Africa we are quite spiritual. And I can assure you most of the clients that we see, whether in the general medicine or even in mental health, they will have gone to a clergy first before coming to the hospital. And even when they come, they'll still keep on getting interventions in between. So how is it that we ensure that whatever other interventions is happening between the clinician, the psychologist, the psychiatrist, and the clergy is in tandem, so that we do not confuse the client or the patient, and also so that we pass a message that is directional. So if you allow me, I can quote from a very renowned source on this same topic that I found while I was researching on the same collaboration. This Reverend Professor Christopher C.H. Cook, who is an ardent scholar in matters spirituality and psychiatry. He is an ordained Anglican priest with a master's in applied theology, and he is also a professor of psychiatry at the Durham University in the UK. And he says that the training of the clergy has stretched many other topics, including service matters, systematic theology, church history, biblical studies, ethics and pastoral theology, liturgy, and more. Within this, mental health typically occupies very little space and rarely ventures beyond the pastoral theology classes. Yet, these are the new priests and deacons who will be presented with a lot of questions that are mental health in nature by their congregants. And sometimes they may be ill-equipped to answer this or help in the appropriate manner. So Professor Christopher opined that this kind of collaboration between the clergy and the healthcare workers, especially in mental health, need to be more profound, so that even if it's the theological colleges, do they have a strong component on teaching the clergy on mental health? Because, as we say, basically most of the things that our congregants present with are spiritual in nature. They are mind-based. There are issues that they are not able to deal with in a formal way. So they are psychological. So for me, this kind of component in this conference seems very timely, and it's good to also note that other people are still thinking of the same, and I think it's about time now we have a formal integration and a way of actually doing it en masse, and then getting our clergy to collaboratively work with the people in this service delivery sector of mental health. I think that's what I can say, and I thank you for the time.
Thank you very much. Thank you, Bwana Mugambi, for that very good contribution, and also to respond to Jacinta's question earlier on the telemedicine and telehealth. That was kind of you. I think, like you have indicated, the collaboration is timely, it's necessary, and perhaps to begin to ask whether the two professions may want to add component in terms of curriculum training to either way. And probably the clergy can say that, those who are here, those who are training. Psychology, I am sure it's part of what you offer. I'm not sure to what extent, like he says, how to what extent, because it's true, especially in our setup. Many people will come to you with issues that are bordering between, psychology or mental issues, and you have to respond because you are the first person they come to. Like Professor Bantu has said, it's probably your responsibility as a clergy to identify when the person requires or would be sorted by, the issues, the spiritual part, and when they need to be referred to the other professionals, like psychiatrists, the psychologists, and so on. I don't know, maybe this is a discussion that you may need to hear more so that we can continue this dialogue. This is the concept of dialogue. I see Reverend Chebere want to respond. Reverend Chebere, you can go ahead.
Thank you so much. I think I really want to add on what others have said on this topic, because you realize that it's not automatic that you will know the extent of each and every individual, but what there is that there should be some kind of an exchange between maybe the counselors themselves and also the spiritual leaders, especially in cases where maybe the problem you are dealing with has had some kind of extended maybe time for people to know really what is needed in each and every individual. But what I would like to add is that as Professor Bantu has hinted and others have also contributed, there is actually something very interesting as it relates to the African cultural context, because these are areas that very many people are not sensitive around, bearing in mind especially the problem that people usually have, especially with regard to what is regarded as traditional. And when you are dealing with matters spiritual, you also want to do things in a way that it doesn't appear that you are promoting something that will be actually regarded as unchristian. And we have that problem, and I've not heard maybe someone talk a little bit about the relationship and how far you should go and not go, because why is it that people, and I can see now that like Professor Bantu, I would like to hear even some response about that, where if really these things happen, like in the traditional setup, like how you catch a thief or something like that, and you believe that these things really happen, what kind of intersection do we need in that case so that people are able to be helped from the spiritual point of view, but also not maybe neglecting the cultural understanding on the same? And is it possible also to have traditional healing that is specifically traditional and cannot be regarded as spiritual or otherwise. Thank you.
Thank you very much, Reverend Douglas. I think in our session and in our dialogue, it's very important to understand the role of witch doctors in healing. And we should be open to each other that witch doctors is a cultural aspect that we have been brought in from the African perspective. Even in the US, I've seen a number. We had one professor who lost her laptop, and the laptop had very valuable things. And the first thing she asked us at Makerere University said, "Do you know of any healer?" Now, when they're talking about a healer, automatically it means you need to have knowledge about someone who can do something about the damage that has been done. So we need to be able to look, this dialogue should be able to have an overview of the historical and cultural significance of witch doctors in various societies. I want to give you a case scenario. And this case scenario, I'm just using Jane. I know I'm not talking about Dr. Jane Marete, but I'm just anonymously using the name Jane. A 35-year-old woman from a rural community presents with the symptoms of anxiety and depression. She reports feeling overwhelmed by family responsibilities and experiences frequent panic attacks. These panic attacks, if you go to the hospital, the thing they can do is to first get samples of your blood, first take history, and they may not be able to know that you might have gone through traumatic experiences or you are being battled through domestic violence. For them, they believe that there is an impairment within the blood system that is creating that. So, the spiritual person will not discover. The doctor may not also be able to discover, but the psychologist can be able to discover this. So what happens, the intervention is doing a holistic assessment. And basically in African tradition, a witch doctor conducts a holistic assessment considering the symptoms of Jane, panic attack. And that's why in most families, in couples family counseling, when the woman or the wife presents such kind of things, panic attack, they ask, "Have you been battled?" Then the woman will say, "Yes, my husband beats me every time I am at home." And in our African tradition, in some cultures, if you don't beat your wife, that means you don't love the person. In some cultures, I'm being told that you have to beat your wife at least once a week, or quarrel or rebuke, to show that you are really, you are there. But now, what they normally do now, they have to do they counter those kind of scenarios. So what they do, they go to a witchcraft. Actually, they use natural methods. How many of you are ignorant about a plant, you touch, it closes? What is the science behind that? So they go, I'm told there is even another weed. They go and say, blackjack actually, that you put this blackjack, if he comes fighting, quarreling, you put it and you don't talk anything. Or you put some of these in the food. So when he comes the following day, he will not be able to do what? To shout at you, because blackjack, that thing keeps him numb. So there was a kind of connectedness. But as we are saying, let us do a holistic assessment, just like medical doctors do. By the way, one of the secrets that medical doctors do is that they will not treat the person until they say, go here, bring this, go here, do scan, go here. They will never. And that is the basic way. So we are also saying, okay, let us look at the presenting concerns this person has come with, psychological concerns. And then when we have done that holistic assessment, we ask if someone has had emotional distress, like now we have talked about that, the distress of Jane. Then we do what is called, we ask, have you ever used any herbal remedies? So herbal remedies, like for example, the witch doctor, what he does, he prescribes herbal remedies known for their calming and mood stabilizing properties. He will tell them, now you go get this, carry this, put here, and in all these setups, such as tea, they are, you know, there is herbal tea. You have heard about herbal tea, which is mostly used even in China and Japan. They know the root, the valerian root. There is another root. These days in some communities, men use that root if they have to get their male strength and all that. So there are some of these kind of herbs, and that's why I'm encouraging the School of Medicine and medicines in our country and in East Africa to make use of the herbs in the forests that are surrounding us. They are medicinal in nature. And most of the witch doctors, actually, you see him go to the bush, collect some of these herbs, and then he gives them to you. So there should be enough research by our medical experts to try and psychopharmacovigilance and try and come up with some of these herbs and how they treat. During COVID-19, almost every tree was tried. Every herb was tried. So for us to have a holistic kind of intervention, we can use herbal, we can have ritualistic interventions. I want to say that even in the Bible, Samuel, Saul was affected so much. And what did he do? He went to consult the spirit of Samuel. But in the absence of caregivers, people who can listen to you and understand, it becomes very difficult. So this dialogue is supposed to have that center so that we have a section of these people and we ask them. We can invite them and tell them, excuse me, how is this done? How do you do it? And by the way, some of them will tell you even the lies they can put so that you can be convinced. They will tell you, this one, when he comes, I know of another professor who had cows, very good cows. And because he was very stingy, he could not give out anything. So the workers connived and went and dug a hole in the place where the cows would feed. So they built, then they put somebody there. So these workers came and told the professor, for you, I think your cows are going to die one by one. But because the professor doesn't have time to be there, so these workers started selling the cows one after another. And then when they called him, that you see, we told you, this thing is happening. So they had put another person in the hall, and then they told him, let's go and check and you will see. So the professor came, and then there was somebody in the pit, and he was talking, your cows are going to die, all of them. You better give me the other cow which is big, and I will help you out. Then the professor, of course, he doesn't see where the voice is, because already he's stressed, because the professor is worried that the cows will be off. The professor has anxiety. So he said, okay, which one? The other one which looks like a lion is the one that I want to take. Then if you don't bring it, so you can imagine the psychology of the people, the psychology of these people doing, you can imagine that if we don't get together, was it true? Actually, later on, he found it was a person. This information leaked, and those guys were handcuffed and taken into prison. So it's very important that we really do work together, we integrate these services so that we can be able to help out. The Reverend Douglas was asking, we need to articulate on some of these things. The dialogue creates knowledge. And yesterday, one of our colleagues mentioned that, I think it was the chaplain for Karatina University, in the book of Hosea, that my people are dying because of lack of knowledge. But now you have knowledge in the institutions of learning. You have knowledge everywhere in the society. You have knowledge. And the Bible says in Daniel that towards the end of life, knowledge shall increase. And then in Timothy it says, study to show yourself a workman approved of dividing the word of truth. So that's the reason why we are here in this dialogue and saying, yes, this clergy, and they are really talking about the things that really affect us. So with those kind of remarks, and since we have a number of our colleagues, the French-speaking countries, I would like to invite one of our key translators to provide a background where we have reached, so that he can be able to let our colleagues in the diaspora and those who are speaking French to know where we are. I want to invite you to provide where we have reached. Bwana Duncan Kyogora, you can brief our viewers and our participants in the French-speaking countries about where we have reached in this kind of dialogue. Thank you.
Thank you, and we continue to acknowledge those who are joining the online platform. I see Dr. Caroline, you're already up. Thank you, and thank you for joining with us. We have a short interjection of the session by having a little bit of the French so that the French speaking can also hear. So a little bit of that is going to be happening now for a moment. So Duncan, please take it over. We are happy that people are with us and are following.
Alors, bon après-midi. Donc, nous allions parler sur ce qui a été présenté aujourd'hui. Donc, nous avions une présentation sur une recherche qui a été conduite à la communauté de Kisii au Kenya. Donc, l'arrière-plan, la communauté du Kisii au Kenya, comme toutes les autres régions, face des défis dans les soins de santé, qui fassent les travailleurs de la secteur de santé. Donc, ces travailleurs ont le stress, il y a aussi les santé mentale, et ça c'est à cause de la nature de leur travail qui a été exacerbé pour les ressources limitées et aussi les systèmes soutien. Dans les années récentes, les technologies numériques ont été élevées comme les systèmes potentiels pour adresser quelques défis, pour offrir aussi des opportunités de l'accès de l'information, la communication et aussi les systèmes du rapport par rapport des soutiens de la santé médicale. Alors, la proposition de la problème, alors, on a beaucoup des avantages potentiels sur les technologies numériques au sein de la santé médicale et aussi la santé mentale à la communauté du Kisii, mais ça déjà est peut-être pas clair et il y a un besoin d'évaluer comment ces technologies sont intégrées dans le système de la santé médicale et comment aussi ça peut affecter la spirituelle, la mentalité et le soin médical des travailleurs aussi. Encore, il y a aussi le besoin d'explorer le potentiel d'intégrer la spiritualité psychiatrique dans la santé médicale et la santé mentale, et aussi la solution qui peut offrir les besoins des travailleurs dans ce contexte. Puis, la justification de cette recherche. Il faut comprendre l'impact de la technologie numérique au sein de la santé médicale et aussi donner comment on peut améliorer la qualité de la soins de la système de la comté d'Ukisi. Alors, il faut aussi évaluer comment on peut intégrer la spiritualité psychiatrique et aussi comment aussi intégrer tout le monde pour développer les interventions pour soutenir cette étude et pour aussi améliorer la comté d'Ukisi. Il y a quelques scénarios du CAS. Le premier, c'est donner la plateforme de soutien digital et numérique. Ici, on peut prendre un exemple d'une imprimateur qui travaille à la comté d'Ukisi. Okay. Alors, pour cet travailleur, il y a beaucoup de stress. Il y a des accès limités de ressources quand elle travaille avec ses collègues à l'hôpital. Deuxième exemple aussi, il faut intégrer la soin spirituel pour cet travailleur parce que à l'hôpital c'est très très occupé et il faut aussi connaître l'importance d'adresser cet besoin. Alors, ce qu'on arrive à la fin de cette recherche, il y a quelques expectations, trois expectations. Le premier, il faut avoir une recherche et une recherche détaillée. Deuxièmement, il faut avoir les programmes d'entraînement. Et troisièmement, il faut aussi arriver à une recommandation du poli pour
merci beaucoup.
Le gouvernement.
Merci. Thank you very much. Our colleagues from the diaspora, I would like to ask Professor Caro, who's in line, to make her presentations, and then we can move on later on with the communication in the other language, in French. Professor Caro, are you around? Can you present?
Yes, Professor Bantu. Thank you very much. I appreciate it.
Thank you.
Can you see my slides now?
Yes. Proceed.
Okay. Do you see my presenter view or? Okay. Okay, perfect. Okay, give me 1 second. Do you see my notes or the pictures? Just the pictures?
Yes, we can.
Sorry. The notes or just the presentation?
We can see the
Just the
presentation.
presentation.
Yeah, we can see the presentation.
Okay.
Yeah.
Okay, sorry about that. Okay, thank you very much. Sorry. Okay. So I just want to thank you all for having me here today. And also I want to thank Professor Bantu for organizing this event with Vice Chancellor Kinori and for allowing me to be here today. It's been it's a very big honor for me to speak to you all. So I just first want to tell you a little bit about my background and what drives me to do what I do. And so my sister, when I was 12 years old, my sister, this is, I'll probably introduce my family first. So this is my family. We used to live in a very small apartment in New York City. And my sister and I, we actually shared a bed because my parents, many of us in an apartment in New York City were very poor. And so I was very close with her. And unfortunately, when I was about 13 years old, my sister was 20 and she had just moved out of the house. And soon after, my sister, she died by suicide. So for me, at the time, it was I did not understand what that word meant. My parents also didn't understand what suicide meant. For them, it was, they were ashamed. They just didn't know how to process what had happened. And so they told me, they told me to tell the people that she died by car accident. And so imagine you're 13 years old, you're processing your best friend's death, your sibling's death. You don't understand any of this. You're going through your own hormonal changes. And then on top of that, your parents are telling you, you can't even mourn her death properly. And then on top of that, you don't even understand what happened. So for me, my parents, because they're very traditional, they're from Colombia and Chile, and so they're very they had a very different view. And I think now coming back to them with the information that I know has really helped them, I think, to process what had happened to my sister. And so for me, I just couldn't understand why someone like, my sister, who was always helping the community and helping everyone else, that this could happen. So, and for me, it was a lot of my Christian values. It's tough because there's this, there's this thing where if the person does this, that they go to hell. And so I remember seeking this spiritual journey, and I finally, came to realize that, that they would understand, that God would understand that she was indeed, sick and stuff. So one of my journeys has been through, I remember when I was younger, was trying to find a note if she left it to understand why she did it. And I never got that note. So part of it, so I turned this personal grief into a relentless drive for answers and action. To understand, because the psychology, the theories behind it, I wasn't satisfied with that, because I'm like, no, that's more of a belief. I need to see empirical data. I need to see biological factors and see what's really happening. So, so this has then drove me then to start a lab. Actually to do research in the brain and to understand how aggression, what's the biological basis of aggression. So you have aggression against others, and then you have self-aggression, which is very impulsive behavior. And so what I do is I look at how does the brain compute this? How does the brain process this information? And then you have this output in behavior. So, first question is like, what is aggression? Okay, so aggression, is a conserved behavior. As you can see here, it's conserved through species. And it's, aggression could be a good thing, because you need it for acquiring food, territories, mates, also protecting, like for defense. And so it's this innate behavior. It's not a learned behavior. It's an innate behavior with a biological basis across species. And so in humans, what happens is that the frequency actually of physical aggression in humans, it's at the years of like when you're a toddler. And there's this like societal, like belief that, males are more aggressive than females. And actually, even during the toddler years, it's not true. They're both aggressive. And so, eventually through the years, this declines gradually. Because then what happens is they learn to develop self-regulation. So, and that usually doesn't happen till you're late, I would say in your late 20s. But even then, like there's still some, sometimes depending on any other factors that can, that can go awry. So it's very important, I think, to understand that, and also to understand that male aggression is just as important as female aggression. And so males, there's this social norm or social expectation from society where, males are more aggressive than females physically and verbally. This is from the 1970s. And then later on, they correlated that indeed there's like this called like a sexual politics, right? Where the cultural norms and expectations is that boys must be more aggressive. They're the aggressor. And so that is in a way, it's just showing and setting up. Sorry, let me just unmute. Oh, my goodness. Okay, sorry about that. Okay, so in a way, it's just a way for, I think that when we do research, a lot of times people were investigating more male aggression and assuming it was also the same for female aggression in the circuits. And so, I'm going to talk about also, so what are the brain structures in the human brain that have been implicated in aggression? And so what we understand is that the limbic system that you see here is the area actually where we believe that is responsible for the process of emotion regulation, specifically the amygdala, where I think Professor Kessler will talk a little bit more about that. Talk about the hypothalamus, and it has also the hippocampus, which is the memory region. And so we know from like rat lesion studies, they suggest that aggression could be controlled by many of these limbic sites, okay? And so with the prefrontal, you have, and also there's also this, some of the circuitry that we, from our research, and most of the research is done by lesions in animals, and then they see the change in behavior, and then they assume that area is involved in this behavior. So one of the other culprits is the prefrontal cortex. Between the prefrontal cortex and the amygdala, this circuitry is in aggression, and they believe that it's this altered circuitry to aggression in neurobiology. And so a lot of these key regions are involved with executive function, processing, and understanding of more of a, and also with the basal ganglia, with the movement. And so here I'll tell you real quick. So one of the biggest areas that, people study when they look at aggression is the amygdala. And so here's a study they did with monkeys where they saw that the removal of the left and the right amygdala in the rhesus monkeys, they saw what they observed, this reduction of fear, anxiety. They saw this hypersexuality was also reduced, and they saw like this really strange change in behavior. So then these changes in behavior, then that is where they say, okay, so then this area of the brain must be involved in this behavior. So there are, different types of aggression. There is what we call predatory aggression, which is more, I would say, it's characterized more by, stalking with few vocalizations, pursuit, pouncing, biting, or killing. It's reduced activity in the sympathetic division of the autonomic nervous system. In humans, predatory aggression may be applied, it's more metaphorically. It's more involves more premeditated individuals who display this aggressive or exploitive behavior in pursuit of it's like a personal gain or some type of sense of reward. And where it differs from what we call like the effective or reactive aggression, where here you have a cat hissing, arching its back at the approach of a dog. So it's more about, it's characterized by this intense emotional arousal. And it's more because they're perceiving threats or frustration. It's more of a reaction to something. So in humans, that would be, you know, like the effective aggression could manifest itself as more as a frustration or irritability in that moment. And it could be triggered by the fear and self-defense. So there's a clear distinction between functionally relevant aggression that's used for, you know, shelter, like mates and stuff. Then you have the more, I would say, like the dysregulation of aggression, which is common in many psychiatric and neurodegenerative disorders, where aggression is actually a problem. And the high prevalence in psychiatric disorder actually, so many of the psychiatric disorders that see aggression as a symptom, the females actually are much higher than the males. And so it's, you know, it's one of the reasons why I always talk about it's important to study both sexes when you do animal model research. Suicide, for example, even though more males die by suicide, at least in the US, more females attempt suicide more often than males. So there's more of this is like they see more of an impulsive behavior. And what's also very interesting in my research is that so aggression is actually an initial symptom of many neurodegenerative disorders. This is something I actually did not know. And until I started doing more work with aggression, and also because my dad was diagnosed with Alzheimer's, and I saw this initial, like something that was not there before, I see this like output in behavior. And so you can imagine that this, you know, like this pathology or this disease ongoing is now no longer inhibiting the sorry about that. It's no longer inhibiting the areas of active, you know, of how to suppress, you know, this anger or how to process this. And so for us, it was very interesting to also so another interesting observation is that dementia is actually 2 times more prevalent in females. We don't, you know, I think that they're still trying to understand why that is, but it shows you how sexually, in the hospitals, they use, I'm sure you guys also use it. It's a very old medication, haloperidol. So it's like a very, they use it to calm the person down or to sedate them. And that's like most of the medications. It's more about taming the symptoms. And so what we find is that people, let's say, for example, with people with dementia, instead of, because when they give these type of medications, whether it be an antipsychotic medication, it really does dampen the person's activity level. And so somebody with dementia, the part of that is you have to maintain, because you're trying to fight against the progression of the disease, and you have to maintain an alert. You know, you have to be cognizant of things that are going on and be more alert and do some exercise. And so if you're numb and you're sedated, it's kind of like, you know, it's not really the disease is going to progress much longer. So part of it is like my work is to try to understand why isn't, like in a disease where the brain, you know, certain areas are dying off, why does it have this robust output of behavior? There's other, you know, some other factors also that are causes of aggression. For example, alcohol. It unleashes, you know, it's very common psychotropic contributor to aggressive behavior. It disrupts normal brain function, and according to, you know, the disinhibition of this, you know, of these areas. And so what, you know, a lot of times the evidence implies that this, you know, the alcohol ingestion, when it increases aggression, and they're seeing that at least 38%, at least these statistics are taken from the U.S., and 38% of the convicted murderers actually were intoxicated at the time of committing assaults that led to murder, and 40% reported sexual assaults are committed by perpetrators found to be under the influence of alcohol. So, as like just now now knowing all of this, right? Knowing all this, it's like, okay, so how do you study aggression? Like how do you even go about looking at this behavior and going into it and trying to unravel how the brain computes this? So like I said, aggression is this, it's a conserved behavior. It's also, it's very robust. It's quantifiable. So you can, for example, I use the fruit fly system where I can quantify, after I manipulate the brain, I can quantify how many times one fly hits the other fly. And then it's also reproducible. So so the aggression, because it's an innate behavior, you can initiate like fights between the animals, whether you have either like a piece of food or some type of motivation. And then from there, you can then go on and you can quantify the behavior. And then you can go ahead and look at, in the brain, like how does this behavior, how is it computed? And so, and what's interesting is like, even though we have some clues, we still don't have yet a full picture of how the whole circuitry, meaning like how does the brain process the information, where does it go, how does it get integrated, and then how do you have this decision to be, or is it impulsive, for aggression? And so, and what makes the fruit fly, so just to give you some context, there have been 6 Nobel Prizes in physiology and medicine that have been awarded to fruit fly research. So a lot of them, they found many of the genes are actually conserved in fruit flies. It's also it's a smaller, so you're not dealing with millions of neurons or billions of neurons as you do with the human brain. With fruit flies, you're dealing with only 100,000 neurons. So that's why we use it. And so there's also easy genetic manipulation. We have many readily genetic lines that we look at. And we also have a lot of large library of mutants. Also, the other part, the advantages of using the fruit fly model system is that it's actually very cheap to use. And looking at the behavior is something that you can readily do easily anywhere in the world, where you just take the fruit fly, you put it in a small, like a clear container, and then you can just easily record it with your phone or whichever, and then observe the behavior. And then you can ask different questions. Like you can say, what if I put, this type of, let's say inhalation of alcohol, how does that modify the behavior? And so the other thing too is that, so Google had paired up with Janelia, which is one of the big institutions here that looks at a lot of animal research, and they managed actually to map out the brain. So what they did was they took a Drosophila brain and they did EM data, so to the synapse of the neurons, and they were able to map them out and trace them. So then you're able to then say, okay, this cell is connected to this cell, to this cell. So then it gives you like an unprecedented way. It's like kind of like a brain GPS of getting down to the system, to the cells. And with the fruit flies, the behavior is so well characterized, so you know what to expect. And so let me give you some history of actually aggression in Drosophila. So it was actually first reported by the scientist Sturtevant in the 1915s. He's observed that the fruit flies had this really particular behavior, the aggressive behavior. And then later in 1970, investigators defined like some of these behavior patterns. It was interesting because they were sex specific. So the males fight one way and the females fight another. And these are behaviors you can quantify. And then in my lab, where I did my postdoc with Professor Kravitz, his lab, what they observed was they actually pinned it down all the way down to the female specific selective patterns. And this was not until 2004. So in the late 1900s, Drosophila researchers were most focused on male aggression. And so it was really interesting to see how like research went about this. And so aggression is this innate behavior, okay, that is hardwired in the nervous system through in development, and it has specific stereotypical patterns of behavior. I'm going to show you how males fight, and I'm going to show you how females fight. Okay, so here you have 2 videos at 400 frames per second. Okay, very slow. So these fruit flies, they fight. It's very quick, but the males, you'll see that the males have this. When they're hitting the other male, there's this top-down approach. Okay, like it's so then we know with the females, you'll see that the female, she will headbutt. It's called a headbutt. So this is a sex-specific pattern of behavior. So we know whenever I see the fruit flies fighting, I know exactly if it's male or female by the way they fight. Okay, because they have a distinct patterns of this behavior. So I think you guys can all appreciate that this behavior that you're looking at, that the animal processes and integrates this sensory input, right? And then it has this output of behavior. All of that is either, it's dictated by genes, by all kinds of different neuromodulators I'm going to talk about. So just here again, you see the female, she's approaching, and then she headbutts the other female. So, so there's this, so the sexual dimorphism of this behavior, meaning that the males and females are different, is, they're under control of these genes that we understand in Drosophila. So the other thing about Drosophila is that some of the researchers know that with this model system, we're actually a little bit more ahead than, let's say, with the mice, because we're able to then, pinpoint these behaviors and bring it down to like a single gene or a single neuron. And so this direct of control of genes is by this sex determination pathway, and it includes what we call this fruitless and transformer genes. Even the body morphology and the pattern behaviors are sexually dimorphic, like I was talking about, and this is all dictated by these genes. And it's important for enhancing, sex-specific prospects for survival and reproduction, and it's hardwired into the nervous system. So what's very interesting is that in the Ed Kravitz's lab is that they part of it was understanding how this sex determination hierarchy happens, okay? And so in flies, it is determined by a ratio of X chromosomes, okay? Where there's this set of autosomal chromosomes, ratio of, the X chromosome, and the expression of the splicing factor, like the sex lethal, what we call the sex lethal, it's a gene is actually turned on. So this is the sex lethal, and so the gene is turned on in females and turned off. It's not on in males, and so while it remains, off in males, and so this presence of this sex lethal protein, it induces productive splicing of mRNAs from transformer, and this tra-mRNAs together with the tra2, which is expressed actually in both sexes, they activate the female splicing of mRNAs from the gene double sex, okay? So it leads to these two mature transcript forms, okay, that you produce the female-specific double sex, and then you have a male-specific with the protein double sex male. So what is really interesting is that our lab, like here's all the references, is that we found that, so what happens, let's say, when sex, we know that when sex lethal is absent, the tri-mRNA is spliced into a non-productive pattern. And without the tri-protein, the cells produce this male-specific transcripts of double sex and fruitless, resulting in a male-like behavior and morphology. So you're able then, so what we found was that we're able then to masculinize a female fly. So by manipulating these genes, I am able to take a female fly, okay, and have her fight like a male, okay, by working, like by manipulating this pathway. The other thing too is that we also take a male fly, and this was done in Ed's lab, is that we can feminize a male fly and have him fight like a female, and not only that, but then he'll court another male and not a female. So, and this is all through, going through this, manipulating these sex determination pathways. And so, I'm going to show you now, what do I mean by hyperaggression in fruit flies? So I'm going to show you what male hyperaggression looks like. So you see these two males, like they're going, that is what we call, boxing behavior. So these are the males. So you see more of this top-down approach. So as you can tell and you appreciate that it's a sex-specific pattern of behavior. And then we have the females, where you have more of this, what we call high posture fencing, okay? And so these type of behaviors, so this is what we call hyperaggression. So we see this escalation of aggression, okay, in the fruit flies. And so Now let me talk to you about some neuromodulators actually that control aggression in flies. And so serotonin is, something like found in mammals. And I mean, in humans, we found that, so there's work with in mammals, the hypofunction actually of serotonin neurons. They characterize these violent and pathological forms actually of aggression behavior. They found like lower levels of serotonin. In Drosophila, serotonin has shown actually to have an enhancing role also on aggression. And in the Drosophila brain, so this is actually the Drosophila brain in immunohistochemistry, we found there are about 100 serotonin neurons, and we found that just activation of 1 or 2 neurons actually leads to either an increase or decrease in aggression. So just by manipulating these cells, these serotonergic cells, you can see changes in the behavior, which really does, you have also which makes a lot of sense because, I know you guys understand, like the psychotropic drugs, a lot of them are SSRIs, which are serotonin reuptake inhibitors, and those modulate also behavior in humans. And so the Drosophila also have dopamine, and they have about 125 dopamine neurons. And that we found that also the pairs, like if you activate certain pairs of dopamine neurons, you see this interesting changes in behavior. They also, express the receptors just like humans do. And so we also have octopamine. So some of these are just like the more major neuromodulators that have been indicated in our work. I mean, not our work, but just research in neuroscience in general. There are about 100 cells that are dopamine neurons, and this is this is close to what they call norepinephrine that's been implicated in mammalian aggression, and they show this to be involved with like ovulation, appetite, and learning, and then the different receptors have been characterized in Drosophila. There's also peptides that are conserved in Drosophila that are found in Drosophila and also in humans. So, for example, take a kinin, which constitutes a group of like this evolutionary conserved neuropeptides. They're both present in vertebrates and invertebrates, and it has a multitude of function of controlling this behavior. And in flies, they actually found that activation-specific psychokinin, you see a robust increase in male aggression, so in the male aggression circuit. Then we have the neuropeptide Y, which is expressed widely in the brain. And in flies, we also have a homolog, which is something similar to it, and we see that it's also associated with mating and aggression. And so it's been a lot of these neuromodulators are pretty conserved through species. And then you have the different gut peptide like hunger. And so they also see this, there's also seen implicated in male aggression. And the reason why you see a lot of this in where it says male aggression is because for a long time, many researchers, they didn't want to bother with researching females, but now the NIH, the National Institute of Health in the U.S., they mandate that you study both males and females. But there was this preconception that perhaps if you understand the males, that it also encompasses the females. But that we know that's not the case because they're both. Everyone should really think of them as separate. And then we know that there's during copulation there's a peptide actually that modulates even in female aggression. So these are some of the things that we understand. We also know social experience modifies aggressive behavior in flies, and they have, for example, they have this dominance where hierarchies are established. They're actually established within minutes, and it's really interesting because there's this what we call more of like a loser, like what Ed's lab did, like a loser effect, where a fly is very interesting. A bully, like we call the bully flies, the fly, when they're fighting their opponent, we know that when they surrender the food area, that's what we call the loser effect, like we call retrieval. And so then the remaining dominant fly remains on the food. And so what we see is that when we take the same fly that was what we call the loser, like the one that didn't remain on the food cup, and we switch it to a different opponent, that loser mentality is still there. The fly doesn't want to fight a new opponent because it thinks that it already assumes that it's already that it's not going to win. However, when the fly fights and it wins, and you change the opponent, it doesn't remember it won. It just keep trying to fight until it loses. And then once that, it's kind of like some type of PTSD phenomenon. We also know that flies that raise in groups actually, what's interesting, because you see this, like how social experience modifies this behavior of aggression, is that when they have when they're actually in isolation, these flies are actually more aggressive. And that's like what I use actually to optimize my aggression assay. But when we call them group housed, they're less aggressive. And so, so the questions are, so now we know this, but, we see this behavior. Now, what is the cell that is involved in male and female aggression? So I spoke about the neuromodulators, but in now for sexually dimorphic specific aggression circuit, we know that from like David Anderson's group and also with Kenta, that we know that these P1 neurons that you see here were responsible for male aggression. So my work was about, one major unanswered question in my field was, which of the nerve cells involved in female aggression, okay? And the way that so that's what I did in Ed's lab. I looked at, which are, are they different? Are the circuits different? And so, and the way to do that in Drosophila, you have what we call a GAL4 UAS system, and it's basically a binary expression system where it allows you to express genes, like you can, and then you have this where basically you express genes, and you can express them in cells wherever you want to in the brain, and it allows you. We have these tools where we can activate the neuron just by heat sensitivity. So it's with the TRPA1, which David Julius won the Nobel Prize for a couple years ago, where we have this temperature sensitive protein, okay, that when you go, so when I express TRPA1 in certain cells that I wanted to look at, I know that the heat depolarized the neuron, activated the cell, and then I saw the changes in behavior. So now in Drosophila, we have a library of fly lines. And so one way to look at this, and these fly lines actually are not specific, but here that you see them in green, they're not specific for anything specific, but this was with the attempt, what they wanted to do, what Drosophila researchers wanted to do is they took basically all the genes from the nervous system in the Drosophila and they chopped them up into bits, and then they made a whole bunch of GAL4 drivers, okay? And then so you have now this library of thousands of different, of each fly has a different GAL4 in those cells, and so then when you can so then if you cross that to a fly that has a heat activator, the heat activator is then going to look for the GAL4 where that GAL4 is expressed, and then that is where you're going to have the cell depolarized. And so I found this one line after doing like a bunch of screens. So I just want to show you what female fruit flies look like when they fight. So you see, like one female, she's like what we call pushing and shoving. So there's not very high intensity. So this is what we call a wild type fight. And then then I found this one line that when I heat activated it, and that these flies were going at it like in this hyper intensive way. So then, I went on, and so some of the questions I ask is like, okay, so if this is female specific with female patterns of behavior, I didn't masculinize the females. I just basically just took, different neurons in the fly brain and activated them. When we looked, like they say, check under the hood, and we saw that the GFP actually was, so this is a staining of a fly brain. And we saw that the GFP was actually expressed in a bunch of neurons. And it may be that the behavior that you see may require all these neurons, but it's more likely it's probably one or two neurons just from the research that we saw from before. And so what I did was we used an intersectional genetic strategy where basically you take that pattern, okay, of all those cells, and then you decrease it, you reduce it, okay, where you have like one population expressing the GAL4, okay, which is the R26001 GAF4, and this number is just telling you basically just like the number of a GAF4, but it's nothing specific. It's just random. And then you have this UAS with the effector, and then you take then you cross it to what we call a flip recombinase, which is another fruit fly. Okay, and then when you make them, what happens is that when these two overlap, okay, you have only the GAL4 driver then with the flip recombinase allows only expression in those specific cells, allowing then for the TRPA activation for much more reduced number of cells. And then you can ask in a heated room, like, you know, does that change the behavior? And so what I found was that I was able to narrow it down. So here you're looking at a confocal immunohistochemistry. The purple stain here that you're looking at is actually to visualize just the synapses. And what we found was, you see these green cells here, these 4 cells that when, I'll show you what I found. So when I activated these cells, this is what I found. So I was able to narrow it down, and you can see that it's not expressed in the males, but it is expressed in the females. I'm going to show you what I found. So when I activate just those 4 cells in the female brain, so at 20 degrees, you see them interacting, you know, like wild type. But then when I depolarize, when I activate those cells with a heat temperature sensitive, you see this robust. These 4 cells then are specific for sex specific for this behavior. And then, you know, we went on and we quantified the number of headbutts. And indeed, we saw the increase in the number of headbutts, as well as you see in the video. Then we went on, and a lot of this is we went on actually through immunolabeling to see which is, because even though we couldn't point out to the cells, we didn't know what are these neuromodulators that are controlling this, what kind of cell is this. And so we saw, like, through immunolabeling, we found that there was like a co-localization with acetylcholinergic with cholinergic neurons. And so when we found this, there was many other famous labs that also went on and looked at our work and cited it. So that was, you know, really cool, because now the P1 neurons, which are found in males, and then our group with Ed, we found the PC1 neurons in female. So it really does lend itself, now that we see that the circuit, you know, the cells that are responsible for male aggression are not the same as their females, and vice versa. So for my lab, what I do is a lot of what we do is, it's called circuit work, where you have what we call it's kind of like a gas break. And that's how the circuitry works. You have excitatory neurons, you have inhibitory neurons, and then you have the output and behavior. And so when you block some of these neuromodulators, like if these cells, if you characterize the cells, you can block it, and then look at, are there any compensatory pathways that can then lead to this behavior? And then from there, we take this information and then we apply it to higher systems. And so just to recap, so fruit flies, what we call gangsters, they're very aggressive. They're sexually distinct sets of neurons that are dedicated to male and female aggression. And dopamine, serotonin, octopamine, acetylcholine, and peptides are involved in aggression regulation. And as you can see, like, very similar to the way mammalian social experiences actually also modify aggression. So I'm going to talk to you a little bit about my community outreach. So some of the work that I'm doing is I'm working with Ruben Parra-Cardona, and this is my work with UT Austin. So basically, what we found was that, like, people like my parents that are immigrants in this in the U.S., what we found is that we have our own upbringing, and we have our own, like, cultural values and sensitivity and things that are not that are not readily recognized, right? So you have at home, there's like a particular relationship you have with your parents. I know somebody was talking about before, like, strictness, or your parents, like, like they scold you, they reprimand you, and they're the hitting part, like that's very I think very, like, it's kind of very common in South America. So what happens when people move to the US, there's this like a cultural adjustment. And so like, my parents came to the US as adults, And so I was born in New York and I was raised here. So it was very interesting to be in school and you're taught, to speak up. When you see something, speak up or like have your opinions be heard. Whereas when I would go home, my parents are like, kids are seen but not heard. You don't speak up. You don't speak up to your elder. So what we found was that a lot of the kids here, especially from immigrant families, there was so much frustration, like from what they were learning in school and then what they were experiencing, just culturally at home, that a lot of times at home it would lead to what we call domestic violence. And so the parents would then, kick out the kids, and then that then introduces them into what he saw, like at least this is from Ruben's work, what he saw was substance abuse, high teen pregnancy, and all kinds of things. So Ruben's work is not so much about this, like, let me teach you, but it's more about, it's a parenting culture adaptation group. So basically, and it's ran in Spanish, and is working with immigrant parents and just telling them, okay, listen, this is what your kid is learning in school, and these are the different cliques that in the school, like there's the bullying, like this, so it's very different dynamic. I think the students here versus like in foreign countries. So we've done a lot of this work, and I think another is going to be also adapting to, you have your norms and you have your country, like how it is, but then you also have this like widespread Google and internet influences. And so I think that adaptation is like, how to, for conserving your culture. So I know people that are studying that. And the other work that I'm doing is trying to diversify the brain bank. So here in the U.S., when you die, you can give your brain to research, and there's like different ways. So you can donate your brain to like the anatomy lab, but that's not research. So research in the U.S., we have 6 national brain banks. And so these national brain banks actually, this tissue is readily available for anyone. So anyone from Kenya Methodist University can request this tissue, and then they can study it. Right now, Timmy, Sabina, and I, we're working with different collaborators in Puerto Rico to help them start their own brain bank, because it does postmortem brain research. Unfortunately, a lot of the tissue that we have and that has been, has been published on, has been based on white, non-Hispanic brains. And so what we find is that that's not indicative of the general population, right? So then we're trying to diversify the brain bank and get all kinds of different brains, so that when we do, make these generalizations, it's encompassing everyone. And so right now, I know Sabina has started with university, like they actually already established it in the University of Cape Town, and I know now she's working with Macquarie University with Sam Coogan, and also with Brenda, in helping to look at how to start a brain bank, because it really does level up your level of research, because now because you have your animal models, but then it's like, okay, well, where's the translational part? Like, how does this implicate in humans? The other work that I did is with Dorothy Sabaka. So Dorothy is a mental health nurse here. She's an RN nurse here at McLean Hospital, and she does a lot of amazing work with many recent immigrants from Africa in the U.S. And so what she finds is that there is a lot of frustration, like what's happening at home and what's happening at schools for the kids, and the adjustment for the families to adjust to these different cultures. And so what she does is, like, she helps them, she connects them with people with resources, with information. Like, she's phenomenal. I hope one day you guys get to meet her. And so but with Brenda, so Brenda's going to talk about, she's been like the forefront of organizing the WUPI conference in Uganda. And Brenda was so brilliant that this is where I met with Professor Bantu, where it was me, Professor Bantu, and a couple of other professionals, and as well as pastors and imams. And so what we had were the people from the community come in and listen to us. So I gave my talk, then a pastor gave his talk, and then Professor Bantu gave his talk. So we were all like, it was all together. So this way, this is where the community receives the information, and rather than, so it was more like a bi-directional. It's like they see that we understand, what's going on. We understand the culture. We are culturally sensitive. And we're there just to give, some information, and then also empower the pastors and the imams and stuff with information so that they know what to do. Because like you guys said, it's very common for everyone to actually go first to the pastor before they go. So they're the first line of I would say, of response of responders. And so it's important to still work with them and equip them with the right information, and also for them to know where to go for resources, so that we can also filter that information and eliminate this misinformation, because that's huge. And so we did this great thing where we also were trying to promote different health screenings that are very simple health screenings that can really do a lot for prevention. And I just want to thank everyone, my collaborators. Definitely, I'm really happy about this summit. I love this. It's been always a dream of mine, is to work with other researchers internationally. And thank you. I'll take questions.
Thank you very much, Caroline. Let's appreciate Professor Caroline together. Thank you. We can now take some questions for Dr. Carol so that she can respond. That's a deep conversation, scientific, how to monitor aggression, and I think the study is very fascinating. And we can now have a few questions, so some questions for her to respond to. I'm waiting to see the first question.
While the questions are coming on, I want to appreciate Professor Caro for the desire and the dream that mental health should be able to reach a bigger population within the community, and that this understanding of the biological basis on aggression and implementing interventions will actually form a background to address some of the mechanisms, the underlying mechanisms of aggression. And since the interconnectedness of both the psychiatry, spiritual, and the mental health professionals can effectively manage aggressive behavior and improvise the overall community-based programs. And I think Kenya Methodist University has the platform to begin with. And I'm looking forward that we could be able to have other modules. I'm very excited about the model that you have used, the Drosophila melanogaster, to explain how aggression affects our day-to-day existence. So I believe that this platform will encourage our partners in other universities so that we can do things together and enhance interventions. And especially my colleague here, Dr. Mushiri, is a scientist in terms of biology. I think it's biology. Is it biology? Microbiology. And I believe that the concepts that you have underlined, like neurobiology, aggression is always influenced by various neurobiological factors that include the structure and function of the brain and neurotransmitter systems. So this means that as we approach these mental health issues, aggression is one of the one of the factors that really cause behavior. And therefore, with Mushiri, I think you need to connect very well with your other colleagues in medicine so that we can have other things put in place, and I think I'll collaborate with those in evolutionary psychology, because as we had suggested that we can have one at the East African region, we need to embrace the evolutionary perspectives that explain psychology and the adaptive aspects, like defending territory. And these behaviors really are embedded in psychology, but what we are lacking is the resources. And I believe that once we get these resources in place, I can assure you that the heavens are no longer the limit. No, the sky is no longer the limit, but the heavens. So I want to thank you for this kind of presentation, and I'm looking forward to using other animals as models, and also we can be able to reach out psychopharmacological interventions targeting neurobiological pathways implicated in aggression. I was excited the way these experiments that you have shown us, how the female Drosophila and the male Drosophila were trying to acquire some basic skills in fighting back. So I want to thank you really, but I wanted to ask you whether genetic counseling and testing can help individuals understand their genetic dispositions, so that we can now be able to use genetic counseling to help our clients who are very aggressive. Thank you very much.
Yeah, that's a great question. So that is something that we're still trying to search, if if there is an aggression gene, or if it's a a compromise of or if it's a combination of many genes. We still don't know. That's something that I'm hoping to find out one day. They found the sleep gene in flies. Maybe we find the aggression gene. So that's a great question, and that's something that's what keeps my lab getting funded, trying to find that gene. But definitely, gene therapy has helped with other types of diseases and stuff like that. So that would be something maybe in the future if we were to pinpoint it down. Like there are some suggestions of like I said, certain neuromodulators, but whether it's a specific gene, that still remains to be determined.
Thank you. I see a few other questions coming. I can see James Karanja. Go ahead.
Oh, thank you. Thank you so much. And thank you so much, Professor, for your presentation. My interest was on the social experience, how it goes about modifying aggression experience. And I was trying to reflect, maybe especially in history, where we have had some communities or some races, like I think there were Aryan people who were generally regarded as hostile. And when they went to India, they relegated that particular community of Hindus to caste system, the lowest. We are talking about radicalization, and here in Kenya, we are talking about guns like Mongeke, where people are really getting violent and doing many things. Nowadays, we are talking about people who are killing. We are also talking about many things, especially in Europe, industrial time. I think the change of the social environment, where the parents actually disregarded their duties and responsibilities, and children were going havoc out there to the point that Sunday school was created. So I was trying to see probably the environment that we grow in can easily lead us to be kind of aggressive, because we also talk about some clans, some ethnic groups that are generally violent, and if you go about or aggressive, so to speak, they can do anything. So does the environment also, over time, create that kind of category of people who are generally aggressive? At what particular point can that be corrected? Thank you.
Thank you. And let me add a few questions, then you can go, Professor. I can see one question on the chat that is asking, from Faith Nana, and she asks, the aggression, under the aggression behavior pattern, can it be inherited? And if yes, what is the first or the earliest character sign that can be seen? Of course, then what would be the solution? That is part of what she asked. And I think related to that, I wanted to understand from your studies, was this, was there age-specific characteristics of the Drosophila, either in male or female? Just like, okay, for us, there are stages where you have changes in terms of hormonal changes that happens over time as individuals mature. I don't think there's a hormonal system in a Drosophila, so is there age-specific characteristics of these elements of aggression that we see in these animals?
Yes, I think so. Just to go with the first professor, this is an awesome question. It's like, so what we're seeing is that like I was talking about before, like human aggression in humans, you see it in toddlers, right? To 2 to 4 years old. But with time, because it's an innate behavior, right? It's like natural. But then in time, you learn self-regulation. So that's a learned behavior of self-regulation. And if you're in an environment that is highly aggressive, that's the self-regulation you're going to learn. So then you're more likely, yes, to be aggressive because that's all you know. So it's like a very, so that's where the social determinants come in. It's also like an instinct of survival as well. If you feel like you're being threatened in like what we call a fight or flight response, and you're basically, I don't want to say conditioned, because these are all just for the, because I'm a biologist and I look at fruit flies, but from my understanding from the readings is that when as humans we are innately aggressive, but then you learn that self-regulation as you get older. So if you're getting older and you're seeing that, then it's like that, it becomes less like, so then it's about, that's how you can either self-regulate or you can continue on. And so the environment does have a lot to do with a lot of the behaviors, because you have like what we call, you have the either nature, they say nature versus nurture, that those are real, that is real. The other idea too is that I would love to talk to you more about is, like you said, about these areas that are seen to be more violent. So another like really interesting area of research is climate change and health. So that is a new field at Harvard Medical School we started. It's called climate change and health. What we're seeing is that changes in climate change, and not just weather changes, not like patterns, but that have actually like resulted in sandstorms or the increase in pollution or the increase in heat exposure. I know that those are very different between weather patterns and climate change. It's very distinct, but they seem to have a lot of impact on human health. And there's work out there that talks about them having also an impact on behavior. Now, this is something I'm really interested in, and I'm hoping to get more involved with. At least, like looking to see how can an environment also modulate aggression. I can say that, let me see, I'm sorry. I'm trying to look, there's also another question so what was, the other question was to see, I'm sorry, Professor Buguma, what was your next question?
The next question was the question about is there an element of genetic inheritance in aggression?
Oh, yes. Okay, yes, so there is. So there's also so there's the genetic inheritance of a lot of psychiatric disorders, okay? And what happens with psychiatric disorders is that there's a dysregulation of a response of aggression or impulsive. So that's in that case, because aggression is a behavior. It's not And I mean, there are diseases that are specific for like intermittent explosive disorder. And that seems to be also a genetic component of it. There's also, like for people, for example, like where it's, post-traumatic stress disorder, there's also this outburst of aggression, which Dr. Ressa will talk about, but that's not necessarily, genetic. Like, whereas like that's what they inherited is the aggressiveness. They inherited I think Professor, he'll talk more about that. Whereas post-traumatic is more about a trauma happening to you, and then this is how your brain is responding. There's also this, so it's kind of more like a secondary, I would say, like for example, Alzheimer's or dementia. So these are people that, they went through all their lives and they didn't have this increase in aggression or behavior. They were able to self-regulate. And then at one point, as you're aging, like, when the disease, the pathology has like progressed, it seems to be there's like more of this impulse of behavior. So I found it very interesting that a brain that's dying off in certain parts has this impulse behavior rather than the opposite, where, you would just like either become more, less movement or less involvement. So there seems to be this interesting factor where it's not so much like there's another word too, actually, that talks about violence, like people like that's more like a social social field work but they have implicating certain I would say certain ways, or certain like certain hormonal levels, or certain cortisol, certain peptidergic levels, or something that are actually correlated with psychopathology, like sociopaths or this type of more tendency of murdering. So that is more. So these are just this is just all my general understanding of it. I'm sure there's probably more recent work out there, but this is an area that I'm really interested in. I'm going into, which is with the climate change, and how does that influence behavior in those areas, and do we see an increase in violence in certain areas, and then ask why. Is it the change in sandstorms? Is it something in the air? Is it the air pollution that is an increase in maybe a certain chemical that could be modulating the brain and then and output of behavior? So that's something that we're still looking into. Like, this is an emerging field. Sorry.
Yeah,
I hope that answered your question, Professor.
Yeah, I think, Professor, you are really addressing these things in a timely manner. And this, of course, requires a very, very comprehensive approach and interventions that could address the biological, psychological, and social factors contributing to aggression. Because I'm aware in politics, especially in most governments, the aspects of aggression behavior is seen during those periods, and the reasons for this is, of course, it goes back to poverty, because most of the young people, they know they would always get support from the politicians during that time, and that's why you find in some countries there's a lot of youth radicalization by sex. So by having comprehensive interventions that would address some of these factors, like what Reverend Karanja asked. In Kenya at one time, the environment where these people were coming from contributed a lot to conflicts in most regions. So by creating supportive and non-threatening environments that trigger aggression, requires us now to implement conflict resolution strategies. And in fact, this is in line with what we intend to do within the region. So we have communities, we do community outreach and provide those skills, especially improving on social skills and communication, fostering empathy and perspective talking, and promoting pro-social behaviors, So we are lacking some of these facilities, and I think by coming up with those centers, we'd be able to have lessons, structured lessons that people can be able to go through, and understanding these conditions will help them. And of course, one of them is use of cognitive behavioral therapy. Because in cognitive,
yes, that's true. Yeah.
Yes, these can help individuals to recognize the challenge, maladaptive thought patterns and behaviors contribute to aggression. So when we have a structure, like as always emphasized, a global mental health facility would be able to address some of these either environmental factors or genetic factors across the board, across the lifespan, so that now we can have it as a continuing form of education, which of course will appeal to the clergy, the people in charge of spirituality, the psychiatrists, because I have seen some of the violent behaviors of patients. And somehow, I remember a scenario in Butabika, I think one of the days when you go to one of these national clinics in Butabika, that's a mental health clinic, where a patient picked a knife and then chased the caregiver, the doctor. They chased and they ran around the whole compound. After they had reached somewhere and the sick patient discovered that the doctor is tired, then the doctor rose his hands up, and then the patient gave him back the knife and said, "Okay, you also chase me." So, you know, the understanding is that these people are given a low understanding, because if you don't really understand what is going on in the minds of the person, this aggressive behavior may continue. Even in families, you may find that a couple becomes so rude, hard. He comes at home with the children just to go and take a cover. So I think when we have a structured facility that can be able to provide training for the children, training for the young people, training for the adolescents, the families, and this really can really work when we have the integration of all these professionals. So this dialogue is really quite relevant. It is good. It's timely. We need now to have these networks, because I'm excited that when we have that dialogue, we can increase capacity in terms of the partnerships that we shall get. We have social support networks, the community-based programs, and then we can also be able to enhance resilience and promote long-term behavior change. So I think it's a very
so
good...
Professor Bun,
yes.
Just to answer two more questions. So there was a question about how to recognize the pattern in aggression. So I think you really made an important point. With aggression is more, you'll see, is more of either a reactive or proactive. Proactive is more quiet, but reactive is more like an impulsive behavior. And so you'll see like different patterns, like, you know, you see this, and you see this mostly in toddlers, but then hopefully they grow out of it, or they learn self-regulation, and sometimes it's not so apparent. So when they have these frustrations, rather than, you know, using the prefrontal and executive functioning, I think the CBT, like cognitive behavioral therapy, are great tools for that moment in time to reason what has happened, and then knowing that there is a solution in the end, or having that, because like, for example, with self-aggression, with suicide, this is like impulse behavior against oneself from that frustration. And as a species, as a human species, you're not supposed to finish off your species by committing by dying by suicide. That's not something. So there is something biologically happening there that is uncontrollable, and so this is something that we're still trying to understand. The other question I know in the chat was about isolation. So yes, it's like social, like isolation. We see that with children, like when they're isolated, they tend to, you know, they become more aggressive, or they become resentful. And so growing out of this stage of this tolerance, but then having this moment of self-regulation, but then if you're exposed to all these other frustrations, it's hard to come up to have this self-regulation. The other point I want to make is that so we know that the brain is not fully developed until you're 25 years old. So that is why, like for adolescents, they have an adult body, but they're not having the decisions are not smart. They're very impulsive decisions, and that is because the prefrontal cortex of the brain that is responsible for planning and execution and also for solution is not developed yet. And that's why adolescents always do these what we call like stupid things or impulsive behavior, always getting in trouble, because it's like they have this adult body, but the brain is not fully developed yet. It's not until they're 25 years old. That's what we're seeing. Whereas like their executive function, the frontal part of the brain can then make these decisions. So that is also a really important factor. And definitely the isolation, it does increase aggression. I mean, you see it with my fruit flies, right? When I single house them, they're more aggressive than the ones that I group house. That in itself just shows you what isolation could be such a very, it's not good. So that's why definitely having a support team, because a lot of isolation also people tend to have these negative thoughts, and that's where cognitive behavioral therapy comes in, because then you have this negative self-talk. These are all great conversations, and I love that we're taking the biology. We're still there's these theories with psychology, and there's also these behavioral modification therapies. Even spiritualities, we know that's also very good. But I think it has to all come together. I think you have to have the scientists, you have to have the psychiatrists, you have to have the psychologists, you have to have the faith-based leaders. I think we all have to come together to try to figure out how to help the patients.
Thank you, Professor. I'm checking with you. Are you likely to be available to introduce Professor Kerry at for the PTSD talk?
Yes.
That's now in half an hour's time.
Yep. I will. Yes.
Very good. Thank you. One last question before we want to take a short break for a lunch bite on this side, so that we can be able to be back for Professor Kerry, so that we are not far at about 2. So, but there's somebody who want to ask a question. So let's go.
Okay. Thank you. Just a quick one. Sometimes we observe, and even our fellow siblings of our children, one of them turns out to be a bit aggressive right from when he's very young, and you wonder, is it innate? Is it inborn? Or later in life you see a particular person in a family goes the aggressive way, and in terms of obedience, in terms of isolation. What could be the issue? Because they are all in the same environment, but one or two tends to be the odd one out. Thank you.
Yeah, that's a great question, and I think that's where this is interesting, because I remember I'm just giving you some anecdotal answer. So from my family, I remember my cousin was very aggressive when we were little, and he would beat up everybody in our circle, like everyone. But then now, as an adult, he is completely a different person. And I think that having this, my aunt having this hypersensitivity to the fact that he was so aggressive, I think they were very keen on calming him down or helping him to understand how to calm down, which he was very opposite to his sibling, who actually was very docile all the time. I think that because genetics is a really interesting is interesting. I think that it can vary across, because not all of us are one the same. So it can vary across across siblings, even if you, and that's like a good control group because you're in the same environment. There's also like the same thing with disorders. It's like you have somebody, one of your siblings develop Alzheimer's, but you won't develop it, but yet you have it, you have the gene. It's just it was not fully triggered or manifests itself into a disease, let's say, whereas your sibling it does. So I think that's a really interesting question. I don't have like a specific answer for it, but I can tell you that is very possible. And it could be due to this diversity of our genetic pool, and that's like the beauty of it. But yes, that is interesting. Yeah, because there's some kids are more sensitive than the others. So yeah, that's really interesting. I think there's a lot of work going into that. I just don't do that type of work. But yes, but I know just from the genetic point how this could be, because of the genetic variety. That's all.
Thank you. Jacqueline, online, I had seen your hand up. I'm not sure I want to go without giving you a chance. Jacqueline Logoro, are you still available?
I'm still available. You can hear me?
Yes, please go ahead.
All right. I want to applaud that presentation about aggression and the question I had asked about whether has been asked. I don't know whether you saw the question, but I want to give a practical example. When it's very hot, that is January, February, and maybe at the end of the year, I'm a very aggressive human being. And sometimes I get to wonder, what if most of the people in the society maybe have a condition like mine, and they don't know. So during their aggression or their manic is when maybe politicians are using us. When you are manic, we don't think straight. So when you tell us to climb a hill, we will climb a hill. When you tell us to beat someone, we will beat someone. So the way you have said that we need to do community outreach so that people can understand aggression and where it's coming from, I think it's very important we work towards that so that we can enlighten the society, because they are the ones living with those children at home, with those teenagers at home, with those youths at home. Basically, what I'm trying to say is that personally, when it is very hot, and I know my two colleagues are here, I'm very aggressive, and I get to know that I might hit manic. And what I do is that I channel my energy positively, because I walk the journey with a psychologist, a psychiatrist. I'm on medication. And I do a lot. I try to channel my energy elsewhere. And my employer ensures I channel my energy elsewhere. That's when I'm going to be given a lot of work, because I express myself. When you know yourself, you express yourself. When you know people understand you, you express yourself. You go to your boss, you tell your boss, I think I'm hitting manic, or I think I'm feeling this way. How can I get help? Because someone like me, I can't stay alone when I'm manic, and I can't stay idle when I'm manic. So that time is when I'm given a lot of work. And trust me, because of the energy, I know there are psychologists and psychiatrists and counselors. You understand that energy, so I channeled it positively. Problem will be someone out there who doesn't know their mental condition or their mental status, and they get into manic, and they don't know what to do with their energy, and they are taken advantage of by the society or those in power. Thank you.
That's a great, thank you, Jacqueline, for sharing with me that. So it's very important that we disseminate information and that we start in the schools early on. And we have to normalize mental health. So, for example, I know the politicians, so we have that problem here too, where sometimes politicians don't want to listen to scientific research because they're motivated by their donors or something else. So another area of advocacy I'm really interested in is in a death penalty. For example, in some countries, the death penalty is like as young as 13 years old. And we know in science that the brain is not even fully developed. And they obviously, in that moment in time, so what this kid needs is rehabilitation. you know, is need to help. It's not that, and I think understanding that more is really important, because they, like you said, there's a lot of, and I think this is where a lot of like child abuse and things like that come in, is because some kids actually tend to be more impulsive than others, and the parents, they don't know what to do, and then they have this reaction to it. So I think understanding and knowing that these are biological factors, there are, you know, medications for there are also these talk therapies for it, and normalizing it so that we can catch it early on is the best thing. You know, and I think hopefully politicians are becoming more and more aware that this, like you said, you know, if you're having an episode, obviously your home will also be affected, and your children will also be affected, your family. So it's like this ripple effect. And so then you have more and more problems coming from this. And then if you have a society with all these problems, you know, you know, that's how then you have, you know, more and more barriers, and then to, you know, to progress forward. But thankfully, you know, you're going to the psychiatrist, the psychologist, and you're targeting this with biological, like pharmacological agents. And I know sometimes there's a lot of side effects, but it's very, sometimes they say that the risks, you know, the benefits outweigh the risks, you know. So, but it is very important, because like a happy mom or a happy kid, that's how it is. So I think that's really important. And I know that there's like a hormonal, like for example, postpartum depression. There's like this huge hormonal withdrawal, and then there's a lot of time this impulsive behavior to hurt the child, you know. And we know that it's something that your body's going through these changes. So understanding this, normally speaking about this, not stigmatizing, not judging people for it, you know, is something that's very important that we need to do and normalize in society. And hopefully having more like these conversations and having people come to light with their own stories will help normalize this. So that's really important. So I really appreciate you sharing your story with me. Thank you.
I wanted to again thank you, Professor, for that observation. I also wanted to amplify the desire that Jacqueline, for re-emphasizing on those conditions, manic disorder, bipolar, and also we also have seasonal affective disorders, and a number of people don't know that they really occur. Like in seasons like January, December period, because of unmet needs, financial crisis and all that. So you will find that some of the behaviors of people completely change. And then also towards the month of August to September, there are also periods, there are episodes of disorders. And you'll always find on the streets a number of people who are either alone, they are carrying things, or they are just seated because they have been overwhelmed. And there is no one single person that has come up with an idea that let's talk to them. I only like the experience of Jesus Christ. In the Bible, for those who subscribe to Christianity, you will appreciate that there is a verse in Mark chapter 4, verse 35. In this scripture, you see a scenario when all the things have been done and Jesus tells his disciples, let's go yonder, let's go and tally, let's go and rest. It has come to a time that we need to recognize the needs, the psychosocial needs of individuals, families, and the communities. I like Jacqueline now that she's in the university setup. You are now the only person who understands how you operate. Can we have a dialogue? Can we have a talk, even on social media, and indicate that, oh, these people are having issues? Can we get together and let's move to the Global Mental Health Center or wherever centers that we shall have made within the community setup so that we can be able to talk to each other? I have understood scenarios. Even recently when I came to Kenya, I read stories where a father killed his son because he had failed to go to the university. And it's because the Bible was not there to help this, because like in the book of Ephesians chapter 6 verse 4, it says, fathers, do not exasperate your children. So we don't have those forums where we can have people talk to their children, people talk with their parents, so that now we have a streamlined structure in terms of how we can understand the nature and nurture of our children. Nature, how someone has been born, and some of the varieties that contribute to the current functioning of the individual. Nurture, because of the environment where these people have really interacted. So, Jacqueline, it's very important. I'm excited that you are there. And you said you are coming from Karatina University. So we need to now dialogue and say, okay, how do we reach out to Karatina University? How many other people can understand their conditions in other universities? Can we make a fora? Can we team up? Can we form and try to help the people to be able to understand the circumstances they are going through? That's why I'm saying spirituality, psychiatry, and mental health can work together to bring sanity in mental health care, because we need to use a multifaceted approach. Like this dialogue that we have really had, it has brought on board a number of facilitators from the US, a number of facilitators from within the East African region, DRC, Rwanda, Cameroon. Now, these dialogues provide a platform for us to say, okay, we need to begin a community-based environment where all the setups and structures would be put in place. We have a chapel, we have a mental health facility, a psychiatric zone, we have social workers, so that these people now can have an opportunity to interface, to dialogue, and be able to share the issues that affect their lives. By so doing, we'll be promoting mental health and will make it visible in all realms of life in the world, in the political world, in the national world, and that will involve a multifaceted approach, just like we have already come here together. There are people in prisons who have suffered because they have conditions that have not been assessed. We have people in government, we have people in security, we have people in the church, we have all sets of personalities, and therefore by coming together would be able to put a platform where people can freely be able to talk about their conditions. I like what Jacqueline was saying, that when manic aspects come in, if she's told to beat someone, it's normal, it's easier, they can do it. If it is laughing, she can do very well. But also, we need to consider climate change. And Professor Caro, I think we need to work out a modality of how we can have researches on climate change and mental health. Really, there are seasons, especially even I'm told that women, there are seasons when they are very aggressive, they can beat someone if you come near them. And this is not known by anybody. So we should be able to create awareness with families in the church, with families in the society, so that those seasons when the women are very aggressive, they don't want to see anybody, or they are annoyed, or they can. I remember a time when one of the women wanted to produce a baby. And during that time, I think they say he was pregnant. So they said every time she would see the husband, she would vomit. And others, whenever they would see their husbands and their workers, they don't want them to go away. So, but how many people really fully understand these scenarios? So it is an opt time where we can be able now to address some of these. They are simple but very serious issues. And these are the ones that are affecting us as a society, affecting us as psychologists. Like, for example, I would be disappointed to hear that someone has crushed another one without no cause. You beat somebody, you become arrogant, Like I've said, most of these offices that we occupy, I've seen scenarios where the bosses say, I don't want you in my office, get out. Then all of a sudden you say, but I didn't have any quarrel with this man or this woman. What really happened? Yet there could be underlying conditions which must be reassessed. And that's why I would encourage that workers, professionals, let's take advantage of these facilities we are intending to put in place so that you can go and check and say, am I okay today? If you are not okay, then a system should be able to tell you, wait, relax, take a cup of water before you talk to somebody when he comes in an office. I have seen that some openings that can be put in place can help people emote, can share their experiences, and they will be better. So, Jacqueline, I would want to encourage you that let's form, and you are aware that we are at an advanced stage with my colleagues from the US, especially Harvard University, and Professor Caro is on the forefront. And I believe in the afternoon we shall be having the director of that institute, or the McLean Hospital. We are interested to interface and have dialogue. And one of the areas that we want to begin with is coming up with a center that shall provide training, outreach, and also provide psychological first aid. So that now persons like already, for example, Jacqueline, I'm very glad you know your condition. There are many others that do not know. And therefore, by so doing, we can really be able to help the society, but at the same time, healing ourselves. Psychologists, clergy, and even the mental health professionals, we always say, heal yourself before you heal others. And we can only heal ourselves by coming together in a dialogue, and we can, at the end of the day, say we have met this nature of persons. So I want to thank you very much. I don't know whether Professor Caro, about this collaboration in terms of these researches, you have something to add on.
I think, no, that these conversations are timely. And so they, they're timely, and I really appreciate that, that you invited me here to speak about this today. Because, like I said, now we have this ever-evolving climate change, the changes in human behavior, and also the other aspect too is that isolation is getting more and more common, especially now with social media and things like that. So I think it's very important to start talking about this, even with the earlier elementary school. Getting into the schools earlier and start talking about this, being mindful of behavior. Or having teachers recognize this behavior so that there's more of a support network for children. I think that also because it could be that the dad, let's say, I know that happened with, I think it's called not femicide, it's called like, not infanticide, but when he killed his son, it could be that maybe, like he needs to understand why the son, I think understanding where the son is coming from is a very important area. Like, was there something before? Did he have an underlying attention deficit disorder? Is it dyslexia, which is a form that it's hard for you to read because your brain confuses letters. Like, that's also very common. And so then kids don't perform well in school. So then the parents get frustrated. I think understanding, I think the same way that we normalized vaccines, in the doctor's office, they should do the same with mental health. It should always be a question in the physical examination for children. I think they should always have, the normal questions like, okay, the weight, the height, how is your mental health? How is the mental health of mom and dad? How is it going? These are questions they need to normalize and embed also, because I understand that the brain, because you can't see it, people think that it's not there, that there's not these problems, but it is there. And it's important, especially when they're younger, and we're seeing that here. Like, this is something that they're trying to normalize now with the pediatrician's office. This is a question like the other day, I took my son to the pediatrician. He's 17. The doctor gave me a questionnaire and he gave him a questionnaire. So they're trying to, because this is a big crisis right now, especially with suicide and adolescents. The other factor too that's very important to understand is that, for example, when teens or when people go into and they do substance abuse, or they use other drugs they're basically masking or medicating what needs to what they're feeling, and then that's what drives into these different other substance abuse. So I think normalizing mental health at a very early stage, getting into the schools, talking with the pediatricians, talking to the communities, the pastors, is the first step, because then it's normalized. And if the minute you see it, or the minute your aunt sees it, or the minute your grandmother sees it, they can call the attention. Then they can speak to a doctor, and then you have this like ripple effect of treatment. And so then the more people are aware, and then there's more support. So I think that's what that's my own my own take and my observation. That normally, like for example, if my parents would have known what to see in my sister, if they would have normalized, like if they would have looked for depressive behavior, let's say, or if they saw that maybe my sister like did something or something, like they would be more intuitive in looking for this, right, and being like more hyper aware of it. And they probably could have saved Angie, and she died in 1993 when Prozac first came out. So there's still, I think we're still evolving. But I think these are the type of conversations, these are the type of summit that we need. And we all need to have a bi-directional, a sort of a dialogue. But thank you.
Thank you very much. Because we are getting to 2 o'clock now, we need to shift gears. So because we are going to soon 2 o'clock on this side, because we are going to have the next presenter in another 5 minutes. That's what I'm seeing. 5 minutes. So what I will request is Reverend Shambere, if you can play for people to have their meal. We shall continue the conversation because we don't seem to have any allowance of breaks.
Let us pray. God, we thank you this time that you have given us an opportunity to have a break. I'd also pray that you bless what you're going to have for our lunch. May it be refreshing to our bodies, so that, Lord, we shall be able to get back to our business for the rest of the day. Hear our prayer. I bless it for our partaking in Jesus' name. Amen.
We are having the next presentation, which is coming from the U.S. By Professor Kerry Lesler in another couple of minutes. So that is what we expect. So that prayer allows you to go to have your bite as we continue. That's the meaning. Otherwise, we are not able to take any formal breaks so that we continue. So like the team online is doing, so do you as we proceed. Thank you. I'm sure you can go ahead. Professor Carlo, are you ready to introduce Professor Kerry? Is he available?
Yes, I will introduce. Let me, I'm going to...
Is he
I will send him a message.
Yes.
He will be coming on in like about at 7 a.m. So, which is 2 p.m. your time, I believe.
Yes, which is about 2-3 minutes from now.
Yeah, 2-3 minutes. Yeah, he's very punctual.
That's what I'm saying. So that's why I'm saying there is no formal breaks.
No, I know, but maybe people have to use the bathroom or something.
Well, they read behind the cameras. Anyway, they will be listening, so that should be no problem. I think they have enjoyed the conversation. That's why we haven't had this lunch hour as would normally be. But that's fine.
Yeah, it's a very exciting conversation, and I love speaking with you all. Thank you very much for allowing me to be here today.
Very good. So when you are ready, let us know. Then we can have Professor Kerry, and the conversation can continue.
I think meanwhile...
I believe... Yeah.
Yes.
I believe Professor Ressler
Yes.
is on.
Good afternoon, everyone. Hi, I'm here. Let me know when you're ready to start.
Would you make an introduction to Professor Astley, please?
Yes, thank you, Professor Bantu. And thank you, everyone in Kenya. We're really excited to be here, and I'm so excited to introduce you to Professor Kerry Ressler. So Dr. Ressler serves as a Chief Scientific Officer at McLean Hospital, which is #1 psychiatric hospital in the United States, where he oversees all ongoing research. He holds the position of the President of American College of Neuropsychopharmacology, and Dr. Ressler has extensive background in post-traumatic stress disorder, which aligns closely with your area of focus, as well as, so before joining McLean, Dr. Ressler spent 18 years at Emory University, at Grady Memorial Hospital in Atlanta, where he established the Grady Trauma Project. This study aimed to understand the psychological, biological, and trauma-related factors contributing to intergenerational cycles of trauma exposure, PTSD, substance abuse, and depression. And it involved over 13,000 participants, primarily from different ethnic backgrounds. And this cohort later became foundational for the Psychiatric Genomics Consortium, PTSD work group, and now encompassing over 200,000 samples worldwide. And he's also a big, I just want to say for my personal experience, also a big advocate for junior faculty development. And he also was actually one of my biggest advocates to go to Africa and to pursue my dream over there and to work with you all in destigmatizing mental illness. So thank you, Professor Kerry, for coming.
Well, thank you so much for having me. I really appreciate the invitation, Dr. Palvicino Maggio, and very nice to meet you, Dr. Bantu and Baguma, and it's my honor to be here today. So does my audio sound okay, and I can share my screen?
Praise, we can
Great.
go. Yeah.
Terrific. So my plan today will be to talk for about 30 minutes on understanding post-traumatic stress disorder. And can you see my screen okay? Everything fine?
Yeah, we can see very clearly.
Terrific. So I'm going to give you a broad overview of trauma, post-traumatic stress disorder as we currently understand it, and mental health. But also considering a substantial amount of time on positive emotion, sociality, and faith, and how we might be able to protect against trauma effects. We often focus on the science on the negative impact of trauma and how trauma and PTSD lead to dysregulation of behavior, but we focus less on safety and sociability and some of the protective factors. And so I hope to bring that in today as well. And then I save plenty of time for discussion and talking about potential collaborations and future directions. Thank you very much, Caroline, for the generous introduction. So, of course, while we have a number of collaborations in particularly South Africa, Cape Town, and Nigeria, most of the work I will focus on today is on from the Western perspective in America. Dr. Sandro Galea is one of the leaders of public health in the U.S., and one of his standing points is that trauma is a foundational driver of health to the public. And while we often think about trauma related to post-traumatic stress disorder, trauma really is a risk factor for many, many disorders in psychiatry and in biology. We often think of now trauma in mental health and in aspects of biological health, similarly as we thought of syphilis in the 1800s as a great mimicker for all sorts of different disorders, and I will walk through some of that. According to the WHO, over the last decade, mental disorders, many of which are trauma-related, and physical trauma are two of the leading areas of highest spending. And over again, we see high rates of trauma in epidemiology. In Western populations, post-traumatic stress disorder accounts for about 5 to 10% of the population. We see about a 2-to-1 risk of PTSD in females compared to males. in part, that is due to increased social and interpersonal violence in females. We also, though, think there may be sex differences at the biological level as well. Importantly, the level of trauma exposure that one has experienced is very important for rates of PTSD. So in military populations, veteran populations, and at-risk populations, some of which I'll talk about that have been exposed to multiple levels and high rates of trauma, we can see post-traumatic stress as high as 20 to 30%. So there's a broad range based on environmental factors. The criteria in the Diagnostic and Statistical Manual, DSM-5, and very similarly in ICD-11 for diagnosis of PTSD, is having experienced an event in which a person was exposed to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence. Importantly, in addition to these specific criteria, the response often involves significant fear and helplessness trauma. In the aftermath of that trauma, many symptoms can occur. The first month of symptoms we call acute stress disorder, and that is because many people have these symptoms far more than go on to develop PTSD. Having a stress reaction in the aftermath of a severe trauma is very common, but most people recover over time. So again, after a single trauma event, probably half the population will have experienced some of these symptoms for the first days or weeks. But only about 10% of that cohort will have gone on to experience chronic symptoms. After 1 month, we diagnose PTSD, and after 3 months, chronic PTSD, if the symptoms continue. The set of symptoms include re-experiencing, which is really one of the most classic components of PTSD, and that involves nightmares and flashbacks, essentially reliving the traumatic experience. And this is very much built on our idea that PTSD is a stamping in or a over-encoding of the trauma memory, essentially a trauma memory that one cannot escape from. Criterion C is ongoing avoidance of the stimuli associated with the trauma, the triggers and reminders and context of those trauma. And avoidance, while very common across all anxiety disorders, is also one of the risk factors, because the more one avoids exposure, the harder it is to actually recover. And I'll talk more about that in some of the treatment options. The third criterion B is negative alteration. This is new from DSM-4 to DSM-5, and negative alterations in cognition and mood. And with that, it gets to the idea of depressed symptoms and emotional numbing, as well as anhedonia, lack of interest, which I'll talk about later, and lack of enjoyment. And those, when we think about protective factors, such as social support and positive emotion, these symptoms really impair the ability to recover in that way. And then finally, criterion E, like criterion B, are some of the most specific for trauma and PTSD, which is increased arousal, sympathetic arousal, decreased sleep, hyperarousal, increased startle, and many of these components can be thought of as the body constantly being on edge and ready to run, ready to defend itself, ready to escape. So I mentioned PTSD is highly comorbid with many psychiatric disorders, and this graph from Ron Kessler WHO studies over almost two decades ago now, show the rates of comorbidity in both males and females across depression, anxiety disorders, and substance abuse disorders. And particularly with substance abuse disorders, which I'll talk about a little bit later, we think that there's similar dysregulation in the brain mechanisms of of both trauma responding and substance abuse responding that lead to this comorbidity. So again, it's highly comorbid, and many of our psychiatric disorders also have trauma as a basic component to them. And one of the leading areas of research right now is trying to understand why childhood trauma or adult trauma leads to different paths. Why for some people it looks more like PTSD, for other people depression, for other people substance abuse, and for many a combination of all of them. Other components of trauma affect one's experience of the body. And we know anecdotally, when people have been traumatized, they will often talk about reliving it in the body. And Dr. Bessel van der Kolk, who is is very well known for his work, particularly in a book called The Body Keeps Score, really talks about the sensory processes and how it feels like the trauma is living in the body. And we now know a lot more about the brain mechanisms of sensory function that represent the body. But just historically, for example, the concept of PTSD has been around for thousands of years. And in the last few hundred years, long before we talked about PTSD as it is, we saw turning various wars from the revolution in the West, from the wars between Europe and the States, and then more recently the Civil War in America and in World War I and World War II. Concepts such as shell shock, spinal syndrome, soldier's heart, nervous shock, battle fatigue, combat exhaustion, all of these have lived in the literature, but all seem to be very similar to what we now call post-traumatic stress or PTSD. Furthermore, there's a high level of overlap in PTSD and disorders of the body. We think in part through areas of, through dysregulation of the immune system, levels of dysregulation of immune function, levels of dysregulation of peripheral stress systems, and of cardiovascular systems, and of redox, oxidative stress. All are associated with trauma and PTSD as a mediator of increased risk for both cardiovascular disease and cancer that has been shown over and over again in trauma-related disorders and PTSD. So not only does it affect one's quality of life and one's ability to function emotionally and mentally, it increases risk for disorders of the body. When we talk about psychiatric disorders and mental disorders of mental health, we really often think about the intersection of the environment with genetics, or the old terminology would be nature versus nurture. And almost every disorder of mental health is related to some combination. And I'm not going to talk much about genetics today, but we know that whether it be substance abuse, alcohol use disorders, depression, anxiety, schizophrenia, or bipolar disorder, and certainly PTSD, all of these have a genetic component. And about 40% of the genetic risk for developing PTSD, of the risk for PTSD, seems to be genetic. But that means about 60% or more is environmental. And while we understand there's a gene by environment interaction in all psychiatric disorders, this has been in some ways most well understood in post-traumatic stress disorder, because by definition the trauma is part of the disorder, and in studies of PTSD one always collects data about trauma exposure. We also know that PTSD, at least in Western literature, while initially talked about primarily around the military, and that was both through historical narratives from the Greeks and the Romans, and more recently in the US from the Vietnam War and World Wars, we increasingly have appreciated that PTSD is a disorder that affects anyone who has been traumatized. It affects the civilians that are the victims of war, such violence. Thank you, Laura, for putting the Body Keeps Score in there. That's great. And I'm not going to talk much about it today, but there's a lot of exciting data on how that trauma affects sensory representation in the visual system, the auditory system, and the somatosensory system that may underlie some of the observations seen in the way we feel trauma in our body. So I'm going to next talk about dive a little more into our understanding of the neurobiology of trauma and fear. So the first question is, well, why would we naturally have a system that goes awry to lead to trauma disorders? And of course the answer is that fear is evolutionarily useful. It is probably the most important evolutionary driver of survival, which is being able to rapidly respond to threats in the world. And if one is walking through, in this case, the woods, but it may be through a forest or a savanna, and one sees what appears to be a snake, right? If there are poisonous snakes, one is often can be very afraid of them, and many of us have sort of what feels to be natural snake phobias. What happens in this case is that one responds to the snake well before one is close enough to often realize, is it truly a snake or is it a stick? And what's going on there is that the eyes or the ears or the smell, any of the sensory systems, are constantly on alert for dangers in the world. And this is for all of us healthy humans. And within a few, within milliseconds, the eye and the information in the eye, the pre-processed sensory information, is processed by the first place in the brain, the visual thalamus. And then projections from the visual thalamus go to both the visual cortex, then from the visual cortex to higher order areas of visual cortex and visual processing, and eventually to areas of higher order association areas and prefrontal areas. That takes on order about a half a second or 500 milliseconds for those tens of synapses that have to be traversed by that information. So we're really consciously aware of what this is, whether that is a snake or a stick. And we may say, oh, it is only a stick. It just looked like a snake. However, within the very first projection, the thalamus also sends information to the amygdala. And this is pre-processed visual information. And it's not nearly as well precise in terms of its information as the higher order information coming through higher visual cortex. The amygdala within two synapses processes that information and activates if it represents or matches previously encoded threat signals. It activates the hardwired fight or flight signal. So the take-home message is that within about 100 milliseconds, the amygdala activates the hardwired fight or flight signal, and one is not consciously aware of what happened until almost a half a second later. So we are often going through the world responding in a reflexive, emotional way much faster than our brain is able to consciously really process what is happening. And that is terrific for survival. We need very rapid systems for activating our threat reflexes. But in the modern world, it is more likely to lead to phobias, panic, post-traumatic stress, aggression, defensive responding, etc., than it is to lead to survival. And importantly, as to the point of survival, the amygdala that we have as humans is very similar to the primate amygdala, but even to cat and dog amygdalas, and even to rodent amygdalas. Even the reptiles, such as lizards, have a primordial amygdala. So it's very much, if you will, the reptilian brain that is keeping us alive, but is also then causing the problem of trauma and threat-related disorders in a modern world. Another example of what this threat system looks like is the concept of a panic attack. If you've ever had or know someone who has had or treated someone with a panic attack, they might say something like, all of a sudden I was dizzy, my legs gave out on me, I couldn't catch my breath. It felt like someone was choking me, my heart was beating too fast, I felt like I was dying, I had to get away. And with a panic attack, one has all of the symptoms of heart rate, chills and hot flashes, and nausea, shortness of breath, chest discomfort, sweating, choking sensation. And then cognitive interpretations of those symptoms as if feeling one is dying. And we see panic attacks across all of the fear and threat-related disorders. But, for example, with simple phobias, fear of snakes, these symptoms are all activated by the trigger of a snake-like figure that I showed. But in PTSD, the panic attack is triggered by the reminders of the trauma. If I go a little further, the amygdala is the place where the previously neutral information, a person, a car, a sound, a smell, is associated with the trauma itself. In the case of a car crash, a motor vehicle accident, the sounds, the smells, the pain of the interaction, the crash, are compared neurally with the previously neutral cues, the sound of a car, a honk, the visual cues of a car. All of that sensory information at the time of the trauma is coming into the amygdala, and through a whole set of synaptic plasticity events, such as NMDA glutamate plasticity, BDNF plasticity, calcium plasticity, and others, leads to structural changes in the neurons in the amygdala, so that in the future, the conditioned stimulus itself that was previously neutral, a car passing, a picture of a car, a person who looks like your attacker, those previously neutral signals, now by themselves in this pre-processed way, activate the amygdala circuit. And what does that mean? Well, it was shown in the 70s and 80s and 90s initially by people like Michael Davis and Michael Fanzelo and Joe Ledoux and others, that the amygdala has hardwired projections to many subcortical brain regions, the hypothalamus, the vagus, the parabrachial nerve, the central gray, and the paraventricular nucleus of the hypothalamus, that together lead to all of the symptoms that I just showed in the panic attack. So it's one of the few places in our field in neuroscience and behavior where we have basically a simple reflex, amygdala activation, we now know with electrical or chemical activation of the amygdala in a human or a mouse, leads to the hardwired panic attack, the increased heart rate, the GI distress, the respiratory distress, the hypervigilance, the startle, and the hypothalamic pituitary adrenal cortisol response. So it's an exciting area in that we now essentially understand the brain reflex of panic and threat. And what becomes the more important question is what is upstream of that? Why after a trauma do 10% of people develop an overly strong threat response that becomes generalized, that becomes too reactive, and that impairs their function and their quality of life, and even may lead to suicidality? Whereas 90% of the people are able to recover over time. And part of that is how the amygdala is regulated by the hippocampus, which is involved in providing contextual and safety information, the prefrontal cortex that's involved in top-down regulation and bringing all the other information in, and some of the other circuits I'll talk about. So as I move into more into how we think about PTSD as a longitudinal development, we can break down the question in why after a severe trauma do 10% of people develop PTSD, but 90% of those recover. And this may be broken down into pre-existing sensitivity. And again, we know about 40% of the risk is genetic, but about 60% is environmental. And we know environment is important, and development environmental is really important. For example, childhood trauma is a much greater risk factor. Those who've experienced childhood trauma have a much greater risk of developing PTSD as an adult than those who did not develop childhood trauma. And those who have multiple levels of trauma over time have a greater risk. We think both of these are involved in sensitization of the amygdala processes, the fear processes. So the more trauma and fear one experiences, the more that occurs over time. We also know that the type of trauma matters. An interpersonal event, a sexual assault, attack by someone you know, is more likely to lead to PTSD than is a non-interpersonal event like a car crash. And part of that, we think, has to do with breaking the underlying basis of safety that I'll talk about later, and that sense of positive emotion. So the things that protect or are resilience factors are most at risk by interpersonal trauma. What we also know is that traumas don't create PTSD immediately, rather they're consolidated over minutes to hours to days. And so what happens in the aftermath, how one sleeps that night, whether one avoids, stays by themselves, and sort of ruminates over trauma versus whether one continues to go about one's daily life and expose oneself and has social supports. Those are some of the critical differences as well in the early aftermath of trauma leading to PTSD versus recovery. And while I won't talk about it today, one of the most exciting areas in the field is how we might be able to intervene early after trauma to prevent the development of PTSD. Once one starts to have symptoms of trauma in the first days and weeks, such as intrusive memories, the nightmares, the flashbacks, avoidance, the increased startle response, also how one responds cognitively can lead to different likelihood of PTSD. Those who develop PTSD are more likely to generalize the threat signals. They might say, I was attacked down that dark alley that night by that man, and initially I didn't want to go to that place, but then I became sort of afraid of being out at night. I became afraid of men in general. I didn't want to leave my part of town. I didn't really want to leave my house, and now I'm just stuck in my bedroom. They generalize the fear, and more things are afraid, leading to dysfunction. Those who recover are able to discriminate. There are safe places and dangerous places and safe people, etc. Those who develop PTSD are more likely to sensitize. Every time they talk about it or have a nightmare or a flashback, it seems to get worse. And this is, we think, has to do with the concept of reconsolidation, where memories get increasingly worse over time instead of being able to be modulated. And that's in contrast to extinction. Extinction is the basis of Pavlovian recovery. And it's the idea is that there's diminished response to cues over time with repeated exposure to cues that are not reinforced by the threat. And this is the basis of exposure-based psychotherapy, but it also happens naturally all the time as people talk about their traumas in a comfortable way within a supportive environment. So a lot of the research now is how do we support discrimination of threat cues and extinction of threat cues, and how do we suppress generalization or overcome generalization and sensitization? So in summary of the general neurobiological patterns, we can think about the amygdala as being hyper-aroused, and areas like the insula and dorsal anterior cingulate being hyper-aroused, hyper-responsive, too quick to respond to threat cues, as if the threat is ongoing and the person is constantly reliving the trauma. And that's being modulated all the time with the threat cue by prefrontal cortex, hippocampus, and other areas. In PTSD, it's as if the brakes have fallen off. The modulatory components of the brain are no longer able to inhibit the amygdala in the normal way. As I shift gears a little bit to some of the other kinds of studies and what else we have learned over the field, I wanted to give a few other examples. Dr. Paolacini Maggio talked about some of our work in at-risk communities in Atlanta. And so for about 15 years, we have been involved in what we call the Grady Trauma Project. And Grady Memorial Hospital is one of the largest charity hospitals in America, based in Atlanta, Georgia, a city of now about 5 or 6 million people. Grady is primarily treats, just due to its location, a primarily Black American population. And because it is a hospital that accepts all comers, it also treats a population that is primarily impoverished. So by U.S. standards, this is essentially everyone coming for general medical care at Grady is below the poverty line. Though for trauma, like car crashes, it can be anyone. Importantly, when we have worked to understand better trauma in inner cities and trauma in at-risk populations in America, this study has become one of the largest studies of understanding cycles of violence and cycles of trauma in at-risk civilians in America. And in this population, we see that about 50% know somebody who had been murdered, so an extremely traumatized population generally. About 2/3 have been attacked sometime in their life themselves, and about 1/3 have experienced sexual assault or experienced childhood trauma. And importantly, we see rates of post-traumatic stress in this civilian population that is not seeking services for psychiatry. They're generally coming for medical care, OBGYN care, pediatric care, etc. But we see rates of post-traumatic stress of around 25 to 30%, and that's rates as high or higher than we see in our military veterans. So again, really driving home the point that PTSD in at-risk communities is endemic and very common and often mostly undertreated. Just an example of types of traumas that we see, both in terms of witnessing attack, being physically attacked, importantly natural disasters. And natural disasters occur everywhere, but within impoverished populations, with often poor infrastructure, we see higher rates of things like house fires. But importantly, if one also is impoverished, one has less ability to recover financially from those natural disasters, doubling the impact. As we think about why some of our communities have ongoing cycles of violence and ongoing cycles of risk, one of the important components is both high rates of substance abuse and high rates of violence exposure, both of which, it turns out, are very much secondary to trauma itself. And in similar studies in the same cohort, we find very high rates of PTSD among people presenting for medical care who have been involved with the criminal justice system, and particularly who have been exposed to some sort of violent crime. And importantly, that risk is highly predicted by PTSD, even when controlling for almost every other factor we can, whether it be sex, age, race, education, employment, income, and substance abuse. PTSD by itself is still an important risk factor. Again, suggesting that untreated PTSD by itself is contributing to some of the aggressive components and some of the cycles of risk itself. And there's many different ways of looking at this. If we also look at rates of exposure, untreated PTSD also is associated with more likelihood of violence, and violence begets more violence. And so we see that PTSD can lead to this, in addition to all of the internal symptoms of anxiety, startle, avoidance, depression. It can lead to increased irritability and defensive aggression, essentially responding inappropriately when one feels one's being attacked, because that's part of the generalization of PTSD, and then can perpetuate the cycle. One of the other most important factors that we see in the U.S. in at-risk communities is very high rates of substance abuse. And we know that substance use is a very high-risk factor for trauma exposure. This is a study also from the Grady Trauma Project, in which we're looking at developmental trauma, early trauma inventory, ETI. And what we see is ranging from low rates of developmental trauma to high rates of developmental trauma, that with every substance of abuse that we look at, whether it be alcohol use disorder, cocaine, marijuana, opiate disorders, all of them show much higher risks in those who've been exposed to childhood trauma. But importantly, as I shift gears from talking about the negative risk factors to positive coping factors, when we look at trauma, in this case audit score, which is alcohol, but it's the same whether we look at any of the substances, if one also has high levels of resilience, and in this case it's measured by a scale called the Connor-Davidson Resiliency Scale, and it's really looking at factors of coping, at factors of social support, at factors of positive emotion. When one has high levels of resilience, one is essentially protected from these increased rates of trauma. So even though one has higher rates of childhood trauma, one does not now have higher rates of alcohol use. So those with low resilience scores, lower coping strategies, have much higher associations of trauma and substance abuse. And we see that for both substance abuse and PTSD. So what do we understand about this overlap between substance abuse, aggression, and PTSD, and all as a secondary to trauma? It comes down to the same networks. So I've been talking about the amygdala as this threat responsive region being modulated by the green areas, the prefrontal cortex and the orbitofrontal cortex and the hippocampus. Well, in the addiction field, and this is a review from George Koob, the director of the National Institute for Alcohol, they focus on these same circuits, but they're primarily focused on the blue areas that are the reward circuits, the striatum and the ventral striatum and the nucleus accumbens. And what we find, and where the neuroscience field is coming together, is that basic emotional responding, emotional regulation of behavior, can be relatively simply thought of as basically negative affect and negative behaviors, such as fear and threat, avoidance, defensive, aggressive behaviors, or positive behaviors, reward, approach, eating, sex, etc. And the negative here is in red, and the blue, and the positive in blue. However, the positive can be overdone in addiction, such as intoxication, binge, and too much. All of these emotional responding are regulated by these green areas. If the top-down regulation is disrupted in development or through trauma, for example, with trauma, now the top-down regulation of PSC, OFC, and hippocampus no longer regulate the amygdala as well, one has symptoms of PTSD, over fear responding. But that generalizes, and that same top-down regulation now doesn't regulate the reward circuit as well either, making one more at risk for appetitive disorders such as addiction. And similarly, if one starts with addiction and has decreased top-down regulation of the reward circuit, that generalizes and puts one at higher risk for PTSD. So both of these, the same brain regions are involved in fear, are involved in reward and positive addiction, and it has to do with this top-down and contextual and safety regulation, so that many of the resilience factors can also work across both. So again, I've talked about cycles of violence and risk and trauma in communities, with risk factors associated with poverty, racism, environmental exposure, trauma, lifelong trauma. All of these interact, poverty and stress and trauma exposure, to disorders like post-traumatic stress, addiction, and increased levels of violence responses. And those are being outweighed in our risk communities by the resilience factors like social support, caring adult, positive emotion. How can we both decrease risk and increase resilience in our communities and in our individuals? So just briefly, how do we treat disorders of trauma and PTSD? I just have one slide on this because it's not really the primary focus, but the two main areas are targeted psychotherapy, medication treatments. And so our first line is actually the psychotherapies, and they're essentially retraining the brain. Prolonged exposure is the most well studied, and the basic idea is one works with the therapist to talk about the trauma. And each time one talks about the trauma, their level of anxiety may go very high, but then recover over time. And with one repeated telling of the event, repeated telling of the trauma exposure, in a safe environment where one is also getting trained for emotion regulation and skills training, the level of impact of that trauma has less and less effect on the person's emotions, on their anxiety, on their threat and fear. And so with exposure therapy, one essentially goes through each of the stories in a very careful way with the therapist over time. Cognitive processing therapy and a range of cognitive behavior treatments, as well as EMDR, eye movement desensitization and reprocessing, are all based on this essential idea of re-exposure and extinction of fear. And I can talk more about how we think extinction works in the discussion. But what we also know, as I get ready to move into the positive valence, is extinction works better in this case of positive emotion and positive social supports. And natural extinction also works better. Our medications are quite limited. We only have 2 drugs that are approved by the FDA or the EMA for treatment of PTSD, and those are paroxetine and sertraline, so SSRIs, and they've been were approved 20 years ago for this. There are other drugs in process, and a lot of the neurobiology is leading, hopefully, to new neurobiologically driven treatments, but we really are at a limit right now in what we can use. I can talk about prazosin in the discussion as well. It's one of the few that has a very interesting targeting the biology of the hyperactive sympathetic system to improve sleep and decrease nightmares. So I want to spend my last 10 minutes or so talking about positive emotion. And how we can maybe able to increase positive emotion through social interaction, support groups, faith groups, and others, and how that may also serve as a critical component of resilience and recovery. One can think of almost all behaviors in mammals as essentially breaking it down to, do we go towards something, approach it, or do we go away from it, avoid it? And we can think of that as trust. Do we trust it, go towards it, or are we afraid of it and fear it? And when I showed the brain diagram a minute ago, we can think of those red regions of fear and threat as being the avoidance regions, and the blue regions of accumbens and striatum as approach. And that this sort of yin and yang goes far back into literature and philosophy. As we understand more about how the nervous system responds to stress, we can also see how this same approach avoidance comes out. And this is one of many examples of sort of the polyvagal theory, with the idea that low levels of threat allow one to go towards positive responses in the world and positive emotion, social engagement, curiosity, compassion, safety, connection, etc. In early threat, one goes to fight or flight, panic responses, anxiety, fear, irritation, rage. These are all areas that are important for the first round of threat, but also can be stepped back from, that they're natural responses to a threat behavior. But when one has chronic stress or PTSD, one often spends more time in this top, where essentially one is shut down, frozen, numb, helpless, depressed. What can we do across systems to increase the positive and decrease the body's being stuck in these freeze or flight or flight systems? And there are many ideas here, but one I'll talk about is the social safety theory from George Slavich, and very much that has come to that. And the idea here that individuals are embedded in a variety of social safety circles: the person, the family, the friends, their faith community, their religious community, their neighborhood, city, etc. And the networks interact with different forms of social safety. In positive ways, that component of cohesion, respect for workplace, welcoming neighbors, but that also opposes where there can be negative components from social networks: family conflict, work hostility, neighborhood violence, perhaps if there's in a war-torn situation, or other sorts of violence, diverse public policy. So that at an individual level, these positive versus negative emotions are at work, and at a social level. Safety, not only is it the concept of safety, is it what is missing in PTSD? There's a lot known now about the biology of safety, starting with the work of Tanenzel and others related to oxytocin and positive emotion, where oxytocin comes both as a reproductive hormone, but is also critical during breastfeeding and bonding in the mother-infant, and it seems to be critical in humans, both with sexual behavior, but also in trust behavior. And oxytocin is in parallel activating the circuits of reward with dopamine in the accumbens and the prefrontal cortex, the rewarding component of positive behavior. And again, all of these seem to be pushing us more towards the social engagement and positive side of emotion and away from the more amygdala and threat negative side of emotion. Again, all of these can be thought of as both the positive and negative sides of social interactions, with both social defense and negative interactions working against attachment and positive interactions, with many different areas of exploration, dominance, affiliation, and caregiving in social interactions. It's also important to recognize that in health, social interactions are critical for reward, and that may be even some of the most rewarding parts of our behavior. In rodents, for example, rodents will bar press. Mothers will bar press to have access to their pups, and rodents that have been socialized will bar press to have access to their friends. And all of this is associated with the idea that social interaction is very positive, very rewarding, and one of the mechanisms we understand of that is the role of the dopamine pathway in activating reward in the nucleus accumbens and striatum. And in humans, studies have shown that in healthy humans, social reward is in a world that seems highly driven by monetary gain. And in contrast, forced social isolation is associated with increased stress and decreased reward. In this case, this is a study showing that socially housed rats have much more rewarding behaviors, in this case taking sucrose, a sweet, that they're much more likely to respond in a rewarded way than socially isolated rats. So that social isolation leads to anhedonia, decreased reward, and in other studies, increased likelihood of trauma and threat responding. So if we take the more complex perspective of fear, such as fight, flight, or avoid versus reward and approach, in many of our complex disorders, we can approach these in different ways, and think about them in different ways. So that the system of fear, fight, or flight via the amygdala response leads to avoidance. The reward activation system via positive bias towards positive stimuli leads to approach. And many of our cognitive behavior theories are built on these ideas, such that cognitive behavior therapy and exposure behaviors lead to behaviors that increase opportunity to learn that feared situations or stimuli are not as harmful, essentially extinguishing that avoidance and fear response. And behavioral activation leads to active engagement in behaviors that are goal-oriented and increase positive reinforcement. Another set of theories has to do with the peer social defense framework, and and I'm happy to share these slides. I'm not going to go through all of this in our limited time, but that positive social reward through attachment theories really has to do with secure attachment, and that whereas where one can flexibly move to emotional pattern to positive and negative emotional patterns and flexible use of behavioral interactions. And that's in contrast to a whole host of mobilizing dominant to demobilizing social responses due to different levels of threat. And that can range from with a lower level of threat being dysregulated distress, difficulty calming down, all the way to high levels of subjective to threat and really looking like, really frozen, shut down trauma responding. And so again, just examples of how this positive versus negative balance is at work in interpersonal interactions, individual interactions, and social interactions. evidence, there's much evidence supporting social safety theory, and again, the social safety idea is both sits within the brain between the positive and negative circuits that I talked about, but also very much within the body, the hypothalamic pituitary adrenal axis, the sympathetic nervous system, and its regulation of heart rate, and the immune system, as well as the vagus nerve and its counter-regulation of heart rate and the immune system. And what we know is that in contrast, or in opposition to our threat evolution, humans also evolved to foster social safety, and that social safety is beneficial for health and behavior, and social threat chronically is harmful for health and behavior. How do we decrease threat behavior and increase safety behavior? And there are multiple different approaches, but one set of ideas, again from Savage, is that there can be strategies at both the individual level and the family and social and community level for increasing positive social safety and reducing social threat. At the individual level, some of our tools like cognitive behavior therapy increase social engagement, reduce social threat. Mindfulness brings awareness to the present, which is typically absent in social threat, where one is all worried about what's next or what's out there, where the threats are. Loving kindness enhances positive emotional states of kindness and compassion, etc. And again, happy to share all these slides. And at the family level, nurturing parenting training to strengthen family relationships and increase positive bonding. Family cohesion training promotes social caring and interpersonal connection. Schoolwork and community, for example, the community reducing bias, preventing bullying, promotes social connection. Building empathy promotes social connection, caring, and empathy. So some of the guiding principles then of broader trauma-informed work is that of ensuring physical and psychological safety, commitment to consistently being transparent in decision-making, offering mutual support in healing and recovery, acknowledging and managing power dynamics, making room for voices, and addressing discrimination and threat. So in summary, I've sort of walked you down a broad range of how we think about threats from an evolutionary perspective to the disorders of post-traumatic stress disorder, some of the main brain regions like the amygdala and insula that are involved in the threat response, and how those are in opposition to some of the reward and positive emotion brain areas, but how both of those are regulated by top-down regulatory circuits, and some of the positive components that we can focus on to decrease threat responses and increase positive responses. In summary, the biology of the brain and genetics interacts with the environment, individuals, families, network systems, communities, and societies for a healthy brain. Threat, the fight or flight or avoid system, is always in opposition to the reward system, which is approach, positive, and social engagement, but when dysregulated is also addiction, and that these behaviors are critically evolutionarily conserved. Trauma via the fight or flight system leads to decreased social interaction, avoidance, chronic disease, and PTSD in the extreme in individuals, even though we're evolutionarily conserved for being able in short bursts to fight or flight or flee for survival. The effect of untreated trauma on systems and communities is destabilizing and can lead to cycles of trauma and dysfunction and cycles of violence. Understanding threat and fear systems is critical to understanding defensive responses, and understanding the affiliative, positive, and attachment and reward systems are critical for recovery, and that very much can be brought into community groups, faith groups, families, and social systems. Importantly, PTSD can be treated, and trauma-related behaviors can be improved to stop cycle of trauma and heal individuals and systems. So with that, I'll say thank you. I'm happy to take questions and discussion now, and also happy to share my slides and to email follow-up for anyone who is interested. Thank you very much for your attention, and I look forward to discussion.
Thank you very much, Dr. Resto. That was very that was very informative. Professor Bantu, does anyone over there have questions?
Yeah, thank you very much, Professor Laslag. I want to thank you very, very much.
Thank you.
You've taken us through PTSD.
I hope that that was clear enough. I know it's
yes.
A lot of technology between here and Kenya.
Yes, my name
no, it was very clear.
Yes, you've really taken us through vital concepts in PTSD, and as you are articulating on the PTSD and the veterans, and also the civilian. And then I was looking at the misconceptions that Africans have on PTSD. And as you are articulating, I said, I wish then we could be able to have a psychological laboratory. This psychological laboratory in East Africa would put in place the infrastructure, like at this university, in Kenya Methodist University, we are thinking that if we can have a psychological lab so that people would be able to access the assessments, they would be able to do activities, and then we provide lab would be our primary aspect. The only weakness that we may have would be the infrastructural frameworks, the human resources, but since now we are thinking of a collaboration with the Maclean Hospital, then we could be able to exchange some of these facilities, then training programs and dialogues like this. Professor Peter Baguma was supposed to also present the experience of the veterans on PTSD in East Africa. And since we've been doing psychosocial support for the post-mission guidance and counseling, we see a number of these traumatic experiences coming on. And these post-traumatic distress disorders affect individuals, affect families, and the community. So one of the entry points that we could be able to envisage is a psychological lab. Then in so doing, we should be able to do a research. We would be able to do a research and we compare the interventions. There are those who really suffer from these conditions and we don't know the current statistics, like conducting research studies to better understand the prevalence, risk factors, and effective interventions for trauma and PTSD in East Africa. That could be very good. And then you talked quite a lot on community engagement. Community engagement, collaborating with local communities, organizations, and policymakers to raise awareness, reduce stigma, and advocate for improved mental health services. Like I came through the Inter-University Council for East Africa Mobility Exchange in Kenya. So you'll find that all governments and nationals are interested in the mental fit of their people, but then there is no structured system that is able to be, say, a referral, like someone who has been in military and is supposed to join the community. So sometimes it is difficult to know how to assess this person. We only get conditions from the social justice system when a problem has already come on. Like we experienced, like in Kenya and I think in Uganda, there was an aspect where pastors and clergy made people go into faith which can lead them into death. And as a result, we should have really been able to have a lab where we can be able to cause these people to go through the assessments. And I think, Professor, I see a number of opportunities. If, for example, we can, Maclean Hospital can help. One of them is shared infrastructure. I know Maclean Hospital can provide technical expertise, training resources, and guidance in establishing and operating the psychological lab within East African universities. Number two, Maclean can offer capacity building initiatives, including workshops and dialogues like the one we have held these 2 days, seminars and exchange programs to enhance the skills and knowledge of local professionals in trauma-informed care and evidence-based practices. And also we can do, Maclean Hospital can collaborate on research projects related to trauma, PTSD, and mental health, fostering partnerships for knowledge exchange and scientific advancement. In terms of resource mobilization, I'm very clear in my mind that Maclean Hospital can be able to help us do fundraising efforts and grant applications to secure funding for the establishment and sustainability of the psychological lab and related initiatives. As long as we are of one cause, serving the community and service to the public, and having a clear mindset of the understanding of these psychological conditions, it will help us. You will not take a day without noting the number of suicide cases in military, among students, among the community. Every day people are talking about people committing suicide. Most of these conditions are a result of undiagnosed PTSD or other psychological conditions. So this lab would be able to help us promote most of these conditions, and I am happy that this afternoon you've shared with us, which is I think your morning, you've shared with us a very important subject, and as you are aware, addressing trauma, PTSD, and mental health in East Africa requires a multidimensional approach which should integrate biological, psychological, social, and spiritual dimensions of well-being, which you have really shared in your slides. And therefore, understanding the neurobiology of fear provides insights into the underlying mechanisms of PTSD and informs the development of effective interventions. In fact, in the Bible, when God created Adam and Eve and put him in the Garden of Eden, it is surprising to note that when God had created them and put them in a good place, you see them moving away from the garden. And when he appears again, the answer they give him, we feared and we hid ourselves. So I think this kind of dialogue is very good because we can begin from the evolutionary aspect of creation, and then we bring people together. So the intersection between this spirituality, psychiatry, and mental health care is very important, and I think it is going to help us move further. So, Professor, I want to thank you very much, and my request is that we would augment on the lab that we envision to set up, and I can assure you, in so doing, we can even begin concepts on digital mental health, so that when we have issues that are affecting the society, we can be able to explain some of these conditions like trauma, PTSD, and neurobiology of fear, because fear is the beginning of these other psychological conditions. So, Professor, I'm excited that once you address some of these issues, you'll be like our hero. You know, heroes always got from very far. So if this is done, I believe that would be the first stage to addressing some of these psychological conditions. Professor, I think I have finished my submissions, and I do not know what you have to say about them. Thank you very much.
Well, Professor Bantu, that is remarkable. I'm extremely honored and very excited by all that you say. I think we're very much thinking along the same lines. I think your summary of the work in the talk was much better than the talk itself. So thank you for that. I think your ideas of having sort of, at Kenya University, a psychological lab that could be a center of both advancing treatment and training for providers, as well as research to better understand the risk factors, the effects, the biological and the psychological and the community ways, and as a center for community engagement and training is a wonderful idea. And while, of course, there would be many details to understand, the one I would be honored personally, and as McLean, if we could be involved for ongoing discussions for advancing infrastructure, community building, knowledge exchange, and resource mobilization. And I think, as you say, the tools, that we're blessed to live in a world that allows us to have digital communications across the world like this, so that I think the barriers are low and the enthusiasm is high for finding ways to work together. So I look forward to those opportunities. Thank you.
Yeah, thank you, Professor. Maybe what I needed to mention here is that in East Africa, we have a number of universities, and in this dialogue, we have representation from a number of universities. Now, where we are, Kenya Methodist University is surrounded with a number of universities. Just to mention a few for your note, is that we have Meru University, which is very close to this university. And this university, where we are holding this summit, has a well-established medical school. And then we have Makerere University. Makerere University is one of the old institutions in the land, and they have an established school of medicine. We have Kabare University, where I'm coming from. This Kabare University borders 3 countries, that is Rwanda, Burundi, and DRC. DRC, these are French-speaking country, and then Uganda. Those are 4 universities, or 4 countries, and with a number of universities. We have Uganda Matters University. Those are in Uganda. And then we have the University of Kinshasa and the University of Rwanda. And then here we have Meru University, we have Chuka University, we have Embu University, we have Tharaka-Nithi University, we have Karatina, and most important, in this region, there are incidences of cancer. And one of the risk factors is alcohol and drug use. So when we have a laboratory, a psychological lab, it is easier for us to organize treatment modalities for them. Now, this university extends to Mombasa. Mombasa is one of the seaports in the country, and it has other universities like Technical University of Mombasa. It has Pwani University, and other universities surrounding that campus. And then also we have in Central, we have University of Nairobi, we have USIU, Kenyatta University, all those universities you can see. So the reason why I decided to choose Kenya Methodist University to be my area of operation during the Inter-University Council for East Africa is because of the stretch and the location where it is. And if we can begin a center, as I mentioned, at the university, we also have Kisii University on the other side in Kenya, and all these universities within East Africa have not a well-established center of mental health and psychological lab. So by starting up with this, I think we can make strides into wellness of the society. Thank you very much. I think that's basically what I wanted to mention, so that you are aware that we have these institutions at hand and we can be able to work together as a team. Thank you very much.
Thank you for educating me a bit on the remarkable collaborations and opportunities that are there. And again, I very much look forward to future discussions about how we can be involved and collaborate with you. It would be a real honor. Thank you.
Thank you.
Dr. Carlo, you are moderating this session.
Oh, I'm moderating.
You're the one moderating this session.
Okay, is there any questions in Kenya?
There are a couple in the chat I can respond to if that would be helpful.
Okay, yeah, let's go with that.
So Dr. Jacinta Calucho said, thank you. Might you have done any research on post-traumatic growth? And the concept of post-traumatic growth, for those who may not be familiar, is the idea that many people have traumatizing experiences, and while it may be very stressful for a time, they find that afterwards they may feel stronger or more able to overcome things. And there's not a very large literature yet on really understanding the mechanisms, but the idea is that if one is, in animal literature at least, if one has a threat or stress situation, but one is able to overcome it, and particularly the concept of controllability and predictability versus in situations where there's uncontrollability and unpredictability, one is able to, some of those in rodent models show when they can control the trauma, the stressor, they're actually more robust and more resilient to future stressors. And so that's this idea of post-traumatic growth. And as we can, it's mostly around developmental trauma, but I think also in adults, there are therapies focused on by both understanding what happened, or at least trying to make sense of it, and then learning from that how one can be stronger in the future. But would love to talk more about that. But it's an area that I think is very important, but that we don't understand enough about. And then the second question from Dr. Varkias was, as an educator, it gives me hope that resilience may be able to be learned and supported. What about using expressive arts therapies as part of holistic trauma care? And I think that's very important. Dr. Kias also shared the Body Keeps Score Vanderkolk book. And again, I think PTSD, because it affects so many parts of the brain and the body and the mind, sometimes it is hard to access those just with language. And a lot of the cognitive behavior therapies are sometimes limited by not having the right words to express. And that's in some ways why things like EMDR, eye movement desensitization, may be helpful, because it keeps the person very grounded and it is less verbal in the exposure. But I do think in the same way that holistic arts therapies and other ways of expressing the trauma, and certainly see this all the time in children doing play therapy and reenacting the trauma with play therapy, can be very, very helpful. So there's absolutely a very important point for other interdisciplinary ways of allowing the person to express and being in the present, because so much of what happens in both a PTSD reenactment of trauma or in a panic is that one doesn't feel in the present. They instead are either in their mind or in the past where the trauma was. So a lot of the exposure-based therapies are based first on emotion regulation skills, like we see in dialectical behavior therapy, where it's about emotion regulation, grounding, diffusion techniques, and others. If you want to send me an email, happy to point you to some of the tools. But there are a lot of therapies now that are focused on helping people deal first with that emotional overwhelmingness before one does the exposure work. Thank you. Thank you all, and I look forward to more opportunities, and happy to share the slides and other resources as are helpful.
I have a question. Who will respond? I have a question.
Is that mic open?
So can I go ahead? Okay. Thank you very much, Professor, for that detailed presentation. My mind goes straight to the interventions for PTSD, particularly to the aspect of PTSD that is becoming quite common in our clinical setups here in Kenya. I don't know about elsewhere. And this is the CPTSD, the complex PTSD. CPTSD seems to require slightly more than the regular treatment models for PTSD, including trauma-focused CBT, EMDR, cognitive processing, in fact, all the ones that you've mentioned, Prof. In your experience, please comment on CPTSD and its effective intervention. Probably, you may want to mention psychodynamic psychotherapy as a first line of intervention, so as to deal with the adverse childhood experiences, which seem to be the trigger for CPTSD. And finally, this is in a comment in the area of corroboration, now that we need to work on. Thank you.
Recording in progress. PTSD-like symptoms, but a lot of more complex depression symptoms, but attachment problems. It can look a lot like borderline personality disorder. We think that borderline personality disorder is often associated with trauma. Can Kenya hear it? Are we back with Kenya? We were frozen for a moment.
We are hearing you. Proceed. Thank you.
Okay. Okay, I'll go ahead and respond. Thank you so much. Those are really important questions, and I think I agree with everything you said. Complex PTSD is associated with developmental trauma and childhood trauma, particularly childhood sexual and interpersonal trauma. It's associated with all of the symptoms I mentioned, but very much so also with attachment problems and interpersonal social relationships. So in the same way that I talked about social interaction and support is such a protective factor in PTSD, with complex PTSD, that important point of resilience is actually lost because it is so hard to Sorry, can you hear? Should I keep going? Can you hear me?
We're hearing you. We're hearing you.
Yes.
Okay, great. So I agree with your points. Psychodynamic psychotherapy, generally there's less data for it, but anecdotally it is certainly very helpful for understanding developmental trauma. As you said, dialectical, but DBT PTSD is one of the ways of combining emotion regulation with exposure, similarly EMDR and CPT, but definitely there's a role for psychodynamic therapy as well in helping people to understand and really come to sort of a component of the existential issues related. So there are many different approaches to this, and I agree with your points. It's very CPTSD is difficult both because of the level of trauma over time, as well as how it disrupts the social bonds that are so important for recovery. Thank you.
Thank you, Dr. Ressler. So just for the interest of time, I know Dr. Ressler has another meeting that they're waiting for him because I hear them calling him. So I have his information and we can continue on with these collaborations. He's going to share with me his slides and then I can share with Professor Bantu or Colin, and then Colin can then distribute them to the participants. Thank you very much, Dr. Ressler. I really appreciate it.
It was a great honor. I look forward to future opportunities, and please don't hesitate to reach out to me. Thank you.
Let us applaud the professor before he takes off.
Thank you very much.
Being informed. Thank you very much. I'm tasked to moderate, but I don't know whether Professor Caro, you are still around, because I'm seeing you are to introduce. You are supposed to have a presentation, and then we need Professor Sifa. Did you say Professor Sifa is going to present? And
yes, that's correct. And I will introduce Dr. Singh. Yes.
Yes. So I would requesting you that you can introduce Professor, and then we move on.
Okay, perfect. I'm really excited to have you, here today with Dr. Singh. So she is a licensed clinical neuropsychologist and the director of digital cognitive research at Harvard Medical School and McLean's Hospital Institute for Technology and Psychiatry. Her research aims to modernize neuropsychology by leveraging digital technologies. And to this end, she has a number of industry partnerships to determine ways to incorporate and validate digital tools that can be used to improve neuropsychological evaluations on a global scale. Dr. Singh is passionate about improving healthcare. She works one-on-one with patients in her private practice at Cambridge Neuropsychology, invests in early-stage startups through her role as an associate at a venture capital fund, and teaches courses related to technology and mental health to undergraduates at Harvard. Dr. Singh also holds leadership positions at the APA, American Psychological Society, and as well as the SCN, and serving as the president of Division 12, Section 10. And so she's also a board member of various institutions and a past neurotechnology officer. So we're really excited to have her here today. Thank you, Dr. Singh.
Thanks so much. It's great to meet everybody. I was in Kenya about, I think, maybe 5 to 7 years ago. One of my parents are psychologists, and one of their colleagues is a psychologist in Kenya. And so it's really nice to be able to talk to you. And, it's nice that Zoom is here for us to facilitate these types of conversations on a global scale. So what I'm going to do here is just share my screen. And just let me know if you can see it, okay? Is it good? Okay, great. So what we'll be talking about is how we measure someone's everyday functioning using technology. And my particular specialty is clinical neuropsychology. And so what I'm looking at is to see how we might utilize tools to modernize our field. And not just neuropsychology, but the healthcare system in general. So to that end, I'll sort of give some background and rationale for why I do this work. We'll talk about some ongoing projects we're doing and new and launching projects as well in the lab. So the first question really is, why do this work? So how do we measure cognition and neuropsychological functioning today? We use tests that are really sensitive to cognitive function, but not specific to specific diseases. And the problem with that is that there are issues establishing ecological validity, in that all of our tests are done in a really controlled environment, and we're only really getting a snapshot of our functioning. And I think this is a problem in our healthcare system in general, where someone comes in and we see them at a single time point assessment, but we can't see them outside. Our tests also have a lot of limitations in that there's limited normative data, there's culture bias, and there's age bias as well. For example, I can tell you most of my students would not know what this cassette player is on the right. And then in the absence of noise, our tests are quite noisy, in that they don't account for contextual factors that are really readily quantifiable. And so my work aims to fill gaps in these gaps in traditional neuropsychological testing by leveraging digital technologies. This will improve our ability to characterize cognitive and psychological functioning in a way that is more ecologically valid. And in turn, we can use these digital tools to improve international data acquisition. So data we capture from around the world. And the studies that I'm going to talk about, they're using a platform called Test My Brain, which was developed by my postdoc mentor, actually, Laura Jameen. And they have normative data from over 3 million people internationally. And so our digital tools are really robust and have really fantastic normative data. So what are the specific digital tools that I'm talking about here? There are cognitive ecological momentary assessment, speech and EMA, context, and additional tools. So I'll sort of break this down here. So what we do is, you know, because we're seeing a patient in a single time point of assessment, we want to be able to capture the patients outside in their everyday lives. Why? Because it's more valid, right? We can capture sort of their fluctuations in their cognition, their fluctuations in their mood. And so what I use are digital cognitive tests that we've developed, but also speech tests. Our work with IBM has demonstrated that speech can predict Alzheimer's disease with about 80% accuracy. So that is a very, very sort of unique tool that we can use to capture everyday functioning. And I always look for things that, you know, we can use as proxies for these cognitive tests that we give our patients. And this even goes back to, you know, psychotherapy. Like, so with speech and cognition, they're related to specific cognitive processes, like, or psychological phenomenon. Like, so specifically with cognition, you have lower processing speed, sometimes lower attention, and things like depression. And that combined with speech, you know, characteristics, you can predict how likely someone might be to develop depression. And with using things, this thing called EMA, which is ecological momentary assessment, this is a tool that can capture fluctuations in everyday functioning outside of the clinic. You can also just capture someone's context and environment, which is something that we don't really capture when we're seeing patients in the clinic. So you can capture environmental noise and psychological context as well. There are also a lot of additional tools, some of them you may have heard of, like face recognition, computer mouse clicks, pressure pads, those types of things. And they can tell us a lot about cognition as well. So what do these tests look like? Now, we specifically use, again, Test My Brain, which has over 3 million international folks that have taken these tests. We have a lot of normative data. And we look at things that we look at in the clinic anyway with our traditional neuropsychological tests. So working memory, attention, processing speed, so how fast you're processing information, memory, one of our biggest ones, something called executive functioning, which is sort of a broad category, but really sort of captures sort of switching between tasks or multitasking, higher order thinking, and then perceptual reasoning. And so we can give all of these tests to our participants. And so then with the speech EMA, this is sort of our work with IBM, and they have, IBM has found that with 75% accuracy based on something called a cookie theft task, where a person would describe sort of an image that they see, if you analyze their speech characteristics, you can predict Alzheimer's with 75% accuracy. That's actually a lot better than our traditional methods for understanding Alzheimer's disease. Even if you combine PET and ApoE4 and all these other things, you only get about 40% sensitivity. So I think that speech is really a frontier that we should explore quite a bit more in our field, because it relates so much to cognition and psychological functioning. And if you think about doing international research, you know, all of our tests that I give in my lab are completely remote. And so someone can do them in the comfort of their own home, but we'd then in turn we'd be capturing data that, you know, isn't clean, right? Because they're not just in our clinics in a quiet environment, but they're out there in the world, and we're able to see how they're sort of doing in their everyday lives, which is unique to this type of work. So this is an example of one of our speech tests. So you can click a microphone and say, the quick brown fox jumps over the lazy dog. It doesn't feel like much, but actually you can tell quite a bit from these types of sentences, where you can look at very specific nuanced speech characteristics and kind of determine you know, what sort of prosody and intonation they're using and how that might relate to their cognition. And this is a very complex slide, but it's really quite, it's actually much more straightforward. So this is an example of the type of data that we get, where each cell is sort of an individual person. And within the individual person, you can see that some people don't have a lot of change, like cell 24 here, but some people have quite a bit of change, right, like cell 40 here, right? And so that tells us that we can't really capture like most of our studies are between people, right? And we actually find that people are unique in their own specific ways. And so you can capture, using this method, lots of different variability in different people, or in the same person. So this is a study that we published last year, where we're sort of looking at different tests, different cognitive tests, and seeing how accurate they are. And we find that, you know, if you give about 10 EMAs, so 10 of these tests remotely, you can actually demonstrate really good reliability and validity. So our big project right now is, during the pandemic, we had a huge issue. We faced a huge issue as clinicians because we had no way of testing patients. Our tests are actually mostly paper and pencil. And so when we translated them to, when you translate our tests, my dissertation work was on this, when you translate tests from paper and pencil to digital versions, they're not valid and reliable in the same way. And so what we did is I kind of worked with our lab to create something called the Test My Brain Digital Neuropsychology Toolkit. And what it is sort of this battery of tests that you can choose sort of any test you want, and then you can look up the normative data here. So a female, 21 to 30, 7 to 11 years of education, and you can find out the standard score. And that's really what we do for our traditional neuropsych tests as well. But this allowed neuropsychologists to work again during the pandemic, because all of our tests, as I said, are meant to be sort of administered in person. That's how they were standardized and normed. And our data demonstrates that these tests are valid and reliable within each cognitive domain. So right here we've got, I'm just going to move this here. We've got processing speed, working memory, and general cognitive ability. And as you can see, you know, in fiscal year 2021, we had 31,000 new test and survey completions. And this just demonstrates, and of course it's gone down as pandemic restrictions have lifted, but you know, we filled a really a big niche there, and we're very proud of that. Now, in our department, what we're trying to do is implement something I developed called, with Laura Jameen, called hybrid neuropsychology. And what that is combining digital tests and in-person tests that are traditional to augment our evaluations. And so the first thing is, you know, we're looking at demonstrating equivalence, cross-validating traditional and digital tests with specific disease markers, trying to achieve diagnostic clarity, looking for patterns captured through digital responses that translate to specific cognitive impairments. Then also looking at performance validity. So performance validity means, is someone engaged or not in testing? This is really hard to measure in a neuropsychological setting, but very easy to do in a digital setting where you can look at item level responses and variations so you can determine cutoffs identifying patterns of inconsistent responding. The next thing we're doing is developing, and this was actually with Dr. Ressler's group, we're developing rapid scalable sensitive batteries. So because our neuropsych tests are so long, we are trying to make them, we're trying to use very, very ultra brief cognitive testing to be able to triage people and in sort of levels of severity. So, you know, high severity, medium severity, low severity. And that way we can use digital tools to better triage patients to either receiving a full neuropsych evaluation or providing them with you know, specific recommendations based on their current level of functioning. So we're determining, again, the most streamlined battery to be used for all our inpatient units at the hospital. And our preliminary data, the goal, is to develop a better understanding of the ways in which cognition, mood, and patient-specific data using electronic medical records relate to diagnoses. And this is something that can be done on an international scale. So, you know, we have the ability to sort of look at patients across the world in different hospitals, right, and see sort of how all of these things kind of come together and might help predict and shorten the time that they need for an evaluation. So another thing we're doing is, so metabolic disease is interesting in that people with metabolic diseases have lots of fluctuations in their cognitive status. And so what we're trying to do is look at cognition, speech, mood questionnaires, blood phenylalanine levels, and also and using finger pricks, so at each EMA point. And so we're looking at 6 measurements over 1 month and varying it by the time of day and day of week. And what we can do is see how cognition, speech, and psychological functioning and blood levels vary together. And so that way we might be able to predict with very streamlined batteries on an international scale how we might quickly diagnose and patients and their level of severity on these different tests. And these are, again, completely remote tests. So one thing that we did was first we built a cognitive and speech battery that's specific for patients with phenylketonuria, which is the metabolic disease that we're primarily focusing on. In addition to type 1 diabetes, our lab in general is focused on that. Validate cognitive and speech battery and streamlined it. So that is what we're doing right now. And we're using the battery to monitor individuals with PKU over time, so we can develop digital diagnostic tools that can help determine prognosis in an individualized way. The goal is then to integrate these batteries into clinical practice and clinical trials around the world. And disseminating it both nationally and internationally will help really promote equity and accessibility. So we're also, so we found that, you know, with IBM, that speech acquisition can really serve as a proxy for cognitive functioning and correlates with blood-based biomarkers. So we can collect patients' verbal responses to tests we give regularly, like semantic fluency, and then we can look at things like response times between words and the frequency of words. That was actually directly related to blood levels. So imagine you don't have to necessarily get your blood levels taken. You can just answer a few speech questions and get your response, and get a really good prediction of what your blood levels are. And this moves us towards precision medicine, which many of you are probably familiar with, where our tests can be integrated with biological and biometric markers. And so as you can see here, looking at the time between someone's words and the frequency of words can be really predictive of, or can be really correlated with blood levels. So now my work has really transitioned sort of along the same line to identifying, characterizing, and stratifying disease using the methods we've discussed already, just on a larger scale. So I'm part of this program called the NIH Bridge to AI program. And what we're doing is we're using artificial intelligence to better characterize and treat mental illness. We're recruiting US-based neuropsych clinics, specifically those that upload raw data into electronic medical records. We're looking at discrepancies between self-report and clinical diagnosis. And then we're launching a pilot at McLean to see how voice and traditional neuropsych test performance plus electronic medical records can help characterize disease. So we are also doing this in patients with cognitive impairment. So we provide traditional neuropsychological evaluations, cognitive tests, and speech tests in the wild, so in someone's everyday life, to better characterize and stratify degrees of cognitive impairment outside of traditional diagnostic criteria. And then we're developing a conversational AI that can be used to chat with individuals over 65. And the goal will be to improve mood and to predict prognosis of patients with mild neurocognitive disorder. And then finally, we're developing cognitive interventions using ChatGPT. So you can imagine creating a book club, and an older patient has to summarize what they've learned. So not only can we characterize their speech, but we can also look at their memory and see how close their responses quantitatively match to the ChatGPT responses. So that's what we're working on right now. And then, so moving forward, what we're building in the lab, we're developing a lot of protocols to provide Fitbits, Apple Watches, actigraphy monitors to patients who have appointments within the next 6 to 12 months with a healthcare provider. And what this would do is, you can imagine, we have patients who come into the hospital. They've been on a wait list, for 6 to 12 months. Our wait list sometimes goes up to a year. What if we could have data on these patients, that is over an extended period of time before we even see them? And that's the idea of this sort of work, is providing these Fitbits, these Apple Watches, these actigraphy monitors to patients, so that way we can look at, hey, in between March and April, you actually had a lot less activity. And so why is that? What happened? And so that can provide, again, better context for us when we're trying to look at patients more holistically outside of the clinic. And additionally, we're trying to speed up our healthcare system. Our reports take a long time to write. Most providers spend a ton of time. I'm sure many of you know this. Most providers spend a ton of time sort of writing notes. And we're trying to figure out ways that during a clinical interview, we can use something like a speech software to look and see how someone's speech is during your intake and integrate that into reports. And we can do that using machine learning, natural language processing, and AI. And if you can imagine, with the Fitbit and Apple Watches and actigraphy monitors I mentioned, we could even have a biometric section of a report where, you know, you sort of, where it can combine sort of their activity and their speech patterns and everything over 6 to 12 months before they even come to the clinic. We're also trying to develop a clinician dashboard that has biometric voice and digital cognitive data that can be readily used by clinicians. A big sort of issue with the clinician dashboard is the sort of barrier to entry for clinicians. I think that, you know, we aren't data scientists, and so understanding what's most useful would be the particular problem pain point here. And finally, you know, this is one is specific to neuropsychology. We have very quantitative data summary sheets for a wide variety of clinics. And maybe we could just, you know, feed them into a machine learning or AI model to determine how we might streamline diagnosis and report writing. So this was sort of an overview of some of the work that we're doing. I think that it has quite a bit of, you know, of applicability on an international level. And I hope that, you know, this can sort of spring some collaboration and, you know, some thoughts, some food for thought about the future. But I'd just like to thank all of the following people, and thank you for listening and your time.
Thank you, Professor Singh.
I think we have a Q&A, so any questions?
Yes, any questions? Any questions from participants, both physical and online? Any of you? For me, I found it a bit interesting, although I came in a little bit late, where you are substituting speech for blood. That's a bit interesting, so that next time when you go to the hospital, you don't have to give blood, no needles. You just say hello, and somehow somebody is able to detect what is wrong with you. That is an interesting future.
Yeah. So I mean, yeah, because we could predict. I mean, we can predict Alzheimer's with higher accuracy than we can with a combination of PET imaging and genetic testing, and so we can capture a lot through speech. And so it's not quite there yet, but you know, I think in the future, once we validate longer speech samples and that type of thing, that's something that, you know, we're hoping for. And if you think about, you know, ease of access and equity and accessibility on an international scale, that's something that could really sort of streamline and make our world a bit smaller in research, so we can, you know, incorporate things on a global scale.
There is a question here from Dr. Mwamisi. He is a medical lab professional. And Dr. Mwamisi, would you like to ask for yourself?
Thank you, Professor. I have enjoyed your talk, your presentation. My question is, if we don't use maybe samples or so, is my talking, saying hello, greeting you, can you analyze my stool? Can you analyze my urine? Can you analyze body fluids and all that stuff? Is that software, that machine able to do that? And if that is great, that's so, we would really appreciate and have a great collaboration with you. Thank you.
Yeah, I think that I think there are some labs that are sort of looking at that. We don't particularly look at those biological samples, but I think that, you know, on the speech front, if you can incorporate some things that look at, you know, speech and as they relate to all of these different things, maybe you could offer some prediction. But no, we don't, unfortunately, look at those things yet. But I think that they're interesting, especially as microbiome research gets sort of more popular in our science.
Okay, thank you. And for some of us who love science fiction, in the future, there are some people envisage a person getting into a room or a smart house that actually is able to detect your physical, mental, and even health status just by analyzing your status, whether it is the way you are moving, the way you are talking. So actually this one is a good start, and it is very interesting. Some of us cannot wait to see it actualized here in our countries. Thank you so much for the research that you're doing, and it is very, very applicable and very relevant. There is another question for you.
Yeah, I also just wanted to say there are smart houses that are being developed in Washington State University where they can detect your movement, and they can detect if you've taken your pills that day, because they have weight sensors and sensors sort of all over your house. And so the data are very noisy, but for now, we do have those, but they're just on a very small scale.
Great.
Okay. Thank you, Prof, for that amazing presentation. I think as every other participant will agree that the digital way is the new way and is the future. And especially on these tools, the diagnostic and assessment tools. For me, I would like to ask how you plan from the other side to make them accessible and affordable to us, because looking at the traditional tools that are maybe available maybe for psychologists, some of them are quite exorbitant, both to the practitioners to purchase and also for the clients to afford. Maybe even if they are not available to all of us as individuals, they can be made available through institutions, so that we know if one has to be assessed, then a certain institution, for example, ours like Kemo University, they can be able to be offered here, even as we try to cascade them in future to all the practitioners. But thank you for that new frontier, and I think I will be looking forward to following you on the other avenues where you publish and get to learn more. Thank you very much, and welcome back to Kenya.
Thank you.
Okay, thank you. That was a comment. Would you like to say something about it before I give you the next question?
I agree that, so we can make these tools are totally remote and free right now, especially our cognitive tests, through institutions, there's, through your grant funding, there's mechanisms for creating your own test batteries, but the digital neuropsych toolkit that we distributed was totally free. And so that's sort of why I do this research, is that it's very easy to do it in any country. All you need is a laptop or a computer or a smartphone, and you can, we can send you a link and you can open it and you can do all these tests completely remotely. And so that's really sort of the highlight of these tests, is that they're free and they're completely remote, but they are more sensitive and specific than our traditional methods.
Okay, thank you.
Thank you, Dr. Singh.
There is a question online. And then we can be able to go back there. Dr. Penina K. Mwenda is stating that this one is a good discovery in the mental health domain. And then he has a question. He wants you to clarify how we link digital neuroscience with the psychometrics.
So psychometrics are part of validating our digital neuropsychology tools. And so all of the sort of like the validation studies that I've done, I think it's here. So these studies that we've done are using psychometrics, the development and psychometric characteristics here of the digital neuropsych toolkit. And so we're looking at psychometrics to demonstrate that these tests are robust in clinical populations.
Okay, thank you. There was another question from the US. Kindly go on. Question, comment?
No, I was just going to say, if Dr. Singh, if you can send me those links, and then I can share it with FEMU.
So it's through testmybrain.org. That's sort of the let me see. If you just Google Test My Brain, that's sort of our platform, and you can take tests right there. But to create batteries, there's no one specific link. Like, you would just have to contact me, and then I would set you up with someone who can create your own specific battery based on your needs, because not everyone needs all 50 tests that we give. So I'm happy to sort of facilitate that connection.
So you mean by one person's needs or by an institutional need?
Well, it depends. I'm guessing one person at an institution that would need to use these tests. There's not like one link that you can use to access sort of like all of our tests. Like, you can go on Test My Brain and take tests for free, but if you want to use it in research, reach out to me, and we can create a specific battery based on what you actually need.
Oh, I see. Okay.
Okay, thank you. Is there any other question, a comment for the presenter? Any other question or comment? Okay, thank you very much. We've not had a lot of uploading. I don't know whether you're uploading your presenters, but I want us to prepare so that we can upload. This one was really interesting. Not that the others were not interesting, but I am sitting here now. Can we upload this one? Thank you so much, and keep up the good work.
Me participating today.
Just in a moment, the next presentation will be announced. Thank you, and God bless. We were talking about digital tools and neuroscience. Okay.
Thank you very much for sharing on digital technology. I would like to augment on this kind of technology. And as we said, we want to establish a global center of excellence in psychology and mental health. We still lack equivalent concepts in our local languages. Like, for example, I don't know if I asked most Africans to speak or say these languages like schizophrenia. We don't have an equivalent. If we talk about dementia or delirium or Alzheimer's, those are conditions really that do not have equivalent names. And most of the facilities we have within the countries, and especially one in Kenya, where people are treated, is called Mathare Hospital. Mathare means madness. People have run mad, are taken into such institutions. And then in Uganda, they have what we call Butabika. Butabika is getting mad or mad. So these conditions have no equivalent. So now envision the establishment of a mental health facility or laboratory within this region. We could be able to share some form of technology that can be used to translate some of these conditions. We have been using the DSM-4, that is the Diagnostic and Statistical Manual for Assessment of Mental Disorders, classification 1, 2, 3, 4, 5. But there still remains language And these institutions that we are here combined have all the faculties of languages. You find in some of these universities institute of languages, and therefore we would wish to require whether we can have a technology that can be able to translate some of these words so that people can be able to understand them than misconstruing them to mean something different. Like, for example, if someone has a psychological condition, you hear people say that he's mad, he has been bewitched, he's a curse, he's demon possessed. So once we have the proper names, nomenclature in our African languages, then it is easier for us to address them. And I'm very sure that you can advise. I don't know whether you are still around so that you can advise before we go to Professor Caroline, who is supposed to present hello?
Hello, hi, Professor Bantu.
Yes, yeah. Yes, so I think we could be able to share some of those digital frameworks or digital, because I was also thinking that we need to have a curricula in terms of digital mental health. One of the presenters in the morning talked about the advantages and disadvantages of digital mental health. But to me, because she was assessing the impact of digital technologies on the holistic health or frontline healthcare providers in Kisii, but I feel that we need to have and augment an infrastructure in terms of digital mental health. And since we are envisioning to start that facility to provide psychological first aid, it would be very important to have the former technology translating it in the local languages. What is your opinion about this?
Yeah, so this is my personal opinion about the DSM-5. Okay, so I think that sometimes, because there's still, this research is still evolving, right? And sometimes we get caught up with titles and these trying to fit into a box of the DSM-5. I think it's important to realize that the DSM-5 is based on studies, like this is from based on studies that are predominantly from a certain group of people, right? Predominantly white European people. And so I don't think it is also very culturally sensitive to a lot of our cultural different aspects of it. For example, I'll give you an example. My dad was diagnosed with Alzheimer's, and I remember so my dad is from Chile, and he has a very stern personality, and he's a very strict guy. Like, he's very, overboard, And so when I brought him I remember I brought him to a doctor, and he tried to tell me that my dad had some mental illness. Like, my father at the time was 65. And he's like, look, I think your dad has, he was going through the DSM-5, and I'm looking at him like, no, this is something, what I'm bringing my dad for is something beyond his normal behavior. I'm like, this is something that I'm seeing, and I don't think it's that, because, I'm not going to bring him to you at 65. I would have brought it to you when he was much younger. So I think that a lot of times we get caught up in these labels. And, I always speak to psychiatrists about this and other practitioners. I'm like, the same symptoms for, let's say, bipolar disorder or bipolar 1 or bipolar 2 or major depression, some of them are very similar across the board. I'm like, how is that possible? Because then, it's so subjective to the clinician, and then they keep changing your diagnosis. And so what he told me was, look, honestly, we have these diagnoses for, the bigger ones, the bigger ones are like major depression. or it's pretty clear cut, like the person has it or not, or schizophrenia, let's say, that's something that's globally recognized because the symptoms are pretty similar across the board. But he told me that, he goes, in psychiatry, it's not about putting people in a box, it's about treating the symptoms. So we don't have any cures yet. We're still trying to understand the brain, but it's more about approaching it systematically. So, like, for example, you might not have depression for other chronic illness for the rest of your life. You might have it episodic, like, maybe it's 3 months, or maybe you were having a hard time. And so what he told me was, like, a lot of people get, mixed up with these, with trying to fit into these boxes of the DSM. I know some of the people that were the authors of the DSM, and I can tell you that I'm not sure if they were very culturally sensitive with all our cultures, and I think this is why a lot of the names for these diseases are not like language equivalent, because what we call it, they don't call that. So I think it's important to also be mindful of that we're still trying to create a more culturally sensitive DSM-5 where it encompasses everyone, rather than trying to fit into a box. For the other example I used a lot is, like, for example, with attention deficit, like, or speaking loudly. Like, in my family, we speak very loud, but to a clinician, depending who you go to, they might say, well, according to me, this sounds more like explosive, personality, or something like you have something, that you can find. So there's always ways, but I think what's important is, as long as it's not debilitating, where it's impairing, like, the way you parent, the way you go to work, like, and I think that's, like, which happens in a lot of the developing countries where there's a lot of generational trauma. So there's generational trauma, like, how are you gonna, like, the motivation of waking up and going to work, that resiliency, that's tough, I think. So that's why, having these conversations and talking about it, and not so much worrying about the labels of it, but talking more about the symptoms is really important, because that's what essentially they treat. And that's why Dr. Rester was talking about the antipsychotic and the SSRIs, because there haven't been any specific, like, these medications are used across the board. Even for epilepsy, they use the same mood stabilizers. And so it's very, so I think, instead of, being caught up in the name, in these labels, I think, because sometimes I feel like that's what brings a lot of the stigma. It's understanding the symptoms and addressing those symptoms so that they don't impair your everyday go-to, activities that impairs you then from being successful or being, fulfilled in your life. That's how I see it. And maybe because a lot of people in my family also, and I know people who have gone to a clinician and then they'll get a different diagnosis every time. But one thing is for sure is that the person keeps sleeping a lot. So whether they have bipolar or bipolar 2 or major depression or anxiety disorder, the symptom is still the same, so that's why I think it's important to treat that symptom. And that's why we use mostly the same drugs to treat across all these different different diseases pathologically. So for example, like Alzheimer's is a pathological disease, and you can see it in the patients after they die. So with Alzheimer's, they have imaging studies. So you can't even actually see the different protein aggregates that are that they say, because there's a lot of controversy over this, that is responsible for the pathology of Alzheimer's. So not until you die, like, for example, my dad has Alzheimer's, and the neurologist told me, and he's published many books on this, and he told me, he goes, what your dad has seems to be more likely Alzheimer's. And I'm like, and then he showed me the MRI, and you see the white matter, like, you see it. I mean, you see the brain really decomposed. And so I'm like, but that's actually. And he goes, yes, but we don't really know until we get the postmortem brain, and then I do the staining. Then I can tell you 100% sure this was Alzheimer's and not some other type of dementia. So I think whereas with these other disorders, I'm not sure where the postmortem brain studies are. But I think what I'm trying to say is that there's some disorders that I think can be a little gray, like it can fit in many different things, and so if, you know, I don't think we should look up, you know, anxiety disorder and then how to help. I think it's like, I'm sleeping a lot, how do I address this? You know, or I'm worried about this, how do I, you know, like that type of stuff, rather than because it might be that you might have overlapping, you know, disorders. So that's my take on it. I mean, that's my personal take. So I don't know how you all feel about that, but because given that most of these diseases are all treated with the same type of psychotropic drugs, that's where I'm like, okay, so you're basically treating the symptom so that the person can live a fulfilled life and continue to work and teach and be a scientist or be a professor. So sorry, I didn't mean to take up a lot.
No, it's okay. Thank you very much. This is very, very, very enriching for us in our dialogue. And it's a very big issue in terms of language, because I've seen some clients saying, my wife was operated and I just forgot about it. Can you imagine? It is disturbing. And then later on you find the person has realized that the wife had gone through major surgery, but because of dementia, and he was not aware. So it pains when the person is told, you know, your wife was operated on this because of this condition. So we need to have a dialogue in terms of infrastructure. We say, okay, the DSM-4 or 5 is not applicable to certain situations, and there are other conditions that have not yet been classified. Like recently, we are struggling with LGBT. And LGBTQ is a very big issue. So if we have a proper diagnosis earlier than before, it is easier to have a dialogue to explain what is really happening, because most of these conditions are more psychological than general. So really a center of assessment, a center of creating awareness, community sensitization is really very, very important. Yeah, so Professor, I think I wanted to introduce you to have a presentation on gender-based violence. I don't know whether it's okay. Professor Caro.
Professor Bantu, just to, so the DSM, actually, that's how you know it's evolving. So, for example, the DSM had removed homosexuality from the DSM in 1973. So it's not, you know, it's not what you know, like, it's not a mental illness. Like that's how, at least that's how. Sorry, I know that's very. Did you hear me? I'm sorry. Was I?
Yes, we can hear you. We can.
Okay. Okay.
Yeah.
Yes. So it's not, you know, like this is something that, you know, what we, you know, there's different aspects, like from LGBTQ. Then there's a lot of within is like people who are, because of the social acceptances, that there's a lot of inner conflict, there's high suicidality, there's like the parents are not supportive, there's, you know, there's a lot of, it's a multi-layer, I think in other countries. I mean, here too, there's still that, but I know that it more so in some of our countries. So that is something that I think hopefully with education we're evolving and learning to accept people. But yeah, so that was removed in 1973 in the US from the DSM. But LGBTQ, like I showed you, even the sex determination, I showed you with fruit flies. I was able to masculinize a female fruit fly to act like a male. And then I was able, just by doing the genes, and then I was able to feminize a male fruit fly to court another male, which he didn't do before. And that was by me manipulating the genes. So that tells you how heavy genetically this, you know, like through the sex determination pathway. And I think understanding it biologically, hopefully, you know, we'll come to understanding and more of an acceptance. Another really important aspect of all this is that people are indeed, a lot of people are suffering in silence, and I understand that part of the stringent rules, at least correct me if I'm wrong, from Kenya, like if indeed in Africa the reason why in many countries it was very strict that you couldn't have LGBTQ relationships, that it was illegal. And so my understanding is that during that time, it was because of the AIDS pandemic. Like everyone else, they thought that it was because of the relationship between the same sex. And so to prevent that, they then instilled these laws. So I'm wondering, like, if now that we know that that's not just the case, that it's a multifactorial, disease. Like, there's many different ways that you can get AIDS. That if indeed this is a dialogue, I think, between clinicians that are starting to talk, or they're starting to see in their own communities. I don't know. I think that. Yeah, I think it's something that's very evolving. I know the Pope has talked about this because there's a lot of people suffering in silence. And something that, I think as clinicians, we need to learn to be objective about these type of things and really look at the science behind it. Because, that's my take on it.
Thank you very much, Professor. I think it's a debate. It's a dialogue that we need to proceed from there, but we have to structure ourselves, and then we begin. It is with great pleasure and immense pride to bring to you the Vice Chancellor of Kenya Methodist University, who shall be introduced by the Deputy Vice Chancellor in charge of administration and finance, and I'm being informed that they are ready. Welcome, Professor Some.
Good afternoon, colleagues.
Good afternoon.
First, we see the Vice Chancellor, who has been occupied with council meetings since morning, and they are in another one. And she's asked me to read her speech and to wish you the very best. I know one day of this has gone. We're on the second day. This has been a very special conference, a Global East Africa Spirituality, Healing, and Mental Health Conference. So allow me to read her speech. Esteemed guests, esteemed colleagues, ladies and gentlemen, it is with great pleasure and profound honor that I welcome you all to the inaugural lecture or conference on integrating psychiatric and spiritual approaches for enhanced mental health and international dialogue. This event marks a significant milestone in our collective journey towards understanding and addressing the complexities of mental health through a multi-dimensional lens. As we have gathered since yesterday and today, we are embarking on a journey of exploration and discovery, a journey that transcends borders, disciplines, and belief systems. It is a journey fueled by the recognition that mental health is not merely the absence of illness, but a state of holistic well-being encompassing the mind, body, and spirit. In today's rapidly evolving world, where the challenges to mental health are manifold and multifaceted, it has become increasingly imperative to adopt a comprehensive approach that integrates psychiatric and spiritual perspectives. By bridging the gap between these seemingly disparate realms, we open new avenues of understanding, healing, and transformation. theme of this dialogue underscores the interconnectedness of psychiatric and spiritual dimensions in shaping our mental health. It acknowledges the profound impact of spirituality on psychological well-being and the potential synergy between evidence-based psychiatric interventions and old-age spiritual practices. Throughout this two-day dialogue, we have delved into a diverse array of topics ranging from depression and trauma to gender-based violence and grief support. We continue to explore the role of spirituality in resilience, coping, and recovery, and examine how it can be harnessed to promote holistic care across the lifespan. Moreover, we have engaged in critical discussions on integrating mental health and spirituality within diverse cultural and religious contexts, ensuring that our approaches are inclusive, culturally sensitive, ethically sound. As we embark and continue on this intellectual odyssey, let us do so with open minds, compassionate hearts, and a shared commitment to advancing the frontiers of knowledge and practice in the field of mental health. Let us embrace the diversity of perspectives and experiences that each of us brings to the table, knowing that it is through dialogue and collaboration that we will gather birth towards greater understanding and healing. In closing, I'd like to express my deepest gratitude to all our esteemed speakers, panelists, and participants for their invaluable contributions to this dialogue. Your expertise, insights, and passion are the driving force behind this endeavor, and I have no doubt that together we will make a meaningful difference in the lives of individuals and communities around the world. Thank you once again for joining us, and I wish you all a thought-provoking and transformative experience over this period of dialogue. God bless you so much, and thank you. Over to you.
Thank you very much. We received the speech and communication from the Vice Chancellor by applauding and clapping for. Thank you very much, Professor Some, for that elaborate and enriching speech from the Vice Chancellor acting. And we look forward to having an enriched collaboration and ultimately.
With me, I think it's so important that we have that we all share with our different insights, because like this, it leads to discovery. You know, like having different diverse perspectives is very important. I love that this is a safe space, that we're all professionals, we're all practitioners. I mean, clinicians, scientists, professors, and so if we have to support each other, you know, because there's a lot to undertake. And I think one thing we all have in common is that we all want to help people, and we want for the good of the people, and that's something that we all share. And I'm really excited to, you know, I'm really honored and excited, and like it's such a privilege for me to be here. In your presence, because like I said, this has always been a dream for me, and so to make this into reality has been amazing. And I really appreciate Kenya Methodist University for making this a reality. Like they were really, you know, they said it and they delivered, so that's beautiful. And I'm very impressed, and like I tell my colleagues here about the wonderful work that you all are doing, and the dialogues that you all are having. It is very impressive and also very moving. So thank you.
Thank you very much, Professor Caro, for that supplement. I would like to invite. I think you may be ready for that representation on gender-based violence and human rights, and I think it is very important because this is an aspect that cuts across in terms of our existence. We need to be able to examine the intersectionality of gender-based violence mental health and human rights. And as you are aware that there's a lot of gender-based violence in African setting.
So, Professor Bantu, I believe, so Brenda will be talking about her community outreach.
Yes.
So some of I didn't get so much into some of the gender, like I just talked about the neurobiology of the different genders and how sexually dimorphic that is in the biological terms. But I think that, I didn't prepare anything per se, but that's something that we can continue talking about because it's something that is so it's something that actually we think is underrated. There are many more instances that are not just being recorded. So this is, so I think for us is like understanding aggression, like learning how to cope with these things and going forward. But yes, I can, we can do that. I think at a later time, if that's okay. And then have Brenda give her talk about the work that she's doing in Uganda with the community faith-based leaders.
All right. Thank you very much. I think, is Brenda already online?
Yes, please, I'm online.
Very good, very good. Professor Carol, would you take an advantage to introduce Brenda also, so that...
yes, of course.
Go ahead. Thank you.
Thank you.
Yeah.
So it is an incredible honor for me to introduce to you Ms. Brenda Nawanga. She received her bachelor's degree from Niji University. She is currently working at McKay University under the mentorship of Dr. Sam Kulunyi. And Ms. Nawanga is also the director of the organization of the Women of Purpose International in Boston and Uganda. Recently, she created a very successful mental health summit where she managed to have the entire community, pastors, imams showed up, and research scientists and professors all came together and in the church, and we all talked about mental health in Uganda. And we had community participants. She even gathered elementary school teachers. So I was really so impressed, and it was what drove me to Uganda, but just the way she coordinated all of this and thought about all these different aspects was just it was so mind-blowing for me, because it really is. So part of our work here is we're seeing a disconnect with medical profession in the community. But yet she's managed to been able to pull everyone together in the same room. And that for me was very remarkable. And not just having research science, but having everybody, the community, little kids, big, older teenagers. So I don't want to take too much of her time, and I just want her to show you all her work that she's doing. And she's also working, she's also helping us start a brain bank at McKay University. So that's also a really important aspect of this work. So thank you very much.
Thank you, Professor Carol.
Thank you so much, Dr. Caroline. Wow, what a wonderful introduction you have made. So good evening, everyone, and good morning from the US. Nawanga Brenda from Uganda, Kampala. Hello, am I audible?
Yeah, you well and clear.
Audible. Okay. So thank you so much for this opportunity. I'll be talking about the outreaches, the community outreaches in Uganda that we have carried out to engage the faith-based leaders plus the professionals in mental health. Allow me to share my slides here. I was able to come up with a simple presentation. Yes. Unfortunately, I'm trying to share my screen, but it's really playing tricks on me. When I share, it mutes, so I can't be heard.
Oh, sorry. We will try to make sure that we listen to the presentation, although the presentations had just appeared. So, but proceed. Whichever way is better for you. Most important is to hear and listen to.
To be on a safe side, let me share my slides with Dr. Caroline.
And then I'll play it.
To project and
Perfect. I will do that. And then you tell me when to go next. Perfect. Go ahead, Brenda.
Okay, in a minute, please. Okay, so I've shared the slides, Doctor.
Okay, perfect. Okay, perfect.
Yes, so as the way for the slides, basically, I'm going to talk about WUPI and the outreaches we do in Uganda to engage the community and the faith-based leaders. Those are the pastors, the imams, the chairpersons, or in whatever category the leaders fall into. We engage them to bring to create awareness about mental health. So I work with an organization called WUPI, and WUPI stands for Women of Purpose International. It was founded in 2010, but this organization was just a mere club in one of the secondary schools in Uganda. That's Ndege Senior Secondary School. So as a club, still students used to carry out different outreach programs whereby they involved other secondary schools to create awareness about to motivate, to lead, and to also empower the women at large. Because in WUPI, we have this, our main goal is to empower women and their families. In that when you empower a woman, you are empowering the entire nation, you're empowering the entire generation. Because if you find a woman and their family, this family has sisters, cousins, brothers, husbands, uncles. So I don't want men to feel like they are left out. We are empowering you as well through the ladies. So basically, that's WUPI for you. Dr. Vicky, the slide?
Yes, 1 second. I'm just having problems with my Zoom now. 1 second, sorry. 1 second.
Okay, I think I can keep going. The slides will find us. So basically, that's WUPI. I think the introduction is this, and our mission is fostering a community rooted in love and compassion in a spiritual full way. Like, we are bringing up this community to be empowered, to be fostered and rooted in one thing. If we all have love, we can look after each other. Without love, people really just underlook others and they are not able to uplift them. So we go to the communities and we empower them. We encourage them to love one another and to show care and compassion everyone. So all researchers, which leaves only a few as clinicians. You can imagine a country with 53 psychiatrists and having only a few doing clinical work. Meaning, mental health is not really, because you find that we only have one government center that takes in all, and that's Butabika.
Can you see the slides or no?
Not yet.
Oh my god. Okay, sorry about that.
So Professor, I want to yes, so talking about the outreach, WUPI a very successful conference whereby we created awareness, and which is so when you look to any elderly to assist them in solving the issue. So this is where we come in as WUPI, and we are like, no, it's not about witchcraft. You can educate these people about, like for example, I'll give you an example. I just have a cousin, challenges, and then you give them the right information, and they are able to follow and get to help other people. We also empower the individuals to reach out to the doctors, the pastors, the imams, because these people really trust. The reason why we do the faith-based approach to involve the community leaders is because the people trust their leaders in the community. They have that connection. They feel like if I go to my pastor and I tell my pastor that this and this has happened, my pastor will understand me more than a doctor in a hospital. That's where we go in to collaborate with the pastors and the professionals to help the community create awareness. Yes, Dr. Caroline, you can move on. So I think the next slide. We have different challenges where the community really finds they have their beliefs and taboos. So when you come to the community, when you get to see the people with a mental illness, we do that guidance to tell them, no, it's not all about witchcraft. Reach out to the pastors, and then these pastors will refer you to the best person or to the best doctors to work with. And we do that so that people confront in the community. If at all in the community, so really it's all about connecting the community with their leaders and the professionals. Dr. Caroline, there is a slide that has some pictures. Yes, so to briefly show you, when we are working on this outreach, the community outreach, where Professor Bantu attended, Dr. Caroline and other different professionals plus the leaders, we went out to the community. We carried out a drive. We had to make people know that mental health, we really care about you. Come and get to know the information, because when doing this, when we did that drive before the conference, we really found out that people, actually you find that most of the people do not know what mental illness is. They do not really know. So after getting all that information on the real day, this is where we found that we got a massive number of people, because we're screening, we're educating, we're counseling, and we passed on the scientific side and also the spiritual side. And if you can ask Professor Bantu, the feedback was really amazing. Like, people got to understand why is it important to know about mental health. So WUPI comes out to the communities to create this awareness, to connect with the people, in that when we go to the community, we get to know what the community needs. When we know what they need, we also give them the resources. That's where our conferences come in, our outreaches. We even go to door to door to educate, to comfort, to also assist in giving the families that have these children or who are having these challenges. Like for example, we after the conference, we had a mom who reached out to us, and she said she had 2 children, a girl and a boy, who had issues. We went to their home. The lady, like the community stigmas, you know, she was hiding her children. Her children were no longer going to school. So when we went there with Professor Caroline, she was able to educate together with us. We engaged with this mother, with this family. We educated the mother. And at the end of that day, she was asking us, how can I now enroll my kids back into school? So you can see what these outreaches really help out with creating awareness. And right now I can tell you the kids are back to school and they're happy. Dr. Caroline, I think I can go to the action. I think I've just talked about WUPI in action, what we do, how we engage, how we collaborate, and how we prioritize mental health in the communities. So just to sum up my presentation, we have future goals, and here we plan on having early interventions with our community, and here we want to have workplaces, like we want to build up a facility whereby we have volunteers, psychiatrists, doctors, like have the professional people, because the faith leaders are willing to work with us. So all we need now is to have the professional team to be volunteering with WUPI and create, have these screenings, create awareness through different initiatives. We also want to have a policy, like we look forward to promote mental health policies. We want to reach out to the government, to different organizations that can support us. We also look forward to address different social issues like isolation, to break the stigma, and to also make these people feel like mental illness is really a normal disease. It's not anything, it's not a taboo, it's not anything that is out of this planet. Everyone is normal in each and any way. So basically, this is WUPI for you. And that's what we do to create mental health awareness in our communities through our different activities. Not forgetting, this year we are looking forward to go to collaborate with different schools, because when you look at Uganda has so many youths and teenagers. So we want to carry out these outreaches in different schools to create awareness. You find a youth who has not been able to have a job just using drugs, and these are the people you find who are on drugs and they are not doing anything sensible. They think like life is all done. And these drugs really affect their mental. These are the people you find raping young kids. So we want to engage with these youths more so that they can spread this gospel or this awareness into other communities. When we talk to our youth who is stressed, because you people go to school now, you find someone stressed because of exams and they can't control the stress. You find one is all stressed because they got a retake. And this stress can cause them to go into depression because I'm stressed, I can't read, and I'm not able to pass my exams. How can I control this? I don't know how to do this. But if a Toro comes out into my school, brings all this information, I will be able to digest this information and I'll be like, okay, it's normal to be stressed, but how do I handle my stress? How do I handle my depression so that I can be able to move on and do meaningful things? So this is what we are aiming for this year, and God willing, if God willing, we shall be able to impact our community through WUPI and other leaders. Thank you so much, but we are looking forward for different volunteers who are compassionate about community service. We also need to have different we also want to have different chapters in different countries so that we are able to help our society and our community. Thank you so much. For more information, you can follow us on our websites, and you can also reach out to us. Thank you so much.
Thank you very much. Thank you very much, Brenda, for that very insightful and very encouraging program that you are learning. And I thank you. I think Dr. Caroline made a very good introduction and giving us a very good background on what you already been able to achieve. It is not a small means, so we are very, very grateful. We obviously would want to interact a little bit, so I would want to offer an opportunity for a couple of questions or comments, just to be able to interact with Brenda's presentation. So those who are online, you might want to take the opportunity. Those who are physically here, you have followed the presentation by Brenda. You would want to, and of course she has invited us to be partners in terms of expanding this work beyond the borders. So that is also an opportunity. We are being invited to this, what we are calling a dialogue, expanding this, because the issues she is raised and elements she is covering, they are not limited to the boundaries of Uganda. They are far and wide. They are affecting us. So obviously it will be a good thing to see how this can be replicated or duplicated in other areas, in other fields, as we enrich one another in this very important field. Members, you are here. Participants, you want to ask a question or comment? Lala says, great work, WUPI Uganda. Thank you for your presentation. I don't know where that is coming from. Okay, any response? We are waiting for the response. Yes, Reverend Kalanja, please go ahead.
Yeah, thank you for that presentation, Brenda. There's something that you had presented about traditional approach to kind of mental health. And I was thinking very hard about that also, because we are talking about indigenous knowledge that has accumulated over generations, some of which we should not ignore, And then that's why probably the Tradition Society, especially African Traditions Society, was a bit stable because of the communal spirit. There was that aspect of the specialists, the medicine persons, the diviners, the priests, the prophets, being close to the society, very much so. They were known almost by everyone. They were what we call the friends of the society, and also they were able to give their services almost free of charge, and they were given tokens according to how they served the society. So coming up with the idea of the community, I think it is very, very much so, because we are going light to the grassroots, and we know for sure one of the community that we can form here is not the kinship community, but the spiritual community, where the church is able to really reach the community across the social status and also across, I mean, the all the regions, because and also the frequency of the meeting. So I don't know how you are working with the religious institutions to effect this and to have some sustainability, some regularity where people are able to gather. I know out there many people, especially the women, have chamas, but what could also probably the church do to bring people together, even in the issues that have to do with wealth? And how do we become, as the leaders, the friends of the society, where people can be able to confide and be able really to come for that which they don't have? The specialists in the traditional African society were people who were really well, they knew the community, they knew the issues that were really affecting the society at detail. Talk of the diviners, talk of the medicine persons, they were of both gender. They were trained and they were introduced to the people, and they knew them as persons. How much do we really know them that are trying to bring us together, and what are some of the strategies that we are likely to use to reach to the very last person there, and how do we get to their level? Because sometimes we communicate at the level that we are, yet we forget that the people that we are dealing with, they are at a particular level. The case of Jesus, where he went to, I mean, she had an engagement with a Samaritan woman. She went to her very level to raise up, or rather to open her eyes to see the reality. Now that is I think the challenge. So for the indigenous, so what I'm trying to say here is that probably we can also learn from what put the society together, because today, as it was presented today, there is the issue of social distance and remoteness, and people becoming isolated because of the technology, where that spirit of communal spirit or kinship spirit is no longer working. Thank you.
Yes, let's have Jacqueline. Blenda, I hope you have taken note of that. Blenda?
Yes, please.
Very good. Thank you. I wanted just to confirm that you are online. Let's go. Jacqueline Logoro, you want to make your comment, so then Blenda can respond as she also takes she catches breath.
Thank you very much. You all can hear me?
Yes.
All right, thank you. Now, thank you very much for that presentation, Ms. Brenda. It was quite educative. I want to report here in this forum that Kenya is also trying something, just that we have not been doing it together like we are purposing to do in the future. Because I don't know whether the part of the clergy is represented here, but personally, though I'm not a researcher, I'm a victim or an advocate. I have been invited in several churches in Kenya, and counting them right now, there are 42 churches that invite people differently during something they call Health Month. I think it's called Health Month, if I'm not wrong. And nowadays they're inviting people who are supposed to bring awareness on some certain conditions, be it cancer, be it mental health. And from last year, September, I have seen churches embrace mental health. There is a body of clergies in the country. I don't know, they came in with the current government. It's a body where they have introduced that part of bringing the awareness matters mental health. So if we can be able to join them, because they present the spirituality that we are saying, and show them the need of having this together, East Africa, and then together, then going forward, things will be so easy. Because as we speak, Kenya has gone a step further. I don't know that other East African countries or African countries have gone that. Kenya have gone a step further to create a Mental Health Amendment Act, which is in place, it is working. And Kenya has gone further to create a body that is called the Mental Health Board, which has a director of education, it has a psychiatrist, it has a psychologist, it has someone maybe in every province who can disseminate matters mental health, and one representative like myself who has maybe experience or something like that. So if we all can bring all those bodies together towards one goal, instead of doing it separately, you bring all those clergy, you bring all those everybody on board, especially the affected. Because let us face the truth. If I go to the church today, which I do, and I give my story as a testimony, which I do, I get more positive feedback and people reaching out to me. And because I'm not a psychologist, neither am I a counselor, I refer them. And I'm referring them to people that I've already met. And I have met some of you here, and for encouragement or for support or for way forward. People who are spiritual, they want something tangible. That's why when Jesus died, he told them, fill the hole. So when I go to church, someone living with it, maybe schizophrenia, bipolar, all those, and you are walking the journey of healing. Personally, I know mine is genetic. God will bring the healing. So I'm in the journey of treatment as I wait healing. And I tell them, praise God, I'm Jackie, so and so and so, and my story. And I tell them God came, and I'm better now. But with a lived experience in front of a pulpit, let me tell you, it has an impact. What Brenda is telling you has an impact. Bring awareness. I hope that this body that you're having here will introduce a part where every employer, be it in hospital, be it in high school, will have a counselor, not a teacher come counselor, someone who's employed specifically to deal with matters mental health in a public institution, in our schools. In universities we are covered, but in high school, in primary school, in hospitals, in police, in the service. In Africa, I mean maybe outside country they do that, but in Africa there's none. Let me use the Kiswahili word, is unambuka ngumu, but the days of staying strong are gone. It's the time of weakness that we need support. And I hope this team will come up with a good strategy to bring all of us together, even those that are sick and are willing to open up. And we're out there, because I have like 16 forums on my WhatsApp. We call ourselves mental health survivors, mental health victims, bipolar fighters, schizophrenia fighters. We have a group of people who talk about their daily life and their daily struggles. And sometimes I look at them talking, we call it a safe space, and I wonder if this someone was given a platform to share their story, how many people will they give hope? How many will they give hope if we all work together, the sick, the professionals, the spiritual leaders, the government leaders, everybody? Then we will heal this country or this world, because a healthy mind is a healthy world. Thank you.
Thank you very much, Jacqueline. And Brenda, I'm sure you will want to make some responses at this point.
Yes, thank you very much. And Jackie, wow, that's really interesting. I've actually been following you since yesterday. Your testimonies and your whatever I say is really correct, and It's really powerful. I wish you can even move in different countries to engage with other people as well. Thank you so much. So, firstly, I don't know if I got the question wrong, but if at all we are asked how are we going to reach to even the last common person in the community, after our conference we opened up an office, and we also have different coordinators countrywide, whereby people can reach out to them, talk to them about how they need help, what they need, or I would say how we can help them. So, however, I can't say that we are able to go to every part of the country, or because of the limited resources, but we try our level best, and I can testify after the conference, so many people were calling me, so many people were calling our different coordinators, inviting them to go and talk to their children, talk to their community. So we look forward to going to even the last person in the rural area and create this awareness. I don't know if I've answered the question right. I don't know if it was really asking that, the first question. And to respond to Jackie, we were at KEMU earlier this year. So as WUPI, we are looking forward to collaborate with different universities, different schools, different organizations, just in the name of creating mental health awareness. So it's not that we are only concentrating in Uganda. We want to move worldwide. We want to start East Africa, create this awareness, and we are looking forward to collaborate with whatever organization, whatever entity is willing to work with us. Yes, I think that's what I can say. Thank you.
Thank you very much. Bwana Mugambi, you want to make a comment? Please go ahead. Any other person online who want to make a comment, please put up your hand. I'll just notice, and then we'll give you a chance.
Thank you for this chance, Chair. Thank you very much, Brenda. I think not only me, but most of us are very inspired, because as we are all aware, stigma is one of the biggest impediments to health-seeking behavior for all of us, especially people who have mental illnesses or psychosocial stressors. And the only way to fight this is to get to the community. In the circles, we say that as long as we have not normalized people walking in to see a psychiatrist, a psychologist, like they walk in for other conditions to be treated for high blood sugar, abdominal issues, maternal issues, we will not get to where we want to. So as long as we don't keep this conversation to the grassroots and getting these opinion leaders to really shape the conversation, then we may fight at the boardrooms, but then the people will still shun seeking health services. I know the biggest challenge, as I've noticed, even in Uganda, which is very similar to Kenya, being neighbors and our sisters and brothers, it's the human resource deficit. In fact, I can give an example close home here in Meru County. At the Meru Teaching and Referral Hospital, we have only 2 psychiatrists. And actually one just recently joined. And Meru has a population of 1.5+ million people. And we know Meru serves the bordering counties of the northeastern frontier and even Tharaka Nithi County. So you can imagine the numbers. When we say that the ideal number, maybe in the developed world, is around 1 psychiatrist or a psychologist per 10,000 people. Here now it's 1 per maybe 750,000. there is no single psychologist at the level 5 hospital, not a single government employed psychologist in this county. And this is one of the top 5 counties in Kenya, so I don't want to talk about other counties. So you can imagine what's happening in the other counties. So really, the human resource challenge is still as profound here as it is in Uganda and many other African countries. And as long as we are not able to now integrate the clergy and the opinion leaders who are more trusted than even the medical personnel themselves, then we will not get this message across. So Brenda, what you've started is something very, very amazing. Some of us have been trying to get to that journey. We didn't know how to go around it, but using your experiences and your expertise on the same, I think most of us will have now to pick it from there, and we will be able to also cascade it into our communities. Maybe another comment on what Madam Jacqueline commented about. She also brought a very integral topic on the same, the social grouping, the support groups. I'm still trying to research on what our ethics say, because I've seen in other conditions people are allowed to form support groups. And I think that is where we are going also in mental health. When someone knows that this is not a personalized condition, it can afflict others, many others are surviving and thriving, they're getting treated and they're getting therapy, then people can support one another. And so in terms of what Jacqueline was proposing about normalizing mental health in every institution, there is hope, because I remember last year the government introduced a policy, the National Workplace Mental Health Interventions, where they are now making it official that every institution has a model for supporting their staff on psychosocial issues, mental health issues, and it has to be formalized. And actually in the government institutions, it is one of the performance contracting that the in-charges will have to really show that they're implementing. So I hope this is not just a policy. Even us on the ground as psychologists and psychiatrists and also counselors, we can approach these institutions, familiarize ourselves with the policy, then try to train them on it, and also support them in implementing this policy. But as you say, we need to collaborate more inter-country between ourselves and our neighbors and even the ones who are ahead of us in terms of maturity in this sector, like Professor Caroline and the rest. And then we'll learn from each other. And I really hope this institute that it's being proposed to be domiciled at Kemu will see the light of day, and I think our people will benefit profoundly from that step. Thank you very much.
Thank you. That has been a comment. I don't know whether there's any response from Brother Dr. Paul Akaria. You want to make a comment also?
Yes.
Go ahead.
Thank you. I've been listening keenly, but not from the beginning, so I don't know whether I may repeat what has already been said by Caroline. But the last speaker, I have not picked his name. I want to pick from what he has said. In issues of mental health, I think social support is very, very important and very key. But I realize when we give social support, it comes as a reactive measure. When the person is has already got a mental problem and is being treated. My thinking is that how I wish we would adopt a model which is more proactive in terms of the social support and the spiritual support, so that we are not reacting when the condition is already full blown and it has grown out of proportion. I am thinking of the Ubuntu spirit, which is well known in the African continent. How can we rekindle that Ubuntu spirit so that I am my brother's keeper, my sister's keeper, and I am keen to see what is happening in their lives, not when something has already gone wrong, and I'm helping as a reactive measure. So I'm putting emphasis on proactive and embracing the African Ubuntu philosophy of being your brother's keeper. You see, for example, like these days, you can have even a conflict with your neighbor, something that is not so big, and you find people have gone to court over a very trivial issue. But in the older African society, we would use mediators to sort out issues, to sort out conflicts. We would use even elders, like in Meru we have during Cheke, and other communities, I believe they have got council of elders. How can we go back to this system, that Ubuntu system of dealing with issues, so that at least we can now be dealing with a more proactive rather than a reactive way of supporting? Thank you.
Thank you very much for that. That is Dr. Spola. Before then was Bwana Mugambi. Blenda, would you want to add to any of that? Or?
Yes, so that's why mental health is now important, even in the schools, and having a change, like to withdraw, and also I think basically that's why we are having to introduce all these in different schools and in the entire society or community at large. That's the importance of mental health awareness, and that's what we are really focusing on, to create awareness in the community. Once people are aware, you will find people are no longer scared of sharing their issues with a neighbor to get the social support. Yeah, thank you.
Thank you. Any other person who is looking to? Yes.
Yeah, I just want to add on and piggyback to what Brenda was saying. I think so. That was a very impactful. It's true, and that we shouldn't wait to the moment that the person is just so severe and then to ask for help. And I think bringing these type of conversations early on into the community is part of prevention, because then you can say if there's changes in a behavior, for example, if the child or the person or your elder is sleeping more than often, you know, and knowing that this could be something related to mental health, like knowing these type of preventative measures where there's mindful awareness of these changes happening, you can avoid then getting it to the point of isolation and substance abuse. So by seeing the changes in behavior early on and being mindful of these type of things, you can get you can then get help, you know, early on, or prevention, or learn to self-cope. Because what we're you know, from my understanding, when I was in Uganda, and just also, I just want to reiterate that I'm also learning a lot here too. You know, we don't, you know, I mean, there's a lot of things that we still don't have right either here. So this is more of a bi-directional global talk. You guys are doing just as great, you know, as we are. There's nothing, just some of us have like just a little bit more resources, but as far as the science goes, it's both excellent. Like your clinicians are also amazing. You just have a huge shortage. But just talking back about prevention, I think it's important, you know, to address like sleep or hygiene. You know, if you know, is for example, if the parent is irritable more often, like having a social support network like around you, then they can pick up on these changes in the behavior and learn to address, well, before it gets to this huge problem. You know, it's the same thing with you know, if like let's say, if you're like, let's say if you're experiencing problems, let's say, I don't know, like something common, like let's say urinating, you know, and then you're like, no, it might go away. And then all of a sudden it's like this huge problem, and then it's so full blown. So I think that it's really important to right away we have these tools to, when we see changes in behavior, if we see changes in like sleep patterns, or if the person is getting more aggravated more quickly, there must be something underlying there. And so having this type of awareness early on can avoid all of this type of where it's like gets so bad that it's, it's a point of like, of no return, or to a point of, God forbid, but die by suicide. So I think, and that's why going into the schools is also early, because this is the next generation. We want to start bringing these preventative measures so that because believe it or not, like children actually, at least here, they are very good. They're very smart. They're very intuitive, and they can go back to the community. They could spread this, and then also, you're just you're changing the next generation to see these type of symptoms early on and get to it, rather than wait until there's a full-blown on panic attack, or there's a full-blown on. And I think part of that is learning some of these like initial changes, like being aware of certain things. And it comes to community outreach, because when I was in Uganda, one of the teachers, she said to me, I have a student that, the parent called me and said that the student doesn't want to come to school, that is severely depressed. So, and one question I asked her was like, did you see any changes? And she goes, I think I did see changes, because there were changes in his grades early on. And I was like, okay, so when you see these type of changes, it's imperative to address them right away, and to speak with the parents, speak with, or the guardian, or whoever, the grandmom, or whoever is taking care of this child, and speak and show, like, whenever these changes in behavior happen, because then it could be something that can then avoid, a tragedy or later on, or something like that. So I think, yeah, definitely being mindful, and part of it is just normalizing. It's like what Dorothy always says. She says normalizing mental health, having an everyday dialogue, so that if you do feel something, you can say it, and then there's more of this spread of awareness. So thank you.
Thank you. This is a beautiful dialogue, and Dr. Caroline is saying, this is a start. This is a conversation that we must continue to extend, and this is like, for me, an eye-opener, kind of organization of this event, and we the various presenters who have brought the very different order form of dimensions. They enrich and they make us know that if we continue this dialogue, so that we don't do it one-off and then wait for a long time before we come back, then we are likely to make progress and to also achieve more as this conversation continues. So thank you very much. Let's applaud Brenda for that very good contribution. Thank you. And I want to now ask Professor Bantu, who has been central to the organizing of this summit, to start helping us to begin to see the way forward, bring forth the issues that we probably have conversed and spoken about. Then from there, we shall be able to invite Bishop Alice for our photo of thanks, and then we shall be able to conclude. Down here it's now about 5:18 or 18 minutes past 5. So I see the numbers have started going down, even those who are online. And I have already indicated that those who are online and who have not done formal registration, you are invited to do that registration. And particularly those who intend to carry a certificate with them, do as the instructions have been given on the platform. You have been given how to proceed, so that then you can register, give us the details, the abbreviations, and so forth. And so we'll be able to prepare a certificate and have it come to you. Thank you very much. Can I invite Professor Bantu then to take us down the end of this very wonderful summit? Professor Bantu.
Thank you very, very much, the Master of Ceremonies from morning up this time. And I want to thank Professor Caro and the team, including Professor Lesla, who was our other speaker, and also Professor Dr. Who presented on CIFA, who presented on digital health. And even Brenda, we want to appreciate you. I'm aware that you have had an opportunity to visit the Kenya Methodist University together with Dorothy, and their desire was to encourage community compassion care. And in my vision, that we need to have a trainers of trainers. And before I talk about the program, I would like to invite the Reverend Dr. Tasira Kibara to give us the reflections on the key learning and insights from the conference. And I think she'll be able to take about 5 minutes. And then afterwards, I will request Professor Caro to give a bit of the remarks on the way forward, because I think this is a big beginning for a better continent. And I'm very excited that Professor Caro, when we were talking about how do we actualize mental health in Africa, I was seeing in your lens the future that you see, and I'm seeing it being operationalized at Kenya Methodist University, and this will be an example for the region, the region and the continent. So therefore, I want to invite Reverend Dr. Kibara to get us through the major areas that we are able to look at during this summit. Back to you, Reverend Dr.
Thank you so much, Chair, Professor Edward Bantu, for this opportunity to present the major areas which the conference has dealt with. One, we have the background information, which covered integrated psychiatric and spiritual approaches for enhanced mental health as an emerging field that recognizes the interconnectedness of psychological well-being and spiritual wellness. This approach acknowledges the importance of addressing mental health concerns through both clinical and spiritual perspectives, aiming to provide holistic care for individuals experiencing mental health challenges. There was the statement of the problem to establish the gap. Despite growing recognition of the significance of integrating psychiatric and spiritual approaches in mental health care, there remains a lack of international dialogue and collaboration in this field. Many mental health professionals and spiritual leaders operate within silos, limiting opportunities for interdisciplinary exchange and collaboration. Justification of this international dialogue. An international dialogue focusing on integrating psychiatric and spiritual approaches for enhanced mental health is crucial for several reasons. Firstly, it promotes holistic understanding of mental health that it takes into account both biological and spiritual dimensions. Secondly, it fosters collaboration between mental health professionals and spiritual leaders, leading to more comprehensive and effective interventions. Thirdly, it addresses the diverse needs of individuals seeking mental health support, recognizing the importance of cultural and spiritual factors in their healing journey. Objectives which the conference has covered: to facilitate interdisciplinary dialogue and collaboration between mental health professionals and spiritual leaders. It is sought to explore innovative approaches for integrating psychiatric and spiritual perspectives in mental health care. The conference also sought to, the summit also sought to enhance understanding of the role of spirituality in mental health promotion and recovery. The summit sought also to identify strategies for addressing the psychosocial needs of mental health professionals. And finally, I sought to promote awareness and understanding of mental health issues within faith-based communities. Expected outcomes: increased awareness and understanding of the importance of integrating psychiatric and spiritual approaches in mental health care. Number 2, enhanced collaboration between mental health professionals and spiritual leaders. 3, development of innovative interventions and programs that integrate psychiatric and spiritual perspectives. Number 4, empowerment of mental health professionals to address their psychosocial needs and prevent burnout. Number 5, strengthen support systems for individuals experiencing mental health challenges within faith-based communities. The importance of this summit or dialogue. The dialogue will provide a platform for sharing knowledge, experiences, and best practices in integrating psychiatry and spiritual approaches for enhanced mental health. It will also foster collaboration and partnership among stakeholders, leading to improved mental health outcomes for individuals and the communities. So, colleagues, participants, and the facilitators, that is, in a nutshell, the summary of what this summit, the international dialogue, was all about. Back to you, Chair.
Thank you very much for that elaborate summary of what we envision to discuss. I was thinking, Professor Carroll, I think you are still with us. I don't know. Yes, Professor Carroll? Yes, so I'm thinking as a takeaway that we are beginning to implement activities. One of the activities was a dialogue, which all of us have been able to attend. And therefore, I'm planning that we should have a log frame of activities within the realms of the established center, the Global Salama Center, Center of Mental Health and Psychotherapy here in Kenya, at the Kenya Methodist University. And therefore, as a result of that, I have proposed that we start a trainers of trainers conference that I'm foreseeing it happen around August. And one of the objectives of these trainers of trainers is to develop training programs. And the trainers of trainers will be composed of chaplains, clergy, psychiatrists, psychologists, counselors, social workers, and healers on the integration of spirituality, psychiatry, and mental health care. Objective number 2 is to establish collaborative networks. So that means if we have all these people who have presented and have participated in this conference, we need to have that meeting so that we can be able to look at how do we establish collaborative networks. I'm excited that most of the groups already exist, but no one has known them. We have now known them this evening in the last 2 days, and we need to have this network. So the objective of our trainers of trainers is to establish collaborative networks and partnerships between all these mental health professionals, spiritual leaders, and academic institutions within East African universities and colleges. And I'm much aware that the Vice Chancellor acting in this university, he has this at heart. And in my discussion with her, I was given a go-ahead. And therefore, it is imperative that we begin operationalizing this. I'm very excited about Jacqueline and also other presenters having made strides to make sure that they have the people helped in this area. So as a result of these other small entities that are fighting for the dignity and right of a human being through mental health, those ones will help us to achieve objective number 3. This objective number 3 is to provide holistic care. So that means we have to enhance the capacity of TOTs, chaplains, clergy, psychiatrists, psychologists, counselors, and healers to provide holistic care that addresses the spiritual, psychological, and psychiatric needs of individuals. I'm aware that in most countries, they have actionalized it. They have actionalized that every institution should have a psychologist, should have a counselor, should have a social worker. But we need to have these ones in a central place where they could be able to get trainings and approaches that they would use to make sure that they provide that. Objective number 4, to promote awareness and education. I'm aware that most of these issues that are affecting the society, people are not aware. And since they are not aware, this Trainers of Trainers conference that I'm envisioning to happen in August should be able to promote awareness and education on the importance of integrating spirituality, psychiatry, and mental health care throughout community outreach programs, workshops, and seminars. That will help us to engage the stakeholders, because I believe in most countries that is the area they want, and they are lacking a platform, which of course we have now provided. And therefore, the integration of spirituality, psychiatry, and mental health care is very essential for addressing the holistic needs of individuals. Mental health problems, which are often have spiritual dimensions that require attention and support from spiritual leaders and healers. So by collaborating with mental health professionals from the levels as we shall be marking a dialogue, I've had some presenters talk about schools, primary schools, secondary schools, tertiary institutions. All these are institutions where most of our youth congregate. And therefore, if we have professionalized training programs that are recognized by government, it would be easier for us to navigate by providing the support system that is required. So by collaborating, this will of course help us to come. I still have an implementation plan within a 2-year plan. Once we have met, in the first year, we shall conduct needs assessment. Because you are saying that they are not recognizing these services, but they have no statistics of what is really happening. So once we have gotten together, we shall conduct a needs assessment to identify gaps and opportunities for integrating spirituality, psychiatry, and mental health care within the East African universities and colleges. And I'm aware that this integration process may take some time, but I'm confident that it is possible. Then number 2, we can develop training curriculum. Like if you get a pastor preaching on the streets, he has the skills, he has the knowledge, but he still lacks to be, he still lacks to have formal structures. I am aware that the Spirit of God can touch someone to go and preach. All right? It is possible. So we need now to provide a curriculum, a training curriculum, which will be addressing the core competencies required for integrating psychiatry, spirituality, and mental health care. In one of the East African countries, Rwanda, for example, every pastor who is preaching must possess a degree. And this is happening. Why? The reason is that this is a very important calling. A pastor, it's a very spiritual calling. So, but then we need to structure so that people are losing image of spirituality. If you find someone preaching over the radio, now on the streets, It really, of course, that's one way of preaching and reaching out for people. So we can have training curriculum for that. Then we train the trainers of trainers. I believe in the facility that we envision to have, we shall have to train further, because people must have continuing education. Train further chaplains, the clergy, the psychiatrists, psychologists, counselors, and healers, which, of course, in most countries they are called traditional healers, but I just generalize them as as healers, especially when we are trying to integrate spirituality, psychiatry, and mental health care through workshops and seminars. Then we have to establish collaborative networks in all these East African countries. Establish collaborative networks and partnerships between mental health professionals, spiritual leaders, and academic institutions to support ongoing collaboration and knowledge exchange within the region. And I'm very excited that our collaborators in the US are ready to give us support in terms of training and leadership. And this I can say confidently that the Vice Chancellor acting has already been introduced with someone from the University of Columbia, and I believe Professor Caro will just augment on that, free training platforms, and we should be able to take advantage of that. Then in the second year, we implement training programs, because there are bodies that regulate these programs within this East African region. So we implement training programs for trainers of trainers, where we shall have manuals, chaplains, clergy, psychiatrists, psychologists, counselors, and healers across the East African universities and colleges. You remember in our meeting, we had people from the religious organizations, like the Muslim, like Professor Muhammad from Umma. So it means that this dialogue is very, very important. So we should also be able now, within the second year, to monitor and evaluate the effectiveness of training programs through pre- and post-training assessments, provide feedback surveys, and follow-up evaluations. This is very important because we need to make sure that we make a significant difference in the lives of people and others. Then the next aspect we need to look at is provide ongoing support and supervision. A member in the conference submitted that we also need to have supervision and consultation. I know our friends who have been licensed, like myself, as an expert in trauma recovery, and have been given a status of gatekeeper. So we need to be able to have these people under supervision so that they can be assisted, so to have a stabilized mental mind, and also to help other professionals. This will ensure the integration of spirituality, psychiatry, and mental health care in their practice. Then last but not least, promote awareness and education. You have seen our last presenter, Brenda, says the Women of Purpose International have tried to create awareness in the community. And the emphasis was, how do we reach the community? And really it is the community from which all our people come from. So we shall provide and promote awareness and education on the integration of spirituality, psychiatry, and mental health care through community outreach programs, through media campaigns, through academic conferences. So I believe that as we plan more conferences, like I was talking to one of our colleagues who was in this meeting, Professor Etnet from the Republic of DRC at the University of Kinshasa, he said we need to come together across the board. The implementation in East African universities, of course, will be alongside what we want to do. How do we do it? We have to engage academic institutions. So by inviting these institutions on board, we are going to engage with academic institutions in East Africa to integrate training programs on spirituality, psychiatry, and mental health care into existing curricula for medical, psychology, counseling, and theology students. When I was doing my first degree, I was told that communication skills is compulsory. And indeed it was. Our Christian beliefs in most Christian institutions, very compulsory. So by engaging the academic institutions, and this conference we had invited vice chancellors. So I believe in our meeting in August, we shall be able to have these representatives so that we can be able to bring them on board. Then we establish training centers. We shall establish training centers because these training centers are in line with the Vision 2063, where people must have competencies. And I know some countries have now started teaching competence-based classroom skills, where a student can finish and still be useful to himself in the community. And I am very happy that we can be able to establish these training centers within East African universities and colleges to serve as hubs for capacity building initiatives, research collaborations, and community outreach activities. I'm very confident that this is doable, and with this coming, we call it new coming technology, we'll be able to do it. Then we can also facilitate research collaborations. Like there are cases that you have heard on the videos, on the audios, on the media, that someone has taken a group of people into occult explosion. But do people really know occult explosion? Do the people know what happens on youth radicalization? So we need to facilitate research collaborations like what Professor Lazarus was saying when he was addressing issues on PTSD. He has given scenarios about PTSD in the community, in the civilian community, in the military, and these, of course, provide insights on how we should be able to treat human beings. So these collaborations should be between mental health professionals, spiritual leaders, and academic researchers to generate evidence-based practices and interventions for integrating spirituality, psychiatry. And indeed, what we are suggesting is that these are just few professions. We have not gone to the legal profession, the judiciary. Someone makes a judgment, others say, no, this judgment is not very okay. We need to provide guidance. Even most of the lawyers, advocates have issues, but they do not have where to put them. And if we have these recognized institutions, by a way of doing research, we can be able to share experiences. Last but not least, we shall advocate for policy change. This advocate for policy change at the institutional and governmental levels to prioritize the integration of spirituality, psychiatry, and mental health care in health systems and academic institutions. You are aware that counseling was not really a recognized aspect in the bygone years, but now it has become relevant. And I know through the ministries of education within East Africa, the requirement is that people should go for mental health assessment and treatment. So this year plan, this 2-year plan of implementing those steps for integrating spirituality, psychiatry, and mental health care within East African universities and colleges, we can enhance capacity and make sure that these people get the requisite. So by way of talking, I think I wanted to ask Professor Carol about what she feels about this. Professor Carol, I see another hand there, but I don't know. Agawa Godi, are you still on?
Yes, I'm on, Professor.
All right. Do you have any comment?
Yeah, the comment is just a message of appreciation. I thank everybody for this initiative. And I'm happy to see my professor. This is Agawa from Uganda, western part of Uganda, a district called Rukunjiri. And I'm a student of education, a Master of Educational Psychology at Kabale University. I'm very happy to see my professor. I'm sorry I joined late because I'm a school teacher. I've been in a class this morning. It's now that I've got some time. I find you people finishing but I followed you up because you were talking about mental health and how we can support people maybe who are affected by that mental health, how we can support them in our communities. And my submission is that we should love them, we should give them a helping hand, we should listen to them, and then do what we can to bring them to sanity. I thank you very much.
Yeah, thank you very much, Bwanagawa, for your submissions. We do appreciate that this is a very important aspect of dialogue. It's an international dialogue, and I am happy that you've made that submission. Professor Caro, back to you.
Yes, thank you, Professor Bantu. So I just want to say that this is just the beginning. And this is an excellent beginning with our mental health summit. It truly sets the right tone. And, you know, really thank you, Professor Bantu, because you're right. In order to drive, you know, change and inform policy, especially institutions effectively, they're going to require, they want to see data. They want to see statistics and published research so that then they have the tools to then go and then justify, you know, investing in these sectors. So it is essential that we disseminate this information, you know, widely to support our advocacy, and so that we can, you know, we can collaborate and have publications. So here, I don't know, like for us, our academic currency is publications. The more publications you have, the more empirical data. That's the way you can drive change, because then it's like, okay, it's been vetted information. And I understand publications are expensive, but you can easily, like for us, it's we have funding just specific for that, and we can easily pair up and getting it reviewed and getting it published, and then this way, you have more substance to show for policy makers, and it's more of an argument rather than just our like our advice or our, you know, it's more like we have to have some type of substantial, I think, like evidence of empirical data to show them that it's not just our opinion, that this is what's happening. So that's where I'm seeing that, and I would love, you know, for us to team up on that and getting some stuff out, because it's important. It's very important, and I think that if we can assess the need of the community and the lack of resources, and sometimes it's just a matter of documenting it and getting evidence and proof, and then just going to the government or to the institutions, say, okay, this is what we need because this is our data. But sometimes when you just like tell them, okay, to advise them, it's not, you know, sometimes it's not enough. And also, you know, I think through publications, we will, you know, it's our legacy as academics. You know, it's out there. It's another way for us to disseminate our information globally. It's, you know, I think that's a really important aspect of it. And also, we want to get some research funding through international agencies. We have to show them that we have publications and that we know what we're talking about. And that's one way of showing that. So I'm really excited about this, and I know our conversations will continue. Thank you so much for having me today.
Yeah,
good night.
Thank you very much, and I'm excited that this can be driven further than this. I've already informed the Vice Chancellor for Kawara University about this establishment, and also the Vice Chancellor acting at Kenya Methodist University is in full support for this. And since we are working towards a proper collaboration with Macklin Hospital as one of the university teaching and referral hospital, Kawara University already has a wellness center in place approved by the Ministry of Health, and this was done to spill over to get, because one of the national teaching referral is overcrowded now and for flooding. They have the staff and the capacity, but a center like the one we have set would augment on the services. And since under the Inter-University Council for East Africa, if we now come together, we have one global Salama Center of mental health and psychology, then we'll be able to begin operationalizing the objectives that we have already mentioned by one of the presenters, the Dr. Reverend Tasira. So thank you very much, and this time I would like to invite the Bishop, Reverend, you know, they have many of these titles and we thank God for them. I would like to invite the Reverend Bishop. I think Bishop is more than the Reverend, isn't it? Yes. Yeah, of course, I think, yeah, you know, these positions are very important. And God also, in His wisdom, He said others are apostles, others are elders, others are prophets, others are bishops, others are pastors. So I think that was the order, and that's the reason why this interaction, dialogue is very, very vital. We are following the basic skills and techniques and steps as provided for by God the Creator. So I'm asking with humbleness, Bishop Dr. Alice Mutuma. You know, the word Mutuma is really a disciple, is an ambassador, to provide us a vote of thanks as we come to the conclusion of our summit.
Thank you very much, Professor Mbantu. Yes, I will also humbly do that, and on behalf of Kenya Methodist University, the host, and all the other planners and supporters, we wish to express our heartfelt gratitude as we come to the end of this Global East Africa Mental Health Hybrid Summit. And we really want to say thank you to each and every one of you for your active participation, insightful contributions, and unwavering commitment to advancing mental health care in our region. Your presence, both physically and online, your engagement and your participation has truly made this event a resounding success. So thank you very much. Throughout the 2 days of the summit, we have delved into critical topics such as integrating mental health and spirituality, addressing the psychosocial needs of mental health professionals, community outreach in faith-based settings, and the impact of digital health technologies on holistic health care, among others. The breadth and depth of discussions have been inspiring, and we are confident that the knowledge shared and connections made will have a lasting impact on mental health practices in East Africa and beyond. We would like to express our sincere appreciations to our distinguished presenters and session chairs for their invaluable contributions and expertise. Your insights and guidance have been instrumental in shaping the dialogue and fostering meaningful exchanges among participants. Special thanks to our keynote speakers, Professor Peter Mbaguma and Professor Mbantu, Professor Caro and others, their thought-provoking addresses and unwavering commitment to advancing mental health research and practice. Your leadership and vision have been truly inspiring. In addition, we would want to really thank the organizing committee for their selfless dedication in making the conference a booming success. This organizing committee include our VC, Reverend Dr. Mary Kinoti, our chair, Professor Mbantu, Reverend Douglas, Dr. John Muchiri, Dr. Rebecca, Reverend Dr. Kibara, Reverend Dr. Peter Mweti, Reverend James Karanja, Reverend Justus Karani, Reverend Alice, Dr. Esther Gakimbabu, Dr. Gakimarete, Miss Jen John, Mr. Daniel Muimi, Colin Mutuma, Beatrice Sisha, Judith Kebwe, Victor Sambuli, and Miss Catherine Jiru. We would also like to extend our gratitude to the organizing committee volunteers and support staff for their dedication and hard work in ensuring the smooth execution of this summit, both in person and virtually. Your efforts have not gone unnoticed, and we are immensely grateful for your contribution. As we reflect on the key learnings and insights gained from this summit, let us remain committed to driving positive change in mental health care and promoting holistic well-being for all individuals. Together, we can continue to break down barriers, foster collaboration, and create a more inclusive and compassionate society. Once again, thank you so much for your participation and unwavering commitment to mental health and advocacy. We look forward to continuing this journey together and building a bright future for mental health care in East Africa. Thank you, and may God bless you all. Thank you very much indeed.
You can get a better clap than that.
Thank you very much for that vote. Expected to give his final remarks on this conference, and we are trying to reach him out, and he's ready to log in, so he'll be able to provide a closing remark. Professor Peter Baguma. I'm going to hand over this to the Master of Ceremonies as I connect him to be ready for that.
Thank you. We're just holding briefly as Professor Baguma joins in. He was asking for the link, so we'll allow him to have the link. We will have him make his final comments, and then from there we should be able to wind down for that purpose. Those of us who are here, I will invite you for a cup of tea, a networking cup of tea, as you conclude the day. So that's why the tea is provided, so that you can exchange. You can have a chance to speak a little bit, to talk to one another, to network, to strengthen our bond. Those of us who are online, again, we acknowledge and appreciate your presence and your support for making this summit a success. So I don't know whether there's anyone who is, as we wait for Professor Baguma, who is with us, who may want to make a comment on air, meaning you want to be heard. You can be physically here, you can be online, and you just want to make a short comment. We will be happy to listen to that as we wait for him to get the link and be able to join. Anyone who is here would want to make that kind of comment? I know we have already had the photo vans. I'm sure you're looking forward for your networking cup of tea, but you could have a comment. I want to see, I'm trying to see whether there's anybody who's had this app online, so that I give you a chance. Yes, so the network will continue, the conversation will continue. The conversation will continue. So let us build on the beginning that we have had today.
Okay, okay. Master of Ceremonies, I want to make an observation. I hope I'm being heard. That this is a conference, a summit with a difference, with a roadmap. So to me, we have started a journey, and the participants who are here and the presenters, we have started a journey. It's my prayer that we shall move together as we do the implementation of the great vision the chair of this summit has, to be able to realize the results. We are in agreement that there's a problem in the house. That is within our families, within our institutions, within our churches, and the problem is global. And I'm happy to note that the vision bearer of this particular idea had a broad mind of bringing us together globally. And therefore, my call to each one of us is that let us not leave anybody behind. If it is the question, the call to research work, let's move together and conduct research. If it is the call for training, let's be there and be involved. If it is other support with any kind of resources, one would be able to come up with from the institutional perspective, individual perspective, family perspective, church perspective. That is the way we shall realize results. The Bible says in Psalm 133, where there is unity, God commands a blessing, and life forevermore. That is, where there is unity, God commands a blessing, and life forevermore. United, we shall be able to address this issue, and we shall have some reference of our legacy when we had the strength and the energy to do that. Thank you so much. God bless you.
Thank you very much, Reverend Dr. Tarsila. I'm waiting to confirm that Professor has been able to join or has not been able to join. He's trying to join. Okay, good. So we still have a chance to join. Professor Baguma, have you been able to join? Professor? Yeah, I invited those of us here for a cup of tea so that they can refresh as we get ready to head. So I'm sure, is there a cup of tea there, Bwana Kiwishi? Can you confirm? It's there. Yeah, it's there. Good. So that people can reflect as we wait. Just a minute. I'm sure that it's just an issue of getting the network. The conversation continues. Obviously, I've invited you to take a cup of tea as you hold on just a minute. Those who are here physically, those who are online, we just request your patience just for a minute, and then we conclude together.
And you can watch the news about this conference tonight. KCB. And what else? There is the news will be there tonight on this conference. People can watch. KCB at what time? 9.
Professor, have you been able to join? Professor Baguma? Not yet. You can give us that reflection of our partners on the screen so that people can be reminded. Acknowledge, of course, the support we have received from our partners who have been part of us in the presentation and even in attendance. We surely are glad that you joined. I'm sure the conversation has just started. The conversation has just started. Members from the University of Karatina, Karatina University, Embu, Kambale, Kampala University, Meru University of Science and Technology, Harvard, represented by McLean Hospital in Boston. We are so happy that you are able to join and come and be part of this conversation. We are really, really delighted. Very, very much so. And I'm happy to have been your moderator. My name is John Mushiri. I'm glad to have been part of the moderation. A member of the university. And as I indicated in the platform, if you do want to get a certificate, please do not hesitate to subscribe to through the provided link so that you can be able to get your certificate. We will be happy to have your details, your affiliation in terms of the university, and so that you can have a record of having participated in this very fruitful event. I don't take sugar at all. Thank you, James Mode, for acknowledging. Thank you, Dr. Caroline. Thank you. Thank you, Lala. Thank you, Josephine. Thank you, Musonga, from University of Kigali, Rwanda. Thank you very much. We hadn't noticed that. Mr. Mukasonga, Virgin, from University of Kigali, Rwanda. Thank you very much for joining this summit. Thank you.
Talk to me in a very calm manner, and we had a discussion.
Recording stopped.